Hello. Hello. Check 1 2 3 4 5 6. Hello. Mic check. 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 Hello. 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 हेलो. हेलो चेक. है. अब देखो. आएगा ऑडियो आएगा. देखो तो सही. आ गया. ठीक है ना. ज़्यादा आ रही होगी ना. हाँ आएगी वो अभी ठीक हो जाएगा. नॉइज आ रही है. हाँ. चलो. चलो ठीक है हाँ? ओके.
नहीं थे ना, अवेलेबल ही नहीं थे। और दूसरा क्या है कि वहाँ से भी हमको रजिस्ट्रेशन थोड़े से मोबिलाइज करने थे, तो भाई अगर अपने यहाँ का होगा तो अपने यहाँ भी प्रचार होगा। हाँ, सुनना, मैं लगाता हूँ तेरे को थोड़े से सब बॉल में सेशन वगैरह तो वो लगा ले। सर आपने ब्रेकफास्ट ली?
हाँ ले लिया। नज़दीक से ले लो।
बस सर, मनोज बी रेडी विद योर प्रेजेंटेशन। मनोज, अनामिका एंड रुचि इन दैट ऑर्डर।
चल भाई हम मोटी नहीं जा रहे हैं। सुबह आओगे ना लंच पे? चाय पीना हाथ में और अच्छा लगा है। चलो एक फोटो ले लो।
हेलो
स्टार्ट करें सर।
रमेश
हाँ ये रहा
डॉक्टर निर्मला दुआ ना निर्मला दुहान
जो आ जाएगा वो ठीक है। तो प्रेम से
बैठे हुए सर आज बनाओ डॉक्टर अनुपमा डॉक्टर रमेश
भी कितने बच्चे बाकी चीज़ें पीछे
Hello. So I welcome you all to the first masterclass in advanced laparoscopic surgery, which is organized by Holy Heart Hospital and ASI Haryana chapter. Very good morning to everyone. So we will begin our first session, in which we will have a poster presentation being done by the great work that the medical colleges have been doing. We'll have some paper presentations, some poster presentations, as well as expert video presentation in this session, and it will be followed by the operative workshop. So for the session, I would like to invite on the chair Dr. Suviraj John sir, who is Senior Consultant Minimal Access Surgery at Sir Gangaram Hospital. Welcome sir. I would like to invite Dr. Rajesh Godara sir on the chair for moderation, who is also the organizing in the organizing team and a backbone of this event. Phone dena bro. I would also like to invite Dr. Romel Singh Mohi sir on the stage to moderate the sessions. Dr. Subhash Chawla sir. Welcome sir. And Dr. Anupama Sethi ma'am, could you please join us for moderating the morning sessions? So I would like to invite our first speaker for the day, Dr. Manoj Kumar, who is Junior Resident in Surgery, PGIMS Rohtak. He'll be giving his paper presentation on management of penile strangulation caused by metallic devices.
Good morning. I am Dr. Manoj from PGMS Rohtak. I am presenting a case report on management of penile strangulation caused by constricting metallic devices. Introduction. Constricting devices placed on penis present as challenge. Various non-metallic and metallic objects are placed on penis to increase sexual performance or because of autoerotic intentions. The treatment of penile strangulation is decompression of the constricted penis to facilitate free blood flow and micturition. It requires no particular skill but does require resourcefulness to perform the removal simply and effectively. Case report. 45-year-old male resident of Nepal working as laborer in private company in Rohtak. He is married for 12 years with 2 children. He was staying away from his family since last 2 years. He was advised by his co-workers to place a metallic ring over the penis for 1 month to increase the duration of erection and prolong sexual activity. He used metallic ring of water pipe and unscrewed over his penis. Patient presented to our emergency department with chief complaint of pain and swelling over distal part of penis since 2 days. On physical examination, the penis was swollen and edematous. Both testes were normal in size, shape and volume. The PWD department of our hospital was consulted and the metallic ring was cut with a steel saw by placing a PVC plug between the ring and the penis to prevent injury while cutting. The metallic ring was removed with steel saw successfully. Intravenous ceftriaxone sulbactam 1.5 gram was administered prior to the procedure and tetanus prophylaxis was done. Patient was admitted for 2 days, edema resolved and the penis returned to normal condition in 10 days. Patient's psychiatric evaluation was also done. It revealed a normal mental status. Here is the picture showing the constricting devices. Penile strangulation is a rare clinical condition that was first reported in 1755. They occur as a result of constriction force of the object applied over penile shaft. In adults, the common reasons are sexual stimulation, prolonging erection, pranks, treatment of incontinence and phimosis. In the literature, various causes of penile strangulation are mentioned like metallic rings, tubes, rings, plastic bottles, rubber bands, rubber strings, hair or threads. These objects when applied over the flaccid penis causes obstruction of venous and lymphatic outflow resulting in the penile engorgement. Due to edema and increase in the girth of penile shaft, the applied object which was placed easily before it is now difficult to remove. As the pressure increases because of lymphatic obstruction and venous congestion, the continuous constriction force results in compartment syndrome-like condition. This eventually leads to obstruction of the arterial inflow to the distal part of the penis, resulting in strangulation. If the offending object is not removed timely, then the strangulation would lead to soft tissue ischemia, necrosis, local infection and gangrene. In 1991, Butt et al. Graded these kinds of injuries according to the increasing severity. In grade 1, edema of distal penis, no evidence of skin ulceration or urethral injury. In grade 2, injury to skin and constriction of corpus spongiosum but no evidence of urethral injury. Grade 3, injury to skin and urethra but no urethral fistula. Grade 4, complete division of corpus spongiosum leading to urethral fistula and constriction of corpus cavernosum with loss of distal penile sensation. In grade 5, gangrene, necrosis or complete amputation of distal penis. Most of the patients delay in seeking medical attention due to fear of social embarrassment or at times neglect the problem and seek medical help for after failed self attempts. The common complaints at presentation are penile swelling, pain at local site or difficulty in passing urine. The delay in presentation results in penile swelling out of proportion to the inner diameter of the object stuck, thus making the task of removing the foreign body even more difficult. The prolonged placement and delayed removal of these objects are likely to cause high-grade injuries. Apart from the material of the object, other factors to be considered before taking the patient for surgery are size, length and thickness of the object, the grade of surrounding tissue edema, the grade of injury and availability of the equipment. There are various techniques described in literature like aspiration, string method, cutting devices, degloving surgeries. The cutting technique is by far the most common intervention. The various tools used for the same are either non-electric or electric, namely orthopedic instrument, ring cutters, metallic saws, hammer, chisel, drills, etc. The non-electric cutting devices are easy to use but require strength and are best reserved for non-metallic items, small metal rings or wires.
You have 1 more minute.
Electric cutting devices are high energy driven tools. They are of greater help in removing large and thick metallic objects, but their handling is difficult and require utmost care and safety precautions to avoid iatrogenic injuries. Use of protective gear for the team member is also advisable. Placement of metallic object underneath the foreign body before using the electric drill helps in minimizing the risk of iatrogenic injuries. Conclusion: penile strangulation is a rare but true urological emergency which needs urgent medical attention and timely removal of the offending object, which can help in avoiding irreversible neurovascular damage to the penis and urethra. Grade of injuries and complications are directly proportional to the type of object and duration of strangulation. The non-metallic objects are easy to cut and remove. However, one should be aware of the
Time
challenges.
is up. We'll have 2 minutes for the question answers.
Doctor, very well presented, but you have to be little slow in speaking initially. And second is you have said they had put something plastic before cutting it underneath. If this was the space, so we could have reduced the edema by some glycerol dressings or some like in paraphimosis we do small needle punches.
Yes.
Was that possible or not possible?
Sir, that was not possible at that time because patient presented late and the edema was too much at that time. If we had left that patient, then it could have caused more edema and strangulation.
Good, thank you.
No, sir, we didn't try.
How long was the duration?
Sir, 2 days.
2 days.
Yes.
So how patient was managing micturition?
Sir, there was dribbling of urine. He was not completely micturating.
So this case was done under GA or spinal?
Sir, spinal anesthesia.
Is there any significance whether to go for GA or spinal? Spinal is supposed to cause more congestion, and already it is a congested thing.
Did you evaluate his this problem which led him to take the decision, this horrible decision? I mean, did you want to evaluate his sexual potency or some hormonal studies, any other thing?
Hormonal studies were
Or
not done, sir.
any examination, physical examination, which by which you were convinced that he doesn't have any such problem?
Sir, on physical examination, no other findings were noted, and hormonal status was not done. But psychiatric opinion was taken, and he was found to be normal.
The time for this talk is up.
Thank you, sir.
I would like to invite the next speaker, Dr. Anamika Singh, JR Surgery, PGI-MS. The topic is to compare clinical outcome of 3 versus 4 port lap cholecystectomy.
Good morning, everyone. This was a prospective study done to compare the clinical outcomes of 3-port laparoscopic cholecystectomy versus 4-port laparoscopic cholecystectomy. Okay, to start, symptomatic gallstone is a common biliary pathology, and the gold standard management is the 4-port laparoscopic cholecystectomy. The studies have shown that 4 ports required to retract the gallbladder, the 4th port can be omitted, and laparoscopic cholecystectomy can be safely performed by a 3-port technique. We performed a randomized control trial at our institute. For this study, there were total 46 patients, 16 consented for the 16 patients gave their consent for the 3-port technique. The results showed that the 3-port group had lesser hospital stay, lesser requirement of analgesics, the lower pain score on numerical rating scale, and faster resumption to work. Thus, the conclusion was that the laparoscopic cholecystectomy with 3 ports can be safely performed. Gallstones are the most common biliary pathology in India. The gallstone disease is relatively common with an overall prevalence in the order of 10 to 20% and is predominantly a female disease. Among males, the geriatric age group is more susceptible. Abdominal pain is the most common symptom. Most patients with gallstone symptoms describe a constant, often severe pain in right upper abdomen, epigastrium or both, often persisting for 30 to 120 minutes. Symptoms are frequently reported in the epigastrium. This is usually called midline pain. However, pain occurs in back and right shoulder in up to 60% of patients where there is involvement of somatic fibers. In a year, approximately 1 to 3% of patients with gallstones experience gallstone-related complication. These complications can be acute cholecystitis, choledocholithiasis, gallstone ileus, acute pancreatitis, acute cholangitis, obstructive jaundice, empyema of the gallbladder, or perforation, which can occur with or without symptoms. Patients without previous symptoms from gallstones have a slightly lower 10-year cumulative risk of complications, 3 to 4% versus approximately 6% in patients who have had gallstone-related symptoms. Transabdominal ultrasonography reliably documents the presence of cholelithiasis. Even in the absence of frank stones, so-called sludge found in the gallbladder on ultrasonography with appropriate symptoms is consistent with biliary colic. Karl Langenbach performed the first successful cholecystectomy at the Lazarus Hospital in Berlin on July 15, 1882. Eric Muhe performed the first laparoscopic cholecystectomy on September 12, 1985 in Boblingen, Germany. Muhe described his own surgical laparoscope, which he called the Galloscope, in 1984. The Society of American Gastrointestinal and Endoscopic Surgeons formally recognized Muhe as the first surgeon to perform a laparoscopic cholecystectomy in 1999. For cholelithiasis, standard treatment of choice is laparoscopic cholecystectomy with reduced post-operative morbidity, complication rate, quicker post-op recovery. While performing the standard cholecystectomy, the 4th port used to grasp the fundus of the gallbladder. Various studies have shown that the procedure can be carried out safely without the need of the 4th port, meanwhile reducing the post-op pain, analgesia requirement, hospital stay, and needing an assistant, one less assistant at the time of surgery. So we conducted a randomized control study to compare the clinical outcome of 3-port versus 4-port laparoscopic cholecystectomy. The aim was to compare the clinical outcomes of 3-port versus 4-port laparoscopic cholecystectomy. Objectives: to study the operative duration time, the duration of the hospital stay, the complication rates, the requirement of analgesics, and post-op pain in 3-port versus 4-port laparoscopic cholecystectomy. The present prospective randomized study was conducted at the Department of Surgery, PGI-MS, Rohtak. Total of 46 patients consented for the study. The study was conducted between February 2020 to February 2022. Patients were in the age group of 18 to 65 years with ultrasound province, symptomatic gallstone disease, adenomyomatosis of either sex attending surgical outdoor were recruited in this study. The cases were allocated to two randomized study groups. Group A consisted of 16 patients, the patients underwent 3-port laparoscopic cholecystectomy as per technique, and Group B consisted of 30 patients which underwent conventional. Sorry. Okay. Then 30 patients underwent the 4-port lap cholecystectomy. The inclusion criteria consisted of age group 18 to 65 years with symptomatic gallstone disease, and all the patients with choledocholithiasis with or without cholangitis, very obese patients with comorbidities or with ASA grade more than 2 were
We have
excluded.
1 more minute.
The results consist. Okay. The results were that the 3-port group had a relatively shorter hospital stay, post-op pain conversion rate, analgesic requirement, and better resumption to work after surgery. And the duration of surgery in both these cases, in both these groups clogged. It was discovered that 3-port group had a higher operative time. None of the patients of the 3-port group had any complications. One patient in the 4-port group had a bile duct injury and needed lesser number of drains than the 4-port group. Thank you.
Thank you. I thought it is a paper presentation. You should have presented PowerPoint slides that would have been given a better outlook. And then reading each line does not give a good message. Anyway, it's a good study. We too have carried out same studies, but we have found that 3-port is much easier to do if you are experienced surgeon, and takes less time. I am surprised in 4-port why there was a bile duct injury. Maybe difficult calots or something, I don't know, but generally in 4-port CBD injury is very rare. Sales, I agree, I do single incision laparoscopy also. In that, of course, one can think of, but again, we have never encountered that type of injury. Anyway, good presentation.
Thanks.
Thank you. I think that was a good attempt at exploring this topic. I think for reasons of brevity of time, we couldn't look at, did you use any classification of the severity of cholecystitis or the degree of challenge ergonomically for the cholecystectomy? Any primary outcomes for that?
We just included the patients with symptomatic gallstone disease. No criteria, and a pain chart was used, but no other criteria.
Okay.
Was used.
Okay, Doctor, it's a nice presentation. Just tell me how you standardize pain, like pre-operatively, intraoperatively, post-operatively. You are giving so many painkillers. Some are using local anesthesia as well. How you standardize these things, and what type of analgesia you use? How frequently?
Sorry, sir, I could not get
Like
the question.
how you make the 2-group constant in 3-group and 3-port and 4-port? Like have you used local anesthesia, pre-operative, some analgesic during post-op surgery? How frequently and what type of anesthesia you use?
So,
Local this painkiller analgesic.
So general anesthesia with analgesics were used, injectable analgesics.
Okay, and analgesic were same in both the groups.
Yes, sir.
And do you think if somebody is having severe pain, how you manage that? Means like patient you are using PCM or diclofenac if somebody is in severe pain in post-op here. So what type of rescue analgesia?
So we could use fentanyl, or we could go for higher analgesics.
And in one of the patient there is bile duct injury. In which group? This was in 4-port group.
4-port, sir.
How you think the 4-port is safer rather than 3-port? How it is possible?
It's very rare, must be some other reason. Either an inexperienced surgeon or
So actually pain is a very complex phenomenon. More or less it is a subjective one also.
Yes.
So it's difficult to assess in a small group of patients.
youngster.
Anyway,
young
this
trainees,
is a
but,
nice.
You would like to...
In one of the study, we have established that technically it is much easier with 4-port rather than 3-port. This is the truth we are... we have to accept that.
I think it's a lovely paper to discuss if we had more time. So I think thank you.
Good.
Thank you.
Thank you.
Thank you. I would like to invite the next speaker, Dr. Ruchi, JR Surgery at GMC Patiala. She'll be talking on a comparative study of direct trocar versus optical trocar.
Good morning
Thank
to
you.
all, and thank you for giving me such an opportunity. I am presenting my presentation on topic. There is a comparative study of a direct trocar insertion versus optical trocar insertion in creating a pneumoperitoneum for laparoscopic cholecystectomy. Laparoscopic cholecystectomy has been the gold standard surgery for the cholelithiasis, and although laparoscopy is usually safe, but there is a concern for rare and life-threatening complications, including severe bleeding due to damage to major blood vessels or visceral injuries with the subcutaneous emphysema or post-surgical infections. Potential for complication is seemingly infinite in obese patient as the BMI increases. There are different methods for creating a pneumoperitoneum: open or Hessen techniques, semi-open technique, and closed method. Hessen method is in this we give a stab incision of 1.5 to 2 centimeter in umbilicus, supraumbilically or infraumbilically, and then we insert a Hessen cannula directly into the abdomen after peritoneum is entered. And in closed method, majority of the laparoscopic surgeons use this technique. In this, we directly insert a varus needle to create pneumoperitoneum, and when the tip enters into the peritoneum, and there is a loss of resistance, and then the blunt tipped obturator advances automatically to cover that sharp needle of the varus needle. In semi-open technique, there is a facial layers are dissected until we reach to the peritoneum, and then we insert the varus needle in the same way as we insert the varus needle in the closed method. There is only difference is that peritoneum is entered directly under vision in the semi-open technique, and there are optical trocars which introduced in 1994 use a hollow trocar with a 0-degree laparoscope to completely visualize the abdominal wall layers during the placement. There is a prospective study included 100 patients which underwent who underwent laparoscopic cholecystectomy in our department of surgery in our medical college, Patiala, in which we made two groups, group A and B. Group A, 50 patients in which direct trocar insertion was followed, and in group B, trocar was inserted under vision. In inclusion, we included all the laparoscopic cholecystectomy patients who were giving the informed consent to participate in the study. And group A, after the safety trocar was introduced through the incision and advanced with the minimal force and maximum control directed straight to the midline without any angulation, using continuous rotatory movement till the peritoneal cavity is reached. And in group B, there is after giving a 10 mm long incision, depending on the surgeon's choice, it can be supra or infraumbilical, with using a 10 mm 0-degree laparoscope was inserted into the visiport, and the abdominal wall was lifted up by the surgeon and assistant on both the sides, and which act as a counteract the axial and penetrating force of the trocar. And the introduction of the optical trocar into the cavity is under the real-time image monitoring. This is the comparison according to the trocar insertion with increasing BMI. This shows that their average time taken for optical trocar insertion was statistically more in the direct trocar insertion at all the BMIs. And this is a table showing the injuries encountered in both the groups. In group A, under direct vision, there was only the minor port site bleeding, and in group B, under the optical trocar insertion, there was no such complications encountered. Discussion. Laparoscopic cholecystectomy, although a gold standard treatment for the gallstones, it can be noticed that time taken for the trocar insertion increased with increasing BMI in both the groups. It was significantly more in the optical trocar group. Bowel or visceral injuries or vascular injuries during the trocar insertion while creating a pneumoperitoneum is feared and deadly complication of minimal invasive surgery. In our study, there was no trocar related visceral or vascular injury reported in both the study groups, but this was due to the fact that surgery were performed by the experienced surgeons and necessary precautions were taken, like bladder evacuation and RT insertion to decompress the stomach. And also the trocar insertion was done by lifting the anterior abdominal wall and with gradual rotatory movements. These also help in avoiding the below placed visceral injuries.
You have one more minute.
The bowel injuries as reported are 0.3%, and port site bleeding is a rare complication of lap cholecystectomy in both the groups, but it was found in group A in our study. It is a minor bleeding that occurs usually during the trocar placement and can manifest, is usually manifest after the decompression of the pneumoperitoneum, and all the patients were post-operatively uneventful. Stay was uneventful and patient were discharged successfully. The conclusion was that Visiport is safer theoretically as well as per literature, but direct trocar entry is equally safe in experience sense. So Visiport can be recommended for younger surgeon in their learning curve for patients with high BMI. Thank you. So 100 patients.
Both arms or 50-50?
50 each.
Did you use a formula to calculate the sample size or just arbitrary?
Arbitrary.
Okay,
Yes.
okay. The reason I ask is because injuries generally are rare, so if you have to actually compare two techniques, you may need a larger size, but I think it's a good effort to go that. But when you make a recommendation, I think you have to be very careful about being categorical about it. So I think this could be a pilot study for a larger study. Thank you.
Thank you.
Good presentation. What you mentioned that younger surgeons should be given the chance to use optical trocar. I will recommend that open port entry may be better for the younger surgeon as a first step. Optical trocar can be at the second or third step. Thank you.
Thank you, sir. So direct trocar placement can result into the vascular injury placed under the umbilical. So the bleeding injury chances are equally in the, that is also the, so we can, but there are less chances because obturator is there which comparatively prevent the bladder injury, bowel injuries. Repeat, sir. Pardon, please.
No, it should not be recommended because there.
What is legal aspect of this, sir? Chawla, sir?
Legal aspect is very much there. You will naturally land up in one or the other complication one day, and then how will you cover yourself? Because unless there is a special reason that you cannot put varus needle or you cannot inflate the abdomen, that is different. There may be any condition.
But
But
sir,
people are doing is exceptional cases who are doing it. They may feel they are very experienced, but one wrong cannot be justified by another wrong statement. But it is
but
direct.
legally this is wrong.
Legally is wrong. There is no doubt about it.
Sir, I would
Sir, as
due
per
to the
literature,
shortage
as
of
per
time.
literature, no trocar entry procedure is above the other. Means whether it is optical, whether it is varus, whether it is direct trocar, the injuries are the amount of injuries is the same. So it's in the literature.
No,
So-
maybe
so-
one
so-
odd
no,
literature
sir.
may be there, but you
Yeah.
have to have multiple papers
No,
and in
sir.
that
I feel-
Clarify, this is a
multi-center study, not single
optical entry and direct entry post carboperitoneum or before carboperitoneum?
No, before he's saying before direct entry
you.
he's talking about. Direct entry.
Yeah.
Sir, I've been doing it for 16 years now.
That's good.
All
Yeah.
direct entries. I have not inflated with.
Open. You are saying open
no,
port.
no. Only direct entry.
I think there's
Sir,
one thing
due
that's very
to-
clear in literature is that when you compare procedures, the procedure that in your hand, which is in which you are confident, please use that one.
Exactly, sir, exactly.
That is the one, and you have to be careful of direct entry because, like you mentioned, with the forceful thrust, you don't know which patient has adhesions inside. The aorta lies 2 millimeters next to the peritoneum in a thin patient, and bad
Very right, sir.
bad examples don't come out.
So because of the shortage of time, we are also starting with the
I'm more
OT.
comfortable by putting direct rather than varus needle. What is the advantage of direct trocar placement?
So can we move forward?
We
sir?
can
will
have this
take
discussion a little later. I think
afterwards
they have a OT
because,
case.
so there are a lot of posters and
Yeah.
papers
Right, sir,
that are
thank you.
waiting.
Thank
and
you,
OT
thank
is
you.
also starting.
Thank
You,
you.
sir. I would like to invite on stage Dr. Prem Singla sir for moderation as well. Dr. Prem Singla sir, kindly join as a moderator on the stage. Next, I would like to call upon Dr. Shobhit Maheshwari, JR2, Maulana Medical College, Ambala. His topic is an unusual case of lipoma in the sigmoid colon.
Good morning everyone, and myself Dr. Shobhit Maheshwari, and my moderator is Dr. Colonel Subhash Chawla sir, and I'm presenting an unusual case of lipoma sigmoid colon. In which introduction, colonic lipomas are rare benign tumors and are usually asymptomatic. So large lesions cause symptoms like abdominal pain, constipation, diarrhea and obstruction, mostly due to intussusception. The epidemiological and macroscopic clinical presentations can sometimes suggest a malignant nature, although malignant transformation does not occur. We present a rare case of large broad-based intraluminal lipoma of the sigmoid colon in a middle-aged female patient who presented with the symptoms of enteritis. 47-year-old female presented to medicine OPD with a history of increased frequency of stools for last 3 months. Stools were watery in consistency, non-sticky, non-foul smelling, and a frequency of 8 to 9 times a day. And this was not associated with any fever, abdominal pain, abdominal distension, vomiting, loss of appetite or weight. Patient had past medical history of hypothyroidism also since 6 months, and was on oral thyroxine 50 microgram per day. No significant past history suggestive of subacute intestinal obstruction. Per abdomen soft, non-tender, not palpable lump, and on digital rectal examination did not reveal any mass or blood on finger. And laboratory investigations, the blood investigations were normal, and the LFTs viral markers were negative, and serum electrolytes and were also normal. Colonoscopy revealed intraluminal mass lesion of approx 4 into 2 centimeter that was spherical smooth surface with no ulceration in the proximal part of the sigmoid colon that was curie of some mucosal growth. Now, colonoscopic guided biopsy revealed only inflammatory tissue. This is the triphasic CT scan that is showing the redundant and tortuous sigmoid colon with a large, well-defined lesion of size 4.6 into 2.8 centimeter in the sigmoid colon with the absorption of the densities of 110 Housenfeld units. That is typically suggestive of fat, suggestive of lipoma, causing occlusion of the lumen. So patient was planned for diagnostic laparoscopy and proceed. And intraoperative, the findings showed a swelling in the proximal part of the sigmoid colon, and lipoma could be seen extruding out of the serosal layer like the tip of an iceberg. As CT findings were highly suggestive of lipoma, so lab-assisted excision of the lipoma was done by giving transverse skin incision approx 5 centimeter in the left iliac fossa, and sigmoid colon was pulled out, and longitudinal incision was given over the swelling, and lipoma present between the submucosa and the muscular layer was dissected out, and primary closure of the incision was done in 2 layers. Post-op period was uneventful, and patient was kept nil orally for 2 days and then started with oral fluids followed by a semi-solid diet on third post-op day, and patient tolerated orally well and passed stool on post-op day 4 and was discharged. These are the intraoperative pictures. That was lipoma present between the submucosa and muscular layer was dissected. So discussion is lipoma of the colon are the second most common benign tumor found rarely, and first case was reported by Bauer in 1757, and only 300 cases have been reported till now. So according to the recent studies by Rogge and state that lipoma of the colon constitute about 0.3% of the cases, includes colorectal problems, and 1.8% of the cases of benign colorectal disease, and more than 75% of the lesions are found in the right colon, and 10% are multiple, mostly in the region of the cecum. Now, some mucosal lipoma are found in 90% of the colonic lipomas, and rest are found in the serosal and in the intramucosal layers. So, incidence is more in female as compared to males, and in male patients are more seen in on the left side. Now, lipoma of the colon are asymptomatic, found incidentally during the radiological imaging or during the colonic surgery for other conditions. It is observed that the size more than 4 centimeters cause symptoms, and it depends on location too. Now, symptoms like pain abdomen, change in the bowel habits, bleeding per rectum, and the features of obstruction. Complications include perforation, intussusception, prolapse, and in some cases, massive hemorrhage can occur. Now, larger sizes can cause a surface ulceration and
You have
bleeding
one
also.
more minute.
So the conclusion, we can say, rarely diagnosed case of symptomatic colonic lipoma needs multidisciplinary approach, and once diagnosis is confirmed, advanced endoscopic technique or laparoscopic or open excision of lipoma can be done. Now, laparoscopic resection is the first choice in patients with doubtful preoperative diagnosis, like complicated cases like features of obstruction, and if endoscopic resection is not possible. So, laparoscopic assisted excision is a good alternative to open conventional surgery, as was done in the patient.
Okay, nice presentation. Doctor, you just tell me, you are saying this was in a submucosal lesion,
Yes.
right? How you explain the features of enteritis with the submucosal lesion?
Sir, features of enteritis due to occlusion of the lumen, due to that is localized and inflammation is there in the colon, so that causes the features of enteritis.
Enteritis usually occurs if there is a mucosal disease, inflammatory disease,
Yes, sir.
rather than submucosal disease.
Yes,
So
sir.
presentation must be something else. Yes, complication can present, but usually feature of enteritis are not there in case of submucosal disease.
Yes, sir.
So why colonoscopic excision was not tried?
Yes, sir.
Colonoscopic excision not tried when the preoperative diagnosis on CT was its lipoma?
Sir, they tried, but that was not possible. So that time.
Since it was involving the serosa also, so colonoscopic it was not possible. It would lead to perforation. That was the main reason. And secondly, enteritis, it was a coincidental. Patient had come with enteritis, treated, but on colonoscopy we had found this, and once we got the CT scan done, so we confirmed, diagnosis was confirmed. Pardon? Yes, we first confirmed the diagnosis. See, it was a very tricky case. One, it was VIP case, then second, diagnostic laparoscopy, yes. Then in diagnostic laparoscopy, we tried to localize the lipoma and then try to remove it. But once we saw what we are seeing on the serosa is the tip of the iceberg. The main lipoma is lying under the subserosal, even the submucosal layer, which was there in this case. So then we did it laparoscopic assisted. That was the only possible, because laparoscopically it would have led to perforation and further complications.
Means laparoscopy is only for diagnosis. That was diagnostic.
No, it was, we started the case laparoscopically. We tried to do it. It was
But
not for only diagnosis. But then we had to convert it to laparoscopic assisted approach.
Right, sir, right.
With a small incision. Thank you. Well presented. Good.
Thank you, sir.
Keep it up.
The next speaker for presentation is Dr. Kunal Chaudhary on the topic of our experience with laser pilonidal sinuses, a case series of 22 cases.
Good morning, everybody. Today I am here to share our experience with laser pilonidal surgery, a case series of 22 cases. Myself, Dr. Kunal Chaudhary, doing fellowship in minimal access surgery at Artemis Hospitals, Gurgaon, Haryana. So what is pilonidal sinus disease? Pilonidal sinus disease is an inflammatory condition in the gluteal cleft. It more commonly affects young men. Risk factors include obesity, excess body hair, and hereditary cause is also there. Traditionally, basic treatment of pilonidal sinus disease has been excision of all skin and subcutaneous tissue involved by either keeping the wound open or closing it primarily versus flap reconstruction. Now minimal invasive surgery has also come up in pilonidal sinus disease, which ensures a shorter hospital stay and quicker return to normal daily activity. Various studies have described the efficacy of laser therapy for pilonidal sinus with variable success rates. So our aim of this study is to share our short-term results of using laser therapy for pilonidal sinus. Material and methods. This study was conducted between April 2021 to April 2022. A total of 22 patients were included in the study. All cases were done under spinal anesthesia after obtaining necessary consents. All surgeries were performed by a single surgeon on the same diode laser machine using the same settings using radial fiber. Inclusion criteria for the study was all cases of pilonidal sinus willing to undergo laser treatment and accepting to come for follow-ups were included, and the exclusion criteria being patient not willing for follow-up visits, secondly patient on presentation having an abscess, and thirdly patients with multiple secondary openings were excluded. Now coming to the surgical procedure, after induction of the spinal anesthesia, patient was positioned in a prone position, antibiotic prophylaxis was given, hair removal done from the operated site. Primary and secondary pits were identified and counted. Pits were excised and tract examined with metal probe, and all hairy material and unhealthy granulation tissue removed and tract curated and flushed with betadine and hydrogen peroxide. Tract examined by using fistuloscope for any remnant hair follicle if present, hair particle if present. Now the tract was treated with laser, radial laser fiber after inserting into the in the tract. Machine was kept at 10 watt setting and 5-second pulse. Laser probe was withdrawn at a rate of 1 mm per second. Tract ablated and margins of the secondary pit excised and sent for biopsy. Hemostasis achieved and small dressing kept over the wound. Follow-up visits. All patients were discharged on the next day of surgery. On discharge, patients were advised to take sitz bath for 2 times a day and keep a gauze over the wound just in case there is any soakage, so it should not contaminate their clothes. And a course of antibiotic and painkillers were advised for 7 days. Weekly follow-ups were done till the wound heals. Results. 22 cases were operated in a period of 1 year. Age of the patients ranged from 16 years to 28 years. Male to female ratio was 21:1, and average time taken for the procedure was 60 minutes, which included induction of spinal and positioning, part preparation and everything. Average energy delivered in the tract was between 500 to 700 kilojoules. Average hospital stay was 1 day. For initial 4 to 7 days, almost all patients complained of watery discharge from the wound that was bothersome, and it subsided by itself by the end of the first week. In all 22 cases, wounds with average time of healing was between 4 to 6 weeks from the date of the surgery. And in our series, all 22 cases had has healed completely. Pain was significantly less after laser surgery with lesser requirements for painkiller. Patient was allowed to resume his daily routine work after the first 7 days. In 2 cases, antibiotic was continued after the first follow-up, as wound had some turbid discharge which decreased with a course of antibiotic and local sitz bath and cleaning. No requirements for large dressings or drain was there. Coming to the discussion, in our experience, 100% healing rate was seen, though in the review of literature, healing rate is around 90%. Also, no recurrences have been noticed in this 1 year, though literature says that there is 2 to 3% recurrence rate over a period of 2-year follow-up.
You have 1 more minute.
That this difference may be attributed to the small sample size and short-term follow-up. So coming to the conclusion, initial results with laser pilonidal surgery are encouraging, and the study may be done on a larger sample size over a longer duration to see for the final results and conclude. Thank you.
Good presentation, Dr. Chaudhary.
Thank you.
You spoke very fluently.
Thank you.
Good. And this should be the presentation. All the residents, please note how to present your paper in the conference. Stick to time, present fluently. Now, my only one question is that you said you energy delivered is 500 to 700 joules.
Yes, sir. In whole of the tract.
Yesterday we were discussing in hemorrhoids, the maximum energy to be delivered is 500 joules. So, is there any limit in a sinus where?
Sir, actually, in some cases the track was long.
Okay.
It was around 10 centimeter also in few cases. So, by keeping a setting of 10 watts and 5-second pulse, for every 1 centimeter, almost 50 kilojoules of energy was used. So, to ablate the whole track, in some cases we have to fire more energy. But the ideal recommendation is less than 500 only, sir.
Dr. Chaudhary, one question.
Please. Per cubic centimeter. Okay.
One question.
That means he is correct.
Any objective qualification of the type of pilonidal sinus and the sinus burden, or evaluation was done by scopy at the time of surgery?
Yes, sir. I also would like to
MRI done before?
Yes, sir. MRI was done in few of the cases.
Few cases.
This study was done in a small setup, so MRI was not possible to be done in all the cases. But in few cases it was done where the discharge was chronic and patient was giving history of discharge for a longer period of time.
That's a very important point, because I've operated on some early recurrences. Yes. So I think when you're dealing with maybe a minimally invasive procedure, it's good to have upfront an imaging for even what appears to be a small case. That's my little experience. Thank you.
Sir, this study is still new. Laser pilonidal surgery is still new, and in 2016 they have conducted Diesel and et al. Conducted a study on 86 patients with a mean follow-up time of 2 years.
Yours is 1 year.
1 year, sir.
And no recurrence, nothing.
Till now there is no recurrence, but few of these cases have only been in follow-up for the past 3 months.
Any skin necrosis?
Initially, sir, skin margin was showing necrosis, which generally heals by 14 days.
Thank you. Very well presented. Well done.
Our next presenter is Dr. Swan Singh Yadav.
Hello. Just one question to you. What is the treatment of choice or the procedure of choice you offer to the patient who are in your exclusion criteria? Suppose I don't have a leg surgery. What is the best procedure choice I can afford?
Swaran Singh, please
Swaran Singh,
join.
please come.
You can discuss.
You could discuss one-on-one there. Thank you.
Next presenter is Dr. Swan Singh Yadav. We want to present a paper on evaluation of clinical and radiological correlation in blunt trauma abdomen.
Good morning, everyone. I'm going to present my paper on the evaluation of the clinical and the radiological correlation in the blunt trauma abdomen. So introduction, blunt trauma abdomen leads to the significant morbidity and the mortality in the patients, and almost all patients of the BTA now require CT scan for the further decision. A modern management of the BTA requires good pre-hospital care, imaging, and the close monitoring. Material and methods we used were, it was a prospective observational study done at the Department of the General Surgery, PGMS Rohtak. Sample size was 62. Inclusion criteria was all the patients proved of the blunt trauma abdomen, and exclusion criteria was pregnant females or the penetrating injury or the patient not giving consent for the study. History and the clinical details of the patients were recorded and imaging findings were noted, and those having the settled solid viscera were explored, and rest all were managed by the conservative approach. At the end of the study, entire data was collected, tabulated, analyzed, and inferences were drawn. The male outnumbered the female. The males were like 95.16% and females were 4.84%. Observation mode of injury were roadside accident was the major and the commonest mode, followed by fall from height and then by physical assault. The commonest age group was from between the 21 to 40 years, and mean age was 30.4 plus minus 11.56 years. So in the present study, approximately 8% of the patients presented with the shock and the symptoms like pain, distension that are depicted in the histogram. And the close to the 50% of the patient had tachypnea and the tachycardia. Observations by imaging study using the USG, free fluid was present in the 96.77% of the patients, and organ injury was detected in the 32.25% of the patients. Common organ injured were liver followed by spleen. CT was done in all the who were hemodynamically stable patients. Sensitivity of detecting the organ injury was 87.6%, 100%, 85.7%, and 100% for the liver, spleen, pancreas, and the small bowel respectively. And the respective specificity was 100%. And in our study, usually in blunt trauma abdomen cases, the commonest organ involved is spleen, but in our study, it came out to be a liver. So the observation and the results, the signs and the symptoms of the BTA are often masked by the concomitant head injury, chest injury, and the alcohol consumption. And the histogram depicting the complications of the patients of the BTA in the percentage: wound complications, bed sores, cardiopulmonary complications. BTA is on conclusion of the study was the BTA is on rise due to the excessive use of the motor vehicles. Early diagnosis and based on the good and the reliable imaging along with the close monitoring is the key to the success. And USG was used as a screening tool, and CT is sensitive and the specific for detecting the organ injured, extent of the injury, and also in deciding the course of the management. However, unstable patients should not wait for imaging and should be directly wheeled to the OT. Majority of the patient can be managed conservatively. However, even today, nothing surpasses the value of the clinical assessment in the management. Thank you, sir.
Okay, good presentation, but in any of your patient 4-quadrant tap was done before wheeling to OT, especially where CT was not possible or where the patient was unstable?
Sir, most of the patients that were wheeled to the OT were in the shock, like they were pale. No tapping was done.
In stable patient, do you recommend diagnostic laparoscopy as a procedure for especially spleen saving, for spleen preservation?
Most of the patients stable are managed conservatively.
Okay.
So I don't think laparoscopic approach is
okay, sir, out of your syllabus, don't worry.
Thank you, sir.
I would like to thank you. I would like to invite the next speaker, who is again Dr. Kunal Chaudhary, fellow at Artemis Hospital, Delhi, to speak on laparoscopic management of traumatic diaphragmatic hernia. We will begin with the e-poster session after this paper presentation. So please be prepared for your e-posters. Dr. Kunal. Please start.
Good morning, everybody. My second topic will be a video presentation on laparoscopic management of right-sided traumatic diaphragmatic hernia. Again, myself, Dr. Kunal Chaudhary, doing fellowship in minimal access surgery at Artemis Hospitals, Gurgaon, Haryana. Now, what is traumatic diaphragmatic rupture has been well described after blunt and penetrating thoraco-abdominal injuries. Left-sided rupture is more common than right, but there is an increasing frequency of right-sided ruptures being diagnosed due to the advanced imaging modalities that are available nowadays. The clinical presentation can be divided into acute and chronic. A high frequency of associated injuries with diaphragmatic hernia often distracts from the diaphragmatic injury, which leads to a delay in the diagnosis and delayed presentation of patient to the emergency department with features of obstruction, pain, nausea or pulmonary dysfunction. Chest radiography is the primary imaging modality with a sensitivity of 27 to 56% for left side, but only 17% for right-sided injuries. The most specific radiological sign is an air-containing viscus in the thorax with focal constriction of the viscus at the site of herniation. Other findings suggestive include elevation of the hemidiaphragm, compression atelectasis of lower lobes, and irregularity of the diaphragmatic outline. Helical CT is a valuable tool with a sensitivity and specificity of 70% and 100% respectively. Both thoracoscopic and laparoscopic approaches have been found to have an excellent diagnostic and promising therapeutic benefits, but laparoscopy gives us the advantage of an integrated exploration of whole diaphragm and peritoneal cavity along with the reduction of the hernia. Now coming to the case history, my patient 62-year female presented to the hospital with repeated episodes of vomiting, pain upper abdomen for 1 month. She gave a history of RTA around 1 year back. Her pulse was 104 per minute. She was dehydrated. BP was 100 by 60 millimeters of mercury. Her per abdomen examination was grossly normal. Blood routine investigations showed a low sodium and chloride values. Rest blood investigations were normal. So due to the severe pain and repeated episodes of nausea and vomiting, she was initially put up on conservative management as a case of acute abdomen, and on investigation her CT showed air loculi above the level of the diaphragm with something outpouching above the right hemidiaphragm, which raised the suspicion of a diaphragmatic hernia, for which a CT scan was done showing a 5 centimeter defect anterior to the liver in the right hemidiaphragm containing bowel loops. After resuscitation and proper preoperative evaluation and fitness for surgery, patient was taken up for a diagnostic laparoscopy, which showed a 5 centimeter diaphragmatic hernia anterior and to the right of right falciform ligament of the liver, containing transverse colon, greater omentum and part of the stomach as content. Stomach was dilated in spite of rise tube being in situ for 2 days, which proved that it might be causing some obstruction or angulation in the stomach, causing repeated episodes of vomiting. After reduction of the contents and reduction of the hernial sac from the right thoracic cavity, closure of the defect was done using a non-absorbable suture, and a composite mesh was used to repair the defect, as the size of the defect was more than 5 centimeters. I'll be presenting a short video of this case just to give a...
You have 1 more minute left.
So here I am going inside, and on first diagnostic, this is the hernial defect with contents. Now we are reducing the contents. Transverse colon is coming out with part of greater omentum, and behind that we can see part of the stomach also pouching inside the diaphragmatic hernia, which is reduced. So this is the falciform ligament which is released and space is created. Now this is the dissection of the hernial sac from the thoracic cavity, starting and in a circular fashion a cut is given and hernial sac is dissected out of the thoracic cavity. This is part of the hernial sac being dissected from the thoracic cavity. Again, final few attachments of the sac is getting detached by using a harmonic energy device.
Please finish fast.
2 minutes.
Fast forward kar do.
So this is the complete sac being dissected. Now we are closing the defect using a proline suture, and towards the above we could not close it, so a suture passer needle was used to close the defect. This is the final picture of closure after closure of the diaphragmatic defect, and a mesh of appropriate size was kept and fixed with sutures with tackers used superiorly and towards the right, taking care that pericardium is not taken accidentally.
You have 2 minutes for the question answers.
Good presentation, Dr. Kunal.
Thank you, sir.
Paper is open for discussion. Any questions from the audience or the floor? It's a very good case, managed very well.
Thank you, sir.
I had encountered such a case in a 13-year-old boy.
Yes, sir.
Who had traumatic injury which even mother did not remember 5 years back or so. Again landed up with the diaphragmatic hernia on the left side.
Yes, sir.
We also managed in the same way and successfully. So
Yes,
crux says that we should try to manage such cases laparoscopically. It's not difficult. If you have experience, you should try and manage it laparoscopically. Mesh can be easily placed, tackers are available nowadays, so there is no problem.
We use single port lung inflation.
Sir?
Lung inflation.
Lung, no, sir. We have gone through the abdominal approach, sir.
Abdominal approach, all right. But I couldn't
Actually,
see,
it was.
I couldn't see movement of the lung on the.
Sir, actually, this defect was not entering the pleura. Pleura was pushed up. So there was no pleural breach. So
generally at times lung is collapsed.
Yes,
which
sir.
Once you repair it, it's again
Yes.
opens up.
but the pleura was intact, sir.
We could see it. Thank you.
Thank you, sir.
After paper presentation, now we'll start e-poster presentations. I would like to invite Dr. Dakshita for poster presentation on intestinal diaphragm causing recurrent intestinal obstruction.
You will have 3 minutes for the poster presentation and 2 minutes for the question answers. Please finish on time.
Good morning, everyone. My name is Dr. Dakshita Adlakha. I'm a resident of MMU Ambala, and my guide is Dr. Subhash Chavla sir. My topic is diaphragm disease. Diaphragm disease was first described by Lang et al. In 1988. It is a rare cause of recurrent small bowel obstruction. It involves formation of multiple thin concentric strictures in the intestine. Intestinal mucosa between the diaphragm was noted to be almost always normal, but there are other findings as well, like villus atrophy or ulcerations of the mucosa at the tip of diaphragm. It has been shown. It has been shown that non-steroidal anti-inflammatory drugs can cause injuries in the small bowel, even in patients with minimal or non-existent lesions in the stomach. The aim is to sensitize the medical officers regarding the rational use of NSAIDs. My case is a 38-year-old male presented to hospital with chief complaints of pain abdomen and inability to pass stool and flatus for 15 days. The patient developed pain in abdomen, which was gradual in onset, diffuse and progressive in nature, and was associated with distension and nausea. Patient also gives history of arthritis, for which he was taking NSAIDs from the past 2.5 years. On examination, vitals were within normal limits. Per abdomen showed distension with diffuse tenderness, and bowel sounds were increased. On X-ray, abdomen erect showed dilated jejunal loops with multiple air fluid levels. Based on the investigations done, a provisional diagnosis was made of recurrent subacute intestinal obstruction. Patient was kept on conservative management and was relieved symptomatically. The patient started with oral fluids and semi-solid diets and developed features of subacute intestinal obstruction again. Therefore, we planned a diagnostic laparoscopy and proceed. Operative findings showed stricture of distal jejunum with proximal dilated gut loops with collapsed distal ileal loops. The patient was planned for resection and anastomosis. Obstructed segment was pulled out and inspected for viability and luminal patency. The strictures part was resected and we found unusual thin intraluminal diaphragm, intraluminal diaphragm with a 3 mm of pinpoint lumen and another diaphragm 2 cm distal to it with 2 mm pinpoint opening. Resection of both the strictures part was done and end-to-end jejunostomy was done. Discussion. Diaphragm disease is seen when the lumen of the small bowel is divided into short compartments by circular muscles of mucosa and submucosa. These membranes have pinhole
The time
lumen.
is up. Please finish fast.
Pinhole lumen leading to frequent episodes of subacute intestinal obstruction. It is seen that it is associated with NSAIDs, NSAIDs use.
Please conclude.
My conclusion is a high index of suspicion is required to diagnose this condition preoperatively, and we can use multiple methods to diagnose it, like enterochlesis, intraoperative enteroscopy, and double balloon enteroscopy, etc. Resection of the segments involved with the anastomosis is a definitive treatment. However, stricturoplasty for this condition can also be done.
Please stop. Question and answers.
Okay, nice presentation. You tell me how you think this is only because of the NSAID use?
Sir,
Only
you're not
diaphragm was
audible,
there.
sir.
There was diaphragm in jejunum, two diaphragms were in jejunum. How you think it is associated with the NSAID use? What's the pathophysiology to explain it?
Sir, pathogenesis of this is it decreases the prostaglandin secretion in the intestine as well. NSAIDs decreases prostaglandin secretion, which causes mucosal disruption and hypertrophy.
There has been studies in the literature about this jejunal diaphragm disease. When I operated, I also thought I did not knew about this condition. Then once I went through the literature and then we prepared this paper, and actually there was a jejunal diaphragm in this. Thank you very much.
Thank you.
Thank you.
The next speaker is Dr. Murugan, and poster presentation on laparoscopic management of mucocele of appendix.
Before Dr. Murugan start, I have two important announcements for you. The first is we are going to stop the breakfast at 10:15 a.m. So after that there will be no breakfast in the restaurant. Tea and coffee will be available at the first floor in the exhibition area, just above the reception. And the third is we will start the lunch today at 12:30 because many of our guests has to depart. So we will start the lunch at 12:30. Okay. And maybe in the next few minutes we are going to start the live operative workshop. So Dr. Morgul, it's you. Now you can start, please. Thank you very much.
Is this the last paper?
No, sir. We have a few posters remaining, but then we'll incorporate them in between the operative.
Excuse me, I would like to call Dr. Prem Singla to join us,
Dr.
please.
Prem Singla, sir.
Yeah,
please join us as a moderator.
His
on
name
the
has
stage.
already been spoken of. So
Yeah.
Thank you very much.
Yeah, Dr. Murugan, please start with your presentation. You have 3 minutes and 1 or 2 minutes. Sir, we'll allow 2 questions since we are going to start with the operative workshop as well. Please start.
Good morning, everyone. My name is Dr. Murugan, and I am the junior resident at MMU Mulana. My guide is Dr. Colonel Subhash Chawla. I have a topic of laparoscopic management of mucocele of appendix. Mucocele of appendix is the obstructive dilatation of the appendix as a result of accumulation of a large amount of mucus, and it may include mucosal hyperplasia, mucinous cyst adenoma, and mucinous cyst adenocarcinoma. It is often detected as an incidental finding during surgery, routine radiological investigation, or endoscopic examination like colonoscopy. The mucocele of the appendix are uncommon, accounting only 0.2 to 0.3% of the appendicectomy specimen. We presenting a case of 62-year-old female presented with the complaint of the pain in right lower abdomen. The CECT abdomen showed appendicular lesion, likely mucocele appendix. The diagnostic laparoscopy and proceed was planned. Laparoscopic appendicectomy was done carefully and the specimen was retrieved in the endobag. A 62-year-old female presented with a history of pain in the right lower abdomen for 4 months and on and off episode of the nausea, vomiting and loose stool for 2 months. Pain was dull aching and the progressive with relief on taking analgesic. There is no other significant complaints. On palpation of the abdomen was soft, non-distended. Tenderness was present in the right lower abdomen with firm tender lump of approx size 8 into 5 centimeter in the right iliac fossa. The hemodynamical and the biochemical parameters are within normal limit. The USG finding shows there is a solid mass region in the right iliac fossa with 8.5 into 5 centimeter. The CCT abdomen show a thin wall, well-defined elongated lesion in right iliac fossa with the ileocecal junction.
Please finish fast.
Likely the diagnosis the appendicular mucocele. The patient was prepared and taken for the diagnostic lab and proceed. Intraoperatively, there was a cystic appendicular mass of the 9 into 6 centimeter with the inflamed wall seen in the right iliac fossa and the cecum to the ileocecal junction omental adhesion as seen in the figure. That there was no spillage in the intraperitoneal cavity and also no enlarged visible lymphadenopathy. The adenolysis done and the
please come to the conclusion.
The conclusion: appendicular mucocele is the rare disease and has a clinical picture similar to the acute appendicitis. Mucocele of the appendix can also mimic an adrenaxal mass due to non-specific symptoms.
Please stop. Sir, we can allow one question because the operative workshop is about to begin. So only one question can be allowed for this speaker.
What are the issues that you'll be careful of? 1 or 2 issues you'll be careful about in a mucocele appendix?
The spillage of the mucus in the intraperitoneal cavity.
Thank you.
It can lead to more mucus and the condition worsening causing the pseudomyxoma peritoneum.
Good. Thank you.
Thank you. Now we'll start with the live operative workshop, and in the between we'll be able to continue with the e-poster presentations. OT, hello, please give the feed to OT.
Hello.
Hello, good morning.
Hello.
Can you hear me? Can you see me?
Hello.
Hello, Dr. Vinod, can you hear me? Hello.
Hello. Yes, sir. You are audible. I am
Yeah,
Dr.
yeah.
Priyank Chelawat. We
Yeah.
can hear you, sir, in the hall.
Okay, so Priyank, this is a lady which we are going to operate today.
So
And,
we are not able to hear you properly. Your mic.
Just a minute, just a minute. I think these guys are doing something.
Please adjust your mic, sir.
Can you hear me now?
Yeah, yes, sir. We can see you and we can hear you as well, loud and clear.
Better,
Okay,
better.
okay, okay, ठीक है. सर हाथ में दे दे.
I can identify Dr. Jignesh Gandhi one side.
Hello. Morning, sir.
Good morning, Dr. Bhatia.
Dr. Chawla, good morning.
Good morning, sir.
Now, honestly speaking, I have stolen the opportunity to show you Dr. Jignesh Gandhi.
Yes.
I thought that no, first I should introduce and then he should introduce himself and then he should speak about the operation. Dr. Jignesh Gandhi has been an excellent friend, excellent good human being, one. And second thing is that he is a giver. He is a teacher in KEM hospital and he always believes on sharing his knowledge as much as possible. He may learn less, but he will give more. And that is the quality of Dr. Jignesh Gandhi. And we always feel happy. Can you imagine, Dr. Subhash, you would be surprised and you will be happy that on the web search, the video portal in which we see the live or the operative videos by so many surgeons, especially the European surgeons and then the American surgeons, Dr. Jignesh Gandhi has been selected and his videos are present today. So I would urge you, and especially my younger colleagues, to go in on websearch.com, web search, you should log in and then see the videos. Recently he has placed a video on laparoscopic cystogastrostomy for pseudocyst pancreas, and you will be very, very happy to see his name and the name of the team members which he is having at KEM hospital. And he has been a proponent of abdominal wall, I would say, learning the abdominal wall, and he's a thinker. He's a cerebral laborer rather than a manual laborer. And I would now hand over the mic to Dr. Jignesh Gandhi to tell about the case and his plans, and then go ahead. Thank you very much. Thanks, Dr. Jignesh, coming all the way from Mumbai to Rohtak to give. As simple as that.
Thank you so much.
So if I can just interrupt for a while.
Yes.
We would like to thank our present moderators and invite the moderators for the workshop. Anupama ma'am, you have to continue ma'am.
Okay.
I would like to invite Dr. Anupama Sethi ma'am, Dr. Ankit Bhardwaj sir, Dr. Sanjay Marwa sir, Dr. Nirmala Duhan madam, Dr. Virendra Chauhan sir and Dr. Bhagat Singh sir to the dais please for moderating the sessions. Dr. Jignesh sir, please continue.
Okay.
Thank you, sir.
Good morning everybody, and first of all thanks to the entire team here. Dr. Vinod for calling me, and Dr. Parveen, my teacher, for such wonderful humble words. So this is a lady which we are going to operate today. She has previous about 3 surgeries. She has a vertical surgery for the C-section. After that she had another C-section, and then she had a hernia, following which there was an IPOM procedure done. I don't know whether it was an IPOM plus or only IPOM. After that she has got a recurrence, so when we are live at that time I'll show you. Now what happens in such patients is it's very important to do a pre-operative planning. So can you all see the CT scan here on the can you see the CT scan? Yeah,
sir,
can you
it
see
has
the
to zoom in a little.
Yeah. Can you
Yeah,
see that?
sir, we can see
yeah.
now.
So as we come from the top, okay, and we keep coming down, we have to decide in abdominal wall reconstruction that what plane or which component are you going to separate, because this patient is amenable both for anterior component separation technique and posterior component separation technique. But because of the previous surgeries, things change. So if you see here higher up, you can see the tags. Can you see this white tags here? These 2 spots?
Right, sir.
Yeah. So as I keep coming, now the defect starts coming in. In fact, the image is cut there, but you can see the right rectus abdominis and the left rectus abdominis, and this is the defect here. And you can see some stranding. Now this trending is probably because of some kind of the momentum which has gone into that. Okay. As we come down, you can now see that there is a bowel here. Okay, and there is a bowel here also in the defect, and you can still see the tags on either side, and this white wine line, you can see this white line here. Can you all appreciate that?
Yes, sir.
With the tackers. Now this is probably the mesh. So can you zoom in there? So this is a mesh. Can you see this white line here?
Yes, sir.
And you can see the tackers have gone all the way. So we are always worried, how much of the purchase. So it all depends on the thickness of the tacker. So you can see here that it has gone all the way up to the rectus.
Right.
Now essentially what has happened in this patient is that the posterior layer, that means the layer where you will have the transverse abdominis, you will have the posterior ector sheath, is all absolutely adherent, and you can still see here down also that there are tags here, and this is the mesh. If you can appreciate, this is a mesh here.
Yes,
okay.
sir.
So the posterior components are completely fused. Now in this patient, if I try to change and try to go into this plane and try to attempt a TAR, I will be creating a lot of buttonholes because A, the mesh has already become peritonealized over there. So the plan changes from a posterior component separation to an anterior component separation because now we have to go to a virgin area. Okay.
Right.
So what happens is that in an anterior component separation technique, what are the important things a surgeon should know? Number one is you should know the width of the rectus. So if you see these cuts of the CT scan, if you can see a standard cuts, there will be about 5 millimeter cuts of the CT scan. So from here to here, you can see that the rectus width in an average male or a female patient will be between 5 to 7 centimeters. So I have to see for the width of the rectus on the right and the left side, because it is only beyond the rectus, which I will be showing there, that beyond the rectus abdominis, you have to go about 1 to 1.5 centimeters lateral, so that you are making the cut onto the external oblique aponeurosis. And if you can see here very clearly, all the three obliques are seen very nicely. Can you appreciate that?
Yes, sir.
The external oblique, internal oblique, and the transversus, which has a part of the mesh also. So I will be going between the EO and the IO because that fat plane, can you see that black line in between?
Yes, sir.
So this is absolutely the virgin area. All the blood vessels are between IO and the TA. But between the EO and the IO, you will always find it's a virgin plane. So we will be making a cut here and then getting into this plane on this side. The end point of that is usually you will find the piercing vessels which will come from the retroperitoneum, and these are the intercostal vessels in the upper part. This is your end point of how much release you can go laterally. Once you have made that release, this component of the rectus abdominis, it starts moving medially. So you're doing a medial advancement by making that cut, and we will see that. Right. Once you have done the procedure on this side, you go to the opposite side and you do the same thing on the opposite side. So try to go into a virgin plane. So in this patient, the virgin plane is the anterior component because posterior component, the mesh is already there. What will be my Achilles heel for this operation? My Achilles heel of this operation would be to separate the adhesions of the bowel here. Can you see? It is very densely stuck here. Can you see this here?
Right, sir.
Yeah, so here it may so happen that we may leave a part of the mesh onto the bowel. So we will see inside what happens, and according to that we'll take a call, because this is an area where we may anticipate problems. But since I'm going to do an anterior component separation technique, even if I just go to the superficial layers and I just leave that mesh as it is, this patient has never had any obstruction, I will not try to do very extensive intraperitoneal adhesolysis because my plane of hernia surgery is totally different. So we will only try to do the dissection, how much we want, and then we will go on the either sides. So there may be a possibility that we may go on this side or this side depending on what we anticipate. So the Achilles heel will be this point, this point. So I know that somewhere in the mid-abdomen, I'm going to expect dense adhesions. Okay.
Right.
Now coming to the scenario of what all can happen. So in preparation of the patient, this patient has undergone a bowel preparation, which is absolutely mandatory. I keep the patients on liquid diet 24 hours prior, give a bowel preparation. Because in any case, if you have a small enterotomy or a colotomy, if the spillage is not much, if it's a colotomy, definitely you're not going to put in a mesh. But if it's an enterotomy, there are two aspects. Number one is that if it's a minimum bile spillage, then there's probability that I may close that opening and we can still go ahead with putting in a mesh because we are in a different plane. But what is the flipper side? There is a 7% incidence that these patients can develop an intracutaneous fistula. But almost 90% of the patients may not develop that if there is a limited or maybe a small opening in the enterotomy. But if you have a large contamination of the bile, then obviously you will defer, you will do a tissue repair and you will come out. So that is going to be the Achilles heel of this operation. Patient is put under complete general anesthesia. We put in a Foley catheter in this patient. Both the arms are to be tucked on the either side. And important is that I will ask my anesthetist what is the peak pressure. So the peak pressure is that whatever is the closure right now, there's a defect there. After we close everything, the components of the abdomen will cause pressure on the diaphragm. So you need to check whether you have a peak pressure, and some advanced monitors also give you a plateau pressure, which is more sensitive than the peak pressure. So between the start of the case and when I close the abdomen, I will ask what is the peak pressure. If the difference between the two is more than 5, I will need some additional release, and I may need some bridging rather than doing absolutely an augmentation mesh plasty. If the difference is 10 and above, then these patients are likely to go into abdominal compartment syndrome. So these are the indicators which I would plea every surgeon in the audience, including the trainee, that start looking at these pressures even in your routine laparotomies when you're doing deep perforations, ileal perforations, and check before and after, and the difference should not be more than 5, because if the difference is more than 5, then you are in trouble. The technique which I'm going to show you today is going to be very useful in difficult abdomen. So you may do a laparotomy for an ileal perforation which is 4 days old. You can still go ahead and do an anterior component separation technique without a mesh. I don't want to get into that area of when you can put in a mesh, because that's a complete different ball game of clean contaminated and level 3 kind of procedures. But you can do an anterior component separation technique, close the abdomen. So I seldom, in last almost about couple of years, I have not put in a Bogota's bag or a Eurosac bag or a mesh or something like that, unless the patient is referred to me with an open abdomen. But a good anterior component separation and a midline closure should be sufficient, and that is what you're going to see today. Okay, so we will start the case and we will move to the other theater. Thank you very much.
Thank you, sir. Thank you very much, sir, for the elaborate discussion. Can we shift to the other OTs as well? Dr. Arun Prasad sir is operating in case of achalasia cardia, and in the OR1 there is a total laparoscopic hysterectomy being done by Dr. Nutan Jain ma'am. Dr. Arun sir, we are with you.
Hi,
we can see the slide.
Can you hear me?
This is a case of 26-year-old female presented with vomiting and difficulty in swallowing for last 6 months. There is no operative history, no comorbidity. On barium swallow, there was bird beak appearance. On upper GI endoscopy, there was dilated esophagus with resistance at lower esophageal sphincter, suggestive of achalasia cardia. Plan is laparoscopic Heller's cardiomyotomy.
Yeah, thank you, dear. Thank you very much. Before Dr. Arun Prasad starts the surgery, though he has already started and he has placed the trocar, before he starts speaking, I would tell about Dr. Arun Prasad that we have been close friends since our Maulana Azad Medical College days, and we have been growing together, and Arun Prasad has also traveled world over. He has been the president and secretaries of many associations. I am not going to name that all, but he is an excellent human being, and he also believes in giving.
Praveen sir, there is a little the voice is not clear as the mic is inside the mask.
So you want that I should take off the mic, or
yeah, so it is just a suggestion from the audio-visual person.
Yeah, sure.
Yeah, sir, we are loud and clear now.
Loud and clear, yeah.
Yes.
So I just wanted to say that Dr. Arun Prasad and me have been closely following each other. We have grown together from Maulana Azad Medical College days, and he has been the president and secretary of so many associations all over the world. And he has always been believing in sharing his knowledge. He is a giver, and today he is going to perform the surgery for achalasia cardia. And I know that he can be interrupted at any time, and you can ask him n number of questions, even if he is doing advanced laparoscopic surgery. Dr. Arun Prasad, please, go ahead.
Thank you. Can you hear me?
Yes, sir.
Thank you, Dr. Bhatia, for those kind words, and everybody here should be able to see the screen where I will first show the X-ray. Can we go to the screen there?
I would also like to invite on stage for moderation Dr. Shashi Chauhan and Dr. Rajesh Yadav to moderate the operative sessions as well. Arun sir, we are with you.
Yeah, are you able to see the screen?
Yes sir, we have the laparoscopic view.
No, we want the
And the
external view.
Yes, sir, but it is
It's in
zoomed
PIP.
out.
Zoomed out.
It's in
It
PIP.
is in
make on
PIP.
the
It is in
screen.
PIP. Yeah, sir. We have it on our
Yeah.
screen.
So this is a 26-year-old female who presented with dysphagia, more to liquids, and as you can see this barium study here, it shows the classic what we see in our MBBS, MS, all exams, the beak appearance. So you've got a dilated esophagus and a beak-like appearance there, which confirms the diagnosis of achalasia cardia. Achalasia cardia, as we all know, is a physiological issue in the lower esophageal sphincter, whereby the dilatation does not occur, especially when we are talking about liquids.
Dr. Arun? Dr. Arun?
Yeah.
Was pressure study was done in this case?
I will have to ask one of the organizers to answer that question. I don't think pressure study was done because based on history and this classic X-ray.
Sir, what about endoscopic findings?
Normality, the endoscope could pass easily into the stomach, so there is no pathological or anatomical narrowing of the lower esophageal sphincter.
Because sometimes it could be pseudoachalasia because of underlying malignancy that
Ye-
might
yes,
look like. Yeah, so
absolutely right. So endoscopy
that
was
should
done.
always be done beforehand.
Yes, endoscopy was done. So now what we will do is, I will ask the external view to zoom on to the abdomen, and I'll just show you the positioning of the
We have
trocar.
the laparoscopic view, sir.
Yeah. So we'll need an inside view. Sorry, the outside view. Okay, go back. Can you see the outside view?
Yes, sir.
So what we have here, the patient is quite small, so the abdomen is quite small. So I have decided to take the telescope in through the umbilicus. Otherwise, generally we go by one palm breadth from the xiphisternum, and usually that comes to about 2/3 from the xiphi to the umbilicus. But as I said, this patient is quite small built, so we have taken the telescope through the umbilicus port. We have two 5 millimeter ports in each mid-clavicular line, about 5 centimeters below the subcostal margin, and we have one assistant port in the anterior axillary line at the level of umbilicus to help in retraction or pulling of the stomach. A very important instrument which I use in all upper GI surgery is the Nathanson retractor, and when you see the inside view, you will see how nicely the Nathanson has moved the liver away and has exposed the hiatus to us. So any questions about trocar placements? Otherwise we'll move in.
No, continue, sir. It's quite clear.
Okay. Now I need one gauze piece. Give me one gauze piece.
Sir, you are on the right side or in between legs?
No, I am standing on the right side of the patient. Yeah, one Maryland or something like that. Now what I am going to do is again external view. External view, please. You can see this gauze piece.
Yes, sir.
So right in the beginning of the surgery, please take out the telescope. I am going to place this gauze piece near the spleen. Push, 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 push. Yeah. Now, the reason for this is we want to avoid any diathermy, cautery as much as possible. So we will use the gauze piece for hemostasis more than any diathermy. Once I put the instruments in, we'll do a cleaning. Is the Riles tube in? There is still some air. So can you just manipulate? Now this is dilated.
Yeah, stomach is distended, yeah.
So what we will be doing grasper. एक और grasper. और stomach पकड़ने के लिए कुछ और उनको चाहिए होगा.
Sir, can we just go back to Dr. Jignesh sir's OT and
Yeah, you
get
can do
back
that
to
while I try to deflate the stomach.
Yes, sir. Audio, please switch to OR2. Hello, Dr. Jignesh sir. We are with you.
Okay. So we have taken the skin incision. Okay. And the plan is that, I was just telling them that I like to take the skin up to the fascia, everything with the knife. And the juniors in the audience, we are very poor at using bipolar. Start using the bipolar from now, and don't try to use a lot of monopolar when you are entering into this plane. Okay. There was a time, once upon a time, that I used to be a very flashy surgeon, and I used to use so much of monopolar, and there used to be so much of smoke in the OT that people used to say, Jignesh nahi dikh raha hai. So we should not, go into that plane. Another thing which you can see is I have modified and made this infant feeding tube tip just to have this projection. Can you see that?
Yes, sir.
So this works very sturdy, and if you can see here, I have given a little angle. So as surgeons, when we operate, usually if we make it straight, then we have a chance of buttonholing into the flaps.
Right.
So making this angle is very important. So this is one tip also which everyone should learn, that you should always have this much, not the entire metal part exposed. Just a small technical tip. Okay.
So the purpose to cover the length is just to avoid lateral damage.
Absolutely, absolutely. Because you are, focusing on particular part of the operation, and then you don't want to get into all that.
Right.
Okay. Blade. So we chose that incision. Here I can feel some stiffness there. I'm just going here layer by layer, because at one point in time we have seen that in the upper part the sac is quite visible there. Okay. So I'll be just reaching that part, and then we will open up into the virgin area as much as possible. So probably this is a sac here. Can you see that?
Yes, it's visible, right? The white thing.
So it's always a good idea to enter from the virgin area in cases like this. Initial part of your dissection should be very, very slow, because there are a lot of structures which are stuck there, and then as you keep going deeper inside, and I told you about the peak pressure. Yeah, so the peak pressure in this patient to begin with is 19. Okay, 19. So if one of the moderators can remember, they can ask me this at the end. What is the peak pressure at the end when I complete the surgery? Okay. Artery. So you can see here, this is a relatively flappy area. Okay. So we will just go around the sac.
Sorry, the field is not visible. Your shoulder is coming in the way, right?
Yeah.
Now you can see
okay,
it.
Okay. Got it. Monopolar. Can you increase the volume on this thing? Monopolar artery.
The view is gone, sir.
Can you see now?
Yeah.
थोड़ा सा आगे आ जाना बेटा. उनको दिक्कत हो रही है.
को बोल दो.
और पीछे रखो. डिस्टेंशन और दे दो ना. थोड़ा डिस्टेंशन दे दो.
मैडम को माइक दिया.
Fluid, हाँ.
Sir, in this case, you have shown us the CT size, CT scan to assess the size of defect.
Yes.
So do you do clinical assessment also?
Yes, absolutely. But what happens in a scarred abdomen like this,
right,
sometimes it is very, very challenging. Now you can see that the momentum, the peritoneum is coming to the way. Can you see that?
Yes, it's visible. Yeah.
So my sincere urge again to every surgeon in the audience is try to save the peritoneum. Okay.
Right.
And we should leave the tigers to the government of India. But surgeons should always save the peritoneum as much as they can. Okay.
Right. So what is the advantage of that?
So because you can use it, it's one of the biological mesh, isn't it?
Okay.
It's a biological mesh made by Mother Nature. So we should not try to disturb it.
Like lot of peritoneum is there in the hernial sac, so you suggest that that should also be saved?
Save the peritoneum till the end.
Okay.
Leave the tigers to government of India.
Because normal tendency is to excise the
so even
sac.
that's what I said. Even we have done that. We have cut the peritoneum and thrown it and given it to the sister.
Right.
I think we should condemn doing that.
Okay, so that's a good learning point, right?
Absolutely. So always save the sac. Always save the sac.
Dr. Jignesh, can we move on to OT
Hello.
1 now?
Yeah.
Please move the audio to OT1, where Dr.
Dr.
Nutan Jain ma'am is operating.
Yeah,
but
Dr. Nutan Jain, all of us know that she has been a prolific laparoscopic gynecological surgeon, and she has been doing workshops all over the world. She has been on the international faculty of AAGL, and she has written books also. And I would definitely urge my younger colleagues, especially my younger colleagues, to read about a single theme book on the Jain point, the how to access the abdominal wall in a battered abdomen. For example, we use Beery's needle, Hassan method, and Jan point. And this Jan point has become international point now. So I am much more happy today when she has come all the way from Muzaffarnagar to Rohtak to demonstrate a case, and in this, the 28 weeks? 26 week size uterus, and she is going to demonstrate her surgery. Over to Dr. Nutan Jain now.
Yeah. Mike.
It is there with you.
Yeah. On kar diya?
Yeah.
Yeah, a very good morning. At the outset, I must thank Dr. Praveen Bhatia, a very close friend, and we've been working together for years together now, for a very kind introduction. And as the aim and a good big kudos to the organizing team headed by Dr. Vinod, who just approached me a very few days back and got my approval. And here we have a lovely case to demonstrate. I will call it lovely because these are the cases which we are turning away. So my idea to show a difficult case is to help many of you to tide over these difficult situations. So I would like to focus over the patient's abdomen. In the hall, can I see someone interacting with me continuously?
Good morning, Dr. Nutan. Hello.
Yeah, very good morning.
Dr. Nirmala Duhan here.
Okay, very good morning, Dr. Nirmala.
Good
So,
morning.
I think you have the abdomen's view. So
Yeah.
we can show you that this is the size of the uterus
Yeah.
coming up to the upper margin of the umbilicus.
Right.
So entry in such cases, big masses, and the scar which you see of the cesarean is almost midway between the pubic symphysis and the umbilicus.
Okay.
So here in this point, we have devised the point which Dr. Bhatia introduced. So we first locate the anterior superior iliac spine. आप थोड़ा सा और अच्छा फोकस करो कि जहाँ मेरी उंगली जा रही है वहाँ पे दिखाई दे ये विश्राम आपको हटना होगा थोड़ा सा. So now can you see? उधर का स्क्रीन मुझे दिखा.
Not really clear, but
हाँ,
yes,
we will try
can
to show you because at least one thing learned. All those who are sitting here will be richer by one more port. So this is a very important and a prominent fixed bony landmark which we call the anterior superior iliac spine. Okay?
Yes.
So we go 2.5 centimeter medial. Let them organize it better. So from this 2.5 centimeter medial, we go up to the level of the umbilicus in a routine manner. But since this case has a bigger uterus, so we will try to move still further higher up. So we palpate for the subcostal margin and we see that there is, which I have done already, that there is no splenomegaly. Okay? Rice tube is already in. So please dal lijiye. So one thing which I cross-checked with the anesthetist is that there should always be a Rice tube. So this is a fixed protocol at most of the centers.
Ma'am,
So
can you show even if the uterus size is smaller, Dr. Nutan?
Can we have the noise level in the theater low now? Please up here. So if the uterus size is normal, we will stick at the upper margin of the umbilicus.
Okay.
But here, since the uterus is very large, so I will try to go 2 fingers higher up so that my telescope is not hitting it all the time.
Yeah.
ये देखो, I am making the incision. आपका ना ठीक से नहीं आ रहा है. Can you see with the telescope now?
We are seeing the external view. Yeah.
Yes,
Hello?
ma'am. We can see it
You can
clearly.
leave the external view और ये telescope वाला दे दीजिए.
We are seeing the telescopic view, ma'am.
Okay. You are seeing?
The external view, ma'am. Ma'am, excuse.
We are showing it better with the telescope.
मैम एक माइक
हाँ, आप उसको हटा लीजिए. ये व्यू दे दीजिए. हम ऊपर
यही जा रहे हैं मैम माइक्रोस्कोप.
Ma'am, we are seeing the telescopic view that is being
You cut it out.
external abdomen is shown.
Sure.
We are seeing it with the telescope, ma'am.
So this is the anterior superior iliac spine. थोड़ा दिखाओ. सामने देखो. ये. And I go 2.5 centimeter medial. Then we draw a vertical line at the level of the upper level of umbilicus. But since it's a big size uterus, so I will go about 2 finger breadth higher. Okay? And here, I'll just wait a minute. The anesthetist is putting a Rice tube. So just as a protocol, always put your hand above the umbilicus and see if the stomach is bloated. Just release any gas which is inside. And another safety protocol which we are doing is the Riles tube. So for this, we make a stab incision, and without lifting the abdomen, we go like this. We first feel for the external oblique, muscle epinurosis, then the fused epinurosis of transversalis and internal oblique. And we reach inside. Then as a safety check, we aspirate and we inject. And we look for the drop test. Do you see?
Yes,
the drop has gone in easily.
Yes, ma'am.
So now we connect the gas. वो दिखा दो तुम. And we focus on the.
Dr. Nutan, how different is this point that you have entered from the Palmer's point
Yes.
in this case?
In this case, बराबर देखते जाओ, because I will be talking. So the Palmer's point has a. You have to locate the mid-clavicular line, okay? And that lies in the unsterile region. This has a very fixed, prominent bony landmark. So for daily use, for the gynecologist, it's very easy. Secondly, it is about 10 to 13 centimeter lateral from the umbilicus. So it avoids all the midline adhesions. Being in the mid-abdomen, it avoids the adhesions of any previous scar which could be in the upper abdomen, okay? And it works well with the lower transverse or the lower abdomen vertical incisions. And then this point itself will continue as the main ergonomic working port. Secondly, for the general surgeons and the urologists sitting in the hall, this point the mirror image of this point can be taken on the right side, while the Palmer's point cannot be taken on the right side for the risk of liver laceration. So this almost becomes the most ideal port, which is devoid of adhesions, which remains outside the main surgical field. It avoids the major retroperitoneal vessels below the umbilicus, avoids the bowel or omental adhesions with the upper abdominal scar around the umbilicus and the lower abdominal scars. So its unique position in the mid-abdomen and very lateral makes it very versatile. And as Dr. Bhatia said, it is being used very freely now by the urologists, general surgeons, and mainly oncologists are also finding favors. And we've got 2 publications from Spanish doctors who were oncologists, and they have published the cases where they had multiple scars because of multiple surgeries of oncology, and after neoadjuvant chemotherapy, they have done second look procedures with the Jan point. So only now I am inserting. We hear the hiss, and now I will go. इसपे cover नहीं है. So now we go in. So while talking, we sort of.
Can we have OR2 feed on the other screen? OD2 feed on the other screen?
So 5 mm port, madam, you have
OD2
created?
feed on the other screen?
Yes.
Now we see there are some adhesions.
You've done just the 5 mm port.
Because this is the scar is in the mid-abdomen. If you see, I told you earlier only. And the uterus is here. So just above the uterus, we have all these adhesions in the mid-abdomen. But we have stayed away from them. And now we will make the 10 mm camera port, which I will take very high up, so that we don't have to clear up the blood or anything which touches. So for this, I am always using a 30-degree scope, and we go very high up, almost just above the liver. ऐसे hold करोगे?
Can we just get back to you? Dr. Arun Prasad is calling us for a while.
Can I just finish the 10 mm scope so that the entry
Yes,
is
sure,
over?
ma'am. Yes, ma'am.
It's very important to keep seeing.
Also,
So now,
can the
under the
resolution-
vision of this 5 mm telescope, we are optimizing a 10 mm port. Okay? Now, the entry part is over. You can switch over to the other.
Thank you, ma'am.
Yeah.
Please shift the audio to OR2. Hello, Dr. Arun, sir.
Hi, can you hear me?
Yeah, we can hear you, sir.
Okay, so I'll just tell you what we have done so far. First, let me hide this secret. ये बाद में दिखाएंगे, पहले छुपा रहे.
Now recapitulating the things.
हाँ, वही मैं कह रहा हूँ, ये छुपा रहा हूँ मैं. So where we started the surgery, telescope पीछे करिए. My assistant port here, Dr. Prem Arora, he is holding the stomach and the fundus. Before we did that, we had the Ryle's tube inside the stomach. So I moved the Ryle's tube around and asked the anesthetist to suck out all the air. After all the air was sucked, the Ryle's tube was removed. Please note, Ryle's tube is not to be pulled back. Ryle's tube has to be removed out of the patient. When you are doing surgery on the esophagus, there should be no Ryle's tube inside the esophagus because that can lead to perforation. So tip number 1, after emptying the stomach, remove the Ryle's tube out of the patient, just like you do no Ryle's tube in bariatric surgery. Similarly, no Ryle's tube in esophageal laparoscopic surgery either. But the stomach is very nicely collapsed, as you can see how we have done that. Patient is very nicely relaxed. Great relaxation by the anesthetist. You can see, I can see big view, good view. You can see the gallbladder there, spleen there. The view is fantastic. The liver retractor is doing a great job. So the first step which we did is with my harmonic, I went into this place. This is known as pars flaccida. So this was, covered something like this. So I opened the pars flaccida, go inside with the telescope, and I reached here to expose the right crus of the diaphragm. So this is the right crus of the diaphragm. Sometimes people confuse this because there is a lot of fat here, so they go straight here. Show me this. So this is the caudate lobe, and under the caudate lobe is the IVC.
Right.
And you can see the color is quite similar. See this color and this color.
Mm-hmm.
So in a fat patient, if this gap is not enough, you might go and start freeing the IVC instead of the crust. So this is tip number 2. Open the pars flaccida nicely, make a nice big window and expose the right crust. After you expose the right crust, all you have to do is tease a little bit with your forceps like this, and you will be able to separate the esophagus, which is this. So esophagus is lying here up, and behind the esophagus I am able to see the left crust, which is there. Go inside. So in a hiatus hernia case, as Randeep is going to show next time, there will be a big gap between the right and the left crust. Here we don't have that much of a gap. And what I have made is a window there. Through the window you can see the spleen. Can you see the spleen?
Yes, sir,
Andar
it's
jao.
visible, yeah.
Andar jao. Or andar. So the spleen is there. Come back. So just like in lap chole, you make a nice good window and you see the liver through the window. Here a good window means you should be able to see the spleen there. Come out. Then we have similarly freed the other side with the harmonic little bit. You can just see this small amount of freeing has been done so that the crura is nice and visible. So you can see the left crust there.
Yes, sir.
So now what I have got is I have got the right crust, left crust, the esophagus has been lifted up and it's nicely being retracted down. Please go inside. Now we need to split the muscle open 5 centimeter on the esophagus and 2 centimeters come down on the stomach. Go inside now. So stomach, there is a vein here. This vein here you can see.
Yes, sir.
So stomach we have to reach till this vein. If you don't come down to the stomach, patient is not going to get better. They will continue to have dysphagia symptoms. However, if you come down to the stomach nicely, you are going to create reflux in the patient. So the idea here is to create a reflux and then do a door fundoplication. Just leave the stomach, aap chhod do. Door fundoplication would mean picking up the fundus, suturing it over the myotomy which we have done to the crura.
It's anterior fundoplication.
Yes, it is the anterior fundoplication, door fundoplication. Yeah, please, now you can hold it again.
Sir, you have ligated some vessels at the fundus to mobilize the upper end?
No, that see that we do these vessels. If you are seeing here,
Yeah.
that is done. If I am doing a Nissen fundoplication, if I was doing a Nissen fundoplication, I would have started here and mobilized this vessel from here to there, like we do in bariatric sleeve gastrectomy, so that the posterior fundus can go nicely around.
Right.
But here, as we are not doing that, so I don't need to free these vessels because the anterior fundoplication would come nicely, good enough.
Okay.
So now we move on to the esophagus, and as you can see, tip number 3, a gauze piece is already inside because we want to use as little cautery as possible. So I have got a gauze piece there, and what I am doing is I am just with my Maryland opening this as you do in lap chole.
Right.
Go inside.
So how do you ensure that you are not going to damage the mucosa? Any tips for that?
You can't ensure. You have to be very you have to be very cautious. The whole team in the OT has to watch very carefully. So if you make a hole in the mucosa, you should identify and stitch it.
Right.
Making a hole in mucosa is not a crime, but not identifying it and leaving it behind is a crime.
Right.
And if you are doing a good Heller myotomy, I think about 10 to 20% times you will make a hole. If the patient has had previous balloon dilatation, then there is a 40% chance that you will make a hole.
Okay.
Please go
With
inside.
balloon dilation, fibrosis develops, and
Yes.
that led to
Absolutely, you're
perforations.
absolutely right.
Sir, what we have taught is if we identified the mucosa, and then we change the direction of Maryland, that as the point of Maryland is facing toward
Quite
mucosa.
right. Absolutely right. So now here we have identified the mucosa.
Yes, we
there.
could see that, yes.
You'll see a small white bulge.
Shiny thing, yes.
It bulges like a balloon.
Yeah.
Go inside.
Dr. Arun?
Yes?
In your hands, this surgery appears to be too easy.
Sorry?
In your hands, this surgery appears to be too easy.
No, that's not true. In fact, I was quite worried about this surgery because these days I do this robotic.
Okay.
So I was also getting worried कि बिना robot के, it's like Mercedes की आदत हो गई है फिर मारुति चलेगी कि नहीं. But I am also happy to actually have the feel because robotic we don't get this feel. So in fact, I am feeling very happy today that I can get this feel.
Now you do all the cases of achalasia with robotic only?
No, it's usually patient driven. Patient आता है कहता है मुझे robotic करानी है.
Yes.
Personally, I feel suturing part is better done robotic, and I can do a little faster robotic. That's all. But otherwise, ऐसी कोई बात नहीं. Yes, you can see the
Yes,
punch
sir,
there.
we can see that.
Yes.
So now, as somebody rightly pointed out, after this, now we are going to turn this to the other side, and this part I don't mind actually using the harmonic suction use करता है ये exhaust.
As such, there are two methods of separation. Either you go layer by layer, or you first approach the mucosa and cut it.
I started layer by layer, and once I have seen the mucosa, now I can go over it.
So what is the upper limit of dissection? How to be sure that you have crossed the narrow part?
I think 5 centimeters.
Any other objective way to assess that you have crossed
there is no objective way.
Okay.
Sir, pressure study is important for this part. If pressure study is there, you can determine the place, how much you have to go in the thorax.
Give me the harmonic.
So I am Dr. Sudesh from Indore. How about intra-operative endoscopy?
नहीं, achalasia में intraoperative endoscopy is not going to help much. Apart from the fact that it will show you transillumination, light will come shine.
No, just to complete the procedure, sir.
And also, it will tell you if there is a hole.
Sir, to complete the procedure, that still there is some resistance or not?
पता नहीं चलता because this is a very physiological thing. It's not a stricture which we are dealing with. क्योंकि endoscopy में achalasia में जब endoscope होता है, it goes into the stomach quite easily. There is no resistance anyway. So this can be done with the cold end of the harmonic below, or we can even use a hook or scissors or continue to tear it. All options are there. इधर से ही डालना होगा, ये ले लो, मेरे मुझे लेफ्ट में दे दी. So here I am going to be slow because this is the slow part of the surgery.
Dr. Sharda, take on the endoscopy is that usually patients of achalasia cardia have 2-3 endoscopy reports. 1-2 are normal, and then someone suspects if symptoms are not relieved, then it's achalasia cardia. It should be suspected, then you can find it's achalasia cardia. Otherwise, on initial endoscopies, you can miss it.
What I think, or what my understanding is, that diagnosis of achalasia cardia is when you deglutinate the saliva and if sphincters are not relaxed. So first endoscopy will tell that that patient is having achalasia.
That you are suspecting, na?
No, that patient is having achalasia or not.
Okay.
Sir, audio shifted, Dr. Gandhi.
Hello, Dr. Jignesh sir.
Yeah.
Yeah, we are with you in the hall.
Yeah, so just to orient all of you, this is the head end of the patient, leg end of the patient, okay?
Right.
And we went, and you can see that it was a tough thing, but we could separate out and enter the peritoneum. This was a mesh. Can you see the mesh?
Yes, sir.
Yeah. And that is a tacker. So you can see that all of us who like to tack, metal tackers, you know, we have to be careful. See how this dangerous is the tack is. Can you see that?
Yeah.
Yes.
Yeah. So it is very dangerous, and it was very close to the bowel there. So the trick of this case is that we did an addizolysis and we saw that the hernia was in the upper part. In the lower part, I know that there is no defect. Okay. So my dissection of the peritoneum will be only to this much. Maybe I might just go another 1 or 2 centimeters down, but it may not be required. The next step is I put in a mop there, which is again a mop with a marker and keeping the tail out, and then you start raising the flaps. Now when you raise the flaps, the key important part is that all your perforator vessels, the major ones, they run above the Scarpa's fascia. So try to remain as flush.
Sir, please focus.
Yeah, can you see that?
Zoom in, sir.
Zoom in.
Yeah. So try to remain as flush as possible. Lot of times I have seen people keep a lot of fat on this.
Yeah.
Because all your vessels in this layer are above the Scarpa's fascia. Okay. So below the umbilicus, the Scarpa's fascia is more prominent. The next step is that I have seen for the width of the rectus, and it was somewhere around 5 centimeters. Can you see my hand here?
Yes, sir.
Yeah. Now what I did, the next step was I took a bipolar and I tattooed. So I go about 1.5 centimeters beyond the rectus, which approximately will be the site of my linea seminaris. Okay,
Right.
Can you see that?
Right.
So I'm just tattooing that area, and this is a external oblique on which I'm doing the tattoo. Now I'll take a 15 number blade. My hand is here. Okay, can you see this inside?
Yeah.
And I will make a cut on that. And when you make a cut on the oblique, the first thing is you should start seeing a little bit of fat below. Can you all appreciate there's a fat below?
Yeah.
Yeah. Now I'll take an artery forceps, and I will start going into this plane above, and I'll tell my colleague who is there with me to open up that. Or you open up this, I'll do that. Just open this for me.
So you are dividing external oblique, aponeurosis.
Aponeurosis, okay?
Yeah.
And we will just still try to go in that area here. Lift up that. Peanut.
Yeah.
Peanut. So this lady has still got a broad rectus. Can you all appreciate that?
Yeah.
So we might have to still go a little bit more laterally. Hold this. So these are all the fibers of the recti.
Rectus, okay.
Because the defect was like this, so it has split up that. You understood?
Right. So maybe rectus has been displaced laterally. Because of hernia.
Correct. But the idea is that we remain into the plane on the external oblique. Okay. So I'll be going there. Can you come there? Audrey?
You will be making another incision or
No,
extending
no,
this
no, no,
incision?
same one we will extend. No?
Yes.
You have to extend the same one. There is no need for another incision.
So we'll just be right back with you.
Yes,
We'll,
yes, yes, yes.
Go to the TLH OT.
No problem, no problem.
Please
no
shift
problem.
the audio to OT1.
OT1.
Hello?
Hello?
Yes, ma'am.
Yes, I'm audible?
Yes, ma'am.
And is the picture quality good?
Yes, ma'am.
Okay.
We
So
have
first,
seen you injecting something and then progressing for the surgery. So could you
yeah.
just explain?
So first of all, I will just show the port placement so you can get an idea what is an ergonomic good working style for such big masses. So this is the epigastrium, and if you see that I'm almost one, what do you call it, this palms, full outstretched palm, and this is the 10 mm port, okay? I'm ipsilateral, so there are 2 ports on the left side, and similarly 2 ports for the assistant on the right side. And there's a separate camera person for the 30-degree scope.
Ma'am, I will just ask you a point.
Yeah.
That, this is not in the center, the camera port.
The camera port cannot be in the center because I have gone even higher up than the falciparum ligament.
Okay.
So that not to tear it, and we keep looking at the liver. And the other things which I would like to show here is that since in such large masses you never know how much are the adhesions, so this extra safety feature we have taken, that we have injected ICG in the ureters, and along with the normal picture, that is the onlay mode. So here I am using a Stryker 1688 camera system, and to increase the safety of the ureteric and the bladder, we have injected ICG. So it is simply done by our own hysteroscope, and you can see here that on both the sides the ureters are very clearly seen. And you see that this is the aortic.
Through ureteric catheters.
Yeah, we have used ureteric catheters. Yeah, hath rakho. And the ICG is diluted in 10 cc of normal saline, and then about 2 to 4 cc are injected in both the ureteric catheters. Since this patient, now supposing I had a patient of severe endometriosis, which is a very routine thing for us, so then this would have been come in much more handier. But here what I was doing, the adhesiolysis were the adhesions of the sigmoid.
And ma'am,
So
you have used vasopressin.
Yes, I will tell about that. So we, isko band kar lo. So we injected large amount of vasopressin. This is about 500 ml. For this big uterus, 26 week size, 100 ml or 200 ml will not work. So we have used about 500 ml, and from both the ports, assistant and mine, we were injecting vasopressin for a long time. And if you see that this uterus, when you put it down, it is coming almost to the level of the aortic bifurcation. So since I asked this, I met the patient yesterday and found that her age is just 42. Yahan se uthao. So once her age is just 42, I will be conserving both the ovaries, and we even counsel the patient.
What is the basic use of vasopressin in this case?
It is gives a lot of hydrodissection and less bleeding.
Hydrodissection, Dr. Nutan, can be done by saline also. So why so much of vasopressin? And I guess
It's not so much of vasopressin. Vasopressin gets diluted. It's only saline. The amount of vasopressin, there is only 1 ampule of vasopressin.
Means 20 units.
Ha.
You want to
in
speak
500 ml.
Yeah, in 500 ml.
In 500 ml. So it is highly reduced in concentration and gives a very good hydrodissection.
What is the use of vasopressin while doing TLH? Like
in TLH, in fact, in our OT, it is being used for every surgery, endometriosis.
No, for TLH, I'm specifically asking.
Yeah,
because other surgeries you can. Like, if you could have gone through, what is the big use of it?
Oh, okay. I will keep talking about vasopressin as we progress.
Yes.
So now I am using a vessel sealer, which is a N-seal from J&J, and if you see, this is articulating. So can you see? It looks like a robotic arm. Andar karo thoda. So, these articulating instruments come in as a very big, good measure, because they can approach difficult angles whenever, like in this, it's such a heavy uterus. All these 4 instruments are being used, and I'm using a uterine manipulator, which is the Rumi uterine manipulator from Cooper Surgical. So once we have done this, and today I will be, if possible with this large uterus, I will try to show you a different way of dealing the uterine arteries and doing a TLH. And then the benefits of vasopressin will also keep coming in between. Is the focus in the picture clear?
Yeah.
Okay. Now keep coming in. यहाँ पे रोकोगे आप? Because I have to leave. यूट्रस को और पीछे करो. ये तुम्हारा है ना? हाँ. So that I can see the tissue in between. इसको और.
Ma'am, would you not like to use a myoma screw for
Yes.
retracting it?
Not really, because the job which the myoma screw does, we do with these 4 hands, and at times there are situations where you have a cervical myoma or multiple myomas, then it comes in very handy. And at the beginning, I do not like to put in the myoma screw, because what happens is you have to change the position of the myoma screw many times during the surgery.
Right.
And all those points, they start bleeding.
Yes.
So better wherever, and if you see this right upper port, आपने हिला के दिखाओ, ये आपको ये दिखाना है, it is holding the round ligament. So we use round ligament as the main point, which is tracking the.
It is holding the fallopian tube, madam.
We'll remove them in the end.
Dr. Nutan?
Yes?
Can we please shift to the other OT? It's Dr. Arun Prasad at a critical
Yeah,
step.
and please come to me after, say, maybe 10
yeah,
minutes.
when we will be reaching the uterine, we will be with you.
No, because my uterine dissection is a little new thing. If you can persist for another 5, or you come back after 5-7 minutes, okay?
Yeah, ma'am.
That is the new thing which we have developed. I would like to show.
Please shift video to audio to Dr. Arun. Dr. Arun?
Yeah, can you hear me?
Yeah, we are with you.
Okay, so what we have done is we have torn some of these muscles. If you come here, so this is the first vein of the stomach. This one. So from this level, if you can go zoom inside, you can see some circular muscle fibers.
Yes.
So we have reached the circular muscle fibers, and here what you see, or this white is the bulging mucosa.
Yes, yes.
So now we have got 5 structures here. The right crus, this one. This is the right
mucosal flap.
split of the esophageal muscles. So this is the esophagus. So this is the right side split. Then is the esophagus number 3. Number 4 is the left split. And number 5 is the left crus. So we've got these 5 structures. So the lower part I am satisfied. I just have to go a little more up, go inside, and make sure that this part is also nicely exposed. And after that we will be able to start with our suturing.
We have around 400 viewers that are live on Lab Guru right now, and also on the Facebook and YouTube. So
So you can see the mucosa bulging right till there.
Yes, well separated.
So now if this is 1 centimeter, this jaw, and we are looking at 1, 2, 3, 4, 5, about 5 centimeter. थोड़ा और ऊपर मैं कर लेता हूँ.
Dr. Arun, I shouldn't ask at this critical time, but if mucosa perforates, then what's
30 vicryl.
Okay.
It's perforating the mucosa is not a problem as long as you identify and suture it. So it's very important to make sure that everybody in the OT is looking at it. Anyone sees any hole-like situation, they should immediately point it out, and we should suture it.
So any specific maneuver to detect or to check at the end of the procedure for esophageal perforation?
If you are so interested, then you can do an endoscopy and.
No, sir. Maybe like passing a air from Ryle's tube or something like that.
No, not Ryle's tube. Then you'll need an endoscope and pass air through endoscope only. Ryle's tubes anywhere.
No. What is your protocol?
If we want to confirm, then you do an endoscopy and do a leak test
But routinely you don't do?
Routinely I don't do. No.
Okay.
Also that door fundoplication which we will be doing acts like a serosal patch.
Right, sir.
So if there is a small perforation, that will patch it up.
Right, sir.
But it's not the excuse to leave it.
Yeah. Is the suture ready? Just one sec. 20 will do. 20 level. फिर मोटा है ये.
Sir, what suture you are using for the fundoplication?
We'll use a ethibond, or we can use Stratafix. What do we have? Stratafix or ethibond? क्या है? Ethibond है?
Always non-absorbable?
Sorry?
Always non-absorbable suture you are using for this purpose?
Non-absorbable or something like PDS, which is a long. Vicryl नहीं use करना. Ethibond दे दो. या फिर V-lock. 20 है. Ethibond अगर है तो देख लो.
Dr. Arun, till you start suturing, can we shift to Dr. Jignesh?
Yeah, please go ahead. I'll just tell you what I'll be suturing. Just
Okay.
one sec. Before you move over. What I'll be doing is taking this stomach and this, आप छोड़ दीजिए. This is going to get sutured to the other side, like that. So first I will take a bite, अंदर जाओ, which will be from this part of the stomach here. अंदर. Show me this stomach. So bite goes from here, 1, goes through the crust 2, goes through the esophageal wall 3. So 1, 2, 3, tighten, 1, 2, 3, tighten. Then what will happen with that? This will get stuck here. Then I will take this to the opposite side again. 1, 2, 3, tighten. Then 1, 2, 3, tighten. This will ensure that the muscle is kept apart.
You will take crus in all sutures?
Yes. So stomach, crus, esophagus, stomach, crus, esophagus. And so I'll start the suturing, and you can always come back to see 1 or 2 of those suturing.
Right.
Okay, sir.
Sir, just a question. I'm Dr. Priyank Chilawat.
Hi.
Sir, sometimes we find that the dissection that you are doing right now on the stomach is difficult, and it is very difficult to get the plane at this side.
Yeah, so it can cause bleeding. So you
Yes,
have to
sir.
be
Sir,
little
what are
patient.
your tips for dissecting this particular plane on the stomach?
Tip is to use this. Come back. You can use this and hold the stomach here. Do this. देख रहे हो? अलग हो रहा है फाइबर. जैसे डिफिकल्ट कैलोस ट्रायंगल में आप यूज करते हो वैसे ही. अलग हो रहा है. ज़्यादा मैं नीचे जाऊँगा ना तो ब्लीडिंग स्टार्ट हो जाएगी. So that's the tip. Suture कौन सा ले रहे हैं? Delay ले लें.
Dr. Arun, we will get back to you. And
sure.
Please shift to Dr. Nutan.
Dr. Gandhi. Please shift the
Smoke.
audio.
Yeah. Hello?
Hello, yes ma'am, you're audible.
Okay. So now I wanted to show you something which we are working on, and we are calling is the posterior approach of TLH. Leela, gauze rakho idhar. So if you see, I have done all the pedicles, and now I am on the round ligament. And karo, saaf karo. Now, if I come over here, I'll show you that we can see the ureters over here. And if people who were watching TLH only all the time saw that we have done the dissection posteriorly. And we have opened up till the arcus taurinus, or the area where both the uterosacral ligaments, they insert. So this is that we have opened up the posterior peritoneum first, and as this case has a previous C-section, I will now take you over to the anterior pouch to show that the bladder is densely adherent. So if you see here, this is the cup which we have applied, and this is the bulb of the Rumi. So what we do is, पीछे से करो, अच्छे से दिखाते हैं. So we work in this cotton candy space, and we have to cut the round ligament. इधर देना, जल्दी आके कर दो.
Dr. Nutan?
Yes.
Ma'am, you usually separate the bladder with Ensil only? Yeah, you use harmonic for this purpose?
Maybe I'll use harmonic. इस टाइम तुम्हारा push का time आ रहा है.
Okay, how about, madam, what is your take on leaving the fallopian tubes behind?
We will talk about the fallopian tube later. Maybe at this time we focus on the uterine artery. Okay? I will definitely talk about.
Okay.
Ma'am, what about the cold knife dissection for densely adhered bladder?
So what we are doing right now is the posterior approach, okay? Since it is a little new, let me take time to explain to you what is this concept and how we have started working on it. So if you see, in the posterior approach, we are bang on the uterine artery and the vein. So this is the cotton candy space, and we will try to skeletonize the uterine artery first. We keep working in small nibbles, small steps, small mistakes. Since we are working with Dr. Bhatia since yesterday, so he always says small bites, small mistakes. So here what I am doing is trying to skeletonize the uterine artery and the vein. Okay? Vishram ji, push. So this is the uterine pedicle. आप पीछे से दिखाओगे? Your, So the ICG shows the position of the ureter all the time. And here, before the bladder dissection, I am taking on the uterine artery. I'll explain my concept a little later. The thing is that once we coagulate and cut the uterine artery, the anterior, आगे से दिखाओ, tip, the anterior Meckenrod's ligament is also cut at that same time. So by cutting the anterior Meckenrod's ligament, the ureter gets free and moves laterally. So the first concept is that the plane of the bladder dissection is also the plane of the uterine artery. At this moment, thoda andar karo. If you see just beyond the tip of the ensil, you can see the uterine artery. Is that clear over there?
Yes. Yes, ma'am. Yes.
So once I take the uterine artery, and just uske upar agar aap dekhoge, has a plane which is quite easily visible.
Ma'am, this is the artery now you have taken, right?
Then the plane of the uterine artery is the same as that of the bladder dissection. Secondly, once we cut the uterine artery, it takes the ureter laterally, increasing the distance between the uterine artery and the ureter. And third point I'll describe when it comes.
Ma'am, can we just coagulate and leave it here? We don't cut. We try and coagulate it and leave it here, where it is. So there will be lesser bleeding.
थोड़ा push करने का time. So it's a big uterus. There could be more bleeding. So I'm just taking a little, cleaning the posterior one more. Now if you see that this is the uterine artery, okay? Everybody clear?
Ma'am, I'm just saying.
I'm just not answering your question at the moment.
Okay.
Please see what I'm trying to show, because it's a relatively new thing. Your questions will be definitely answered duly. Now you see how we are getting into the plane after cutting the uterine artery. Do you see? Now this is the cup. Push. So this is already the cup. And if I keep moving in this, I will get the good plane of bladder dissection. Now I want my harmonic. Harmonic please. ये इसको और ले लें. So this we have named as the posterior approach of TLH in difficult bladder dissection. Change to harmonic. So I'll just show you how what I mean. इसके अंदर से दिखाओ. So now what we say is, now this is the uterine artery. Try to show better. इसको नीचे करो ना. Try to go in. कर रही हूँ. ऑन नहीं है शायद अभी. हो गया? So now if you see where that I am activating the harmonic. So but if you see, so now, yeah, please just give me 2 minutes more, because I want to finish the uterine artery part dissection, and that is the main idea of taking a TLH with previous surgeries. Okay. So now if you see that this is the cup, and we've got clear the plane of cleavage of the bladder. विषम पुश करते जाना है ना. स्मोक. चलो अंदर. Now if you see, just see this cotton candy plane. Without doing anything, the bladder has already, you've got a very good plane of cleavage. अंदर दिखा सकते हो? Try to show inside. Yes, with just one more cut, you will see the plane properly reached. Look. Now come in. Push, push.
Can we please shift to Dr. Jignesh
Sure,
for a while?
please. Sure.
Yeah, thank you.
Yeah.
Dr. Jignesh?
Yeah, I was just wondering, people have a lot of interest in hysterectomy. The surgeons here are doing a lot of hysterectomy. That is what I could infer.
There was conflict of interest.
Yes. I know, I could make out, and with 3 gynecologists on the podium versus 2 surgeons, they took over the scene completely.
Yes, as expected, sir.
Yeah. So what I was talking about was,
sir, camera is slightly rotated. Please make it in a way.
So just please tell us the planes.
ऊपर से आइए, straight आइए ऊपर से. I'll just revise the anatomy quickly. What we have done so far. Straight आ जाइए ऊपर से. इधर से आइए straight. नहीं और आगे आइए. या और आगे आइए. ये देखो इधर ऐसे. So can you see this? Okay?
Yes, sir.
So this is the head end of the patient. Okay, this side is the head end. Okay.
Yeah.
This is the leg end of the patient. All right.
Right.
Now we are onto the right side of the patient, and on the right side of the patient, this was like this. Okay.
Yeah.
Now what we did was we held the entire rectus in our hand, and at one point when you hold the rectus, go 1.5 centimeters lateral to that to make the first cut for the anterior component separation technique. So when you make the first cut, what you should see is this fat below. Can you see there is a little fat here on the muscle?
Right.
Yeah. The moment you see the fat below, that means it tells you that you are in the right plane. Then we lifted up this plane.
Right.
Okay. And here, what I am seeing on the roof is the EO. Okay. Peanut.
Yeah.
And on the floor, and you can see the purchase of the tacker.
Yeah.
See how deep it has come. And here, this is an avascular plane. So just gentle traction, counter traction, and I'm just going laterally, and I'll show you where we are going to end, because a lot of people ask ki, usko, where do you stop?
Right.
So you stop at a point where you will start getting the intercostal and the blood vessels coming from the retroperitoneum. So you can see this. This is a very, very avascular plane. Can you all appreciate that?
Right.
Can you see this?
So there are no perforating vessels in this area?
Nothing, except that it comes very laterally, which I'll just show you now.
Right.
And when you come at that lateral end, that is where you're going to stop.
Right.
Okay?
Sir,
so you can see this external oblique going up, going up.
So suppose this patient has undergone colostomy previously and there is a colostomy scar
so
in
you'll have
between.
to go around it. You'll have to go around it. You'll have to go
won't
around
that compromise your dissection?
No, it doesn't. It doesn't.
Right.
You'll have to go around that hole.
Right.
It's a little tricky to understand in the third dimension, but you have to go around it. Now, can you see the vessel coming in there?
Yeah.
In the depth here? This one there?
Yes, it's there.
Can you see this?
Yeah.
So just stop there. Okay?
Okay.
And here you have got enough lateralization and the medialization of the pedicles. So with this, what has happened is this entire component has started moving forward. Can you see that?
Yes, nicely it has come.
So this has come here, and actually I can do an overlap.
Right.
Can you see that?
Right.
Now this defect was almost reported as 7 centimeters. Ellis forceps, and I'll just show you one more Ellis.
You will do separation on one side only?
No, we did on both sides.
Okay.
This is the opposite side.
So
I want to go home early, so I'm doing fast. Ellis.
Jignesh, for 2 minutes, can we go to Dr.
Yeah. So I'm just showing the medialization, so you can see this. Can you see that?
Yeah.
And I'll hold this like this. So another thing before I leave,
right.
I'll tell my assistants to hold with 4 Ellis forceps on either side, and we wait for 5 minutes and check the peak pressure.
Okay.
That time, if my anesthetist says that peak pressure is okay, the difference is less than 5, then I will start closing it.
Okay. Otherwise,
what happens? You close it, and then the anesthetist says, sir, peak pressure is 29. Now we will have to again open up the whole thing. So this is what I say as a pseudo closure. You know, you have to do a pseudo closure and wait. And now the mesh will be coming in this plane between the EO and IO on one side, all the way till the opposite side. So I will tell you when we come to that step. Okay.
So can you, sir, please show us the upper part of the section as well?
Yeah. So upper part of the dissection, we have gone almost up to the costal margin. Can you see the costal margin outside? I have gone till here, and I can still go in the chest. So if my defect is higher up,
to
say a
costal margin.
post-CABG hernia, I can still go higher up till there.
And lower margins are up to?
Lower margin here I have gone till the ASIS.
ASIS, right.
Because the defect is here, we don't want to unnecessarily devascularize too much of flap.
That's
An important point, which I mentioned earlier, is if you see my flaps, if you see my flaps here, I have gone flush and below the scar pass. Can you see there is hardly any fat on that top of that?
Right.
So remain below the scar pass fascia. Okay? Then your chances of lipocutaneous necrosis practically goes away. And there is another thing called SPIFE, which is an open ICG, which we have already published a paper in World Journal of Surgery. Is you give ICG and you can see for this flap vascularity, and you can keep on revising it. So your lipocutaneous necrosis still goes down.
Right.
Okay. So we have done ACST on the right side, ACST on the left side. I will now close the defect, and then we will go for the mesh implantation. And before that, we'll just do a little bit of superior dissection so that we have a superior overlay. Okay.
Right. Sir, suppose
for 2 minutes, I will go to Dr. Arun Prasad's side.
Yeah.
Dr. Arun Prasad is
no problem. No problem.
His, yeah, just Dr. Arun Prasad, please.
Hi, can you hear me?
Hello.
Can you hear me?
Dr. Arun.
Can you hear me?
Yes.
Okay, so this we are just coming towards the end. What we have done while Jignesh was nicely showing us the anatomy was I have sutured on the left side of the patient. Idhar dikha do. So there was a bite which was from the fundus to the crus to the open esophagus. Now you can see this balloon here.
Yes, it's bulging.
With the blood vessels under now. This is balloon sign.
Right. Yes.
Now also, you know, this is nice and distended. अगर इसमें छेद हुई होती ना तो balloon collapse हो गया होता. So that's also one feature, so suggesting that we have not made a hole. Come back. Now, so the left side of the patient has been sutured. Now I will just show you one suturing of the right side, after which you can go to another OT. So this is a bite taken from the fundus here. So it's a 3-point bite. Fundus, esophageal wall, go inside.
Dr. Arun?
Esophageal wall and crus. Yes, sorry.
Dr. Arun, you usually don't take the apex till you have cut?
Sorry?
That's the myotomy you have done.
Yeah.
At the, you don't take apex in the suture?
No, no, no. I am just suturing, I am doing an anterior fundoplication.
Okay.
So now, this is a 3-point bite which has been taken. Show me the tail. And you may have to help me. So, my assistant will hold the with the grasper, the stomach there. So that is what will complete. So you need to hold here.
Dr. Prem, yeah.
Yeah, and take it there, so that when I tie my knot, there is no slipping off. This is fine. I think this should work. Not a problem. So in 1995, Dr. Bhatia and I were together in the early days of advanced laparoscopy. I remember we had done a lap sigmoid colectomy.
I know.
You remember?
Much blood has flown under the bridge.
Just stay there. Very nice.
And this for this, Arun, you will always use Vicryl?
No, this is Ethibond equivalent made by Medtronic.
All right. But it is violet
This
and
is
Vicryl color.
Yes, this is polyester braided.
Yes, I was surprised.
So you thought it's Vicryl?
Yeah,
Yes,
I
it's
thought
good
that
that
was
you asked the question. And again, for the audience, this is not Vicryl. This is braided.
Non-absorbable. Braided, non-bladed, non-absorbable suture.
Okay. Now we need the. Give me the scissor. आप पकड़े रहो. मैं scissors मैं ही cut कर दूँगा. ये ले लो.
Dr. Arun?
Yeah.
Till you suture it, can we shift OT to Dr.
Yeah.
Nutan?
Okay. So that would be one last suture, and then I'll remove the gauze piece. I don't think you need to come back to me. Please carry on.
No, we'll come back to you
Okay.
to give round blows.
Thank you very much. Good job, sir. Excellent.
Please shift audio video to Dr. Nutan. Dr. Nutan?
Yes.
We are with you.
Yeah, sure. So I waited for a while because I wanted to show one of the concepts that once we tackle the uterine artery, then we were able to open up the cotton candy space. I think those who were watching, something like this was opened up, okay? And the bladder was still stuck over here like a canopy. And beneath that, we found the way to dissect the bladder. So this was a very densely stuck bladder, but with very ease of adhering to that third principle, that the bladder is adherent more on the top and less adherent at the level of the uterine manipulator. So this posterior approach is based on these three, that the plane of the uterine artery is the same as that of the bladder dissection. So all of you will see that these 4 ports are making the surgery easier. The uterus is large, but we are able to maneuver it even without the use of any uterine manipulator. So now we will just show the posterior approach on this side, maybe it's easier. I'm now using the harmonic only for retaining the ovary. And the second principle is that once we cut the uterine artery, the anterior Mackenrod's ligaments are released. Okay? So by that movement, the ureters move still more laterally, making way for a safe ligation. Ligation of the uterine artery we have already done, but the ureters also move more safely, opening up the plane of the bladder dissection. And the third concept which I said, that the bladder may remain still adherent on the top, but we are able to find the cotton candy plane beneath it. Now if you see, almost the hysterectomy has been completed till this end, and we will just show you here, maybe it will be easier on this side, once we have dissected, how we approach the posterior leaf of the broad ligament. Green kar do.
Dr. Nutan?
Yes?
You mean to say if bladder is adherent anteriorly, then go from the lateral side?
No, I am not going lateral. That's what I am trying to show you. If you persist for 2 more minutes, I'll just show you. We are calling it a posterior approach.
Okay.
Because we are not going lateral first. We open the peritoneum. छोड़ दो, इसको आगे से पकड़ो ना.
But ma'am, on this
Yeah.
side you've not.
Look, I'm doing an articulating action of the end-seal. For a bigger uterus, it is easier to approach on the other side. And all this green is the ICG, which only helps to, yeah. So now I am taking the round ligament also. Again, if you see, the bladder has been totally mobilized. Even the uterine artery in still smaller uteri can be exposed and skeletonized on the contralateral side only. Usually I do the left side first because I am standing on the left of the patient. And the benefit of ICG, you can see the ureters are continuously in view. So in big uteri, you don't have to keep looking for it all the time. So after the round ligament, I say, take one more pedicle, okay? One more after the, इसको आप गिराओ ना, हाँ, keep showing the Vishram, push, now back, इसको उठाओ, ovary, so that they can see how you can, how we open up the posterior leaf. Push, start pushing, push जैसे जो खुलेगा तो एकदम दिख जाए, push to the maximum. Now if you see, as I come back, do you see the, मेरे ना harmonic दे दो, just stay on over here. I'll just show you if you stay on for 2 minutes, how we do the posterior approach. Now, let's focus on this posterior leaf of broad ligament, okay? White is always right, huh? Dr. Bhatia, if he is listening, he'll find that I'm a good learner. Few of his concepts, I didn't know, but I learned from you. White is always right, huh? Idhar lagao bachche. हाँ, you are always right, huh? So we are just following the posterior leaf, and you can see the green glowing ureter all the way. And here, I'll just open up the posterior leaf. Oh, sorry. वो green बंद कर दो. Yeah. So we have seen where the ureter is. So I'll just open this posterior leaf, and now my assistant will insinuate his grasper. Can you see the uterine artery already there? Hello?
Yes, we are there.
In the audience, you can see this uterine artery, which I am pushing medially.
Yes, we are getting it, ma'am.
So here, here, and I just strip it off more. So one of my old saying that uterine artery is like a cabaret dancer. The more you strip, the better it is.
Better it is
Yes.
twisted.
So ये तो मेरा 20 साल पुराना dialogue है. So I am now opening up the posterior leaf, okay? I have not done anything laterally, if you see. Andar aao. Just show them the uterine artery, the pulsations and everything. So this darker one you can see is the vein. एक single jaw लगाओ. Yes. And he retracts it and I push it medially. I'll do it once more. इधर वाला दिखाओ थोड़ा. Yeah. So now this is ready to go. Do you all agree in the hall?
Yes, ma'am.
हाँ?
Yes, ma'am.
या आगे
Yes,
से
ma'am.
देखो. ये. So should I change to NC? करते जाते हैं. We try to take the entire bulge. It may not come in one go, so I'll do it. Now in harmonic change to 3. 2 or 3. So somebody was asking me, do you do the uterines with harmonic? मेरे पास करो. हाँ. So we can increase the coagulation mode to 2 or 3 when we are dealing the uterine of such a big uterus. थोड़ा ऊपर घुमाओ. Show the big uterus.
You are taking the Mackenrod, part of Mackenrod also along with the uterine, Dr. Nutan, in this one?
Yes. Once we do the uterine arteries first, we take the anterior McInroth ligament along with the uterine artery.
Okay.
So, and there is a saying that it's the ureter it is the uterine artery itself which binds the ureter to the uterus. So once we take the uterine arteries, along with that the McInroth ligaments are also taken, and the ureter gets released, moves more laterally, and that is why we have been doing this technique for last 5 years at least, but we thought of now popularizing it since we are very convinced about the safety.
Okay.
And last year when I was chair for the AAGL TLH course, that is the best or international organization for endoscopy. So as a chairperson, I had the right to show new concepts, and then we had shown and talked about it, showed the videos, and it was largely upheld by the international community also. Piche hatao. Bipolar. It would have been better with the मेरे को bipolar का चाहिए foot pedal with the NCL, but you know, in changing over of instruments, पीछे करो, the peritoneal surfaces are lost at times.
Madam, can we shift to Dr. Jignesh
Sure.
for a while?
Sure.
Thank you.
Because the concept has been.
Dr. Jignesh, please.
Thank you for coming back to me. Yeah. So, what I was trying to teach, again, if there must be some postgraduates in the audience,
Yeah.
that when you take the closure stitches, you have to take only a single layer closure. Preferably, you saw that we did 2 sutures. Can you see this? Because
Yes.
the length has to be 4:1. So, how do you know? You don't actually calculate 4:1.
Mhm.
Important is that when you are going halfway through, you come to know that you are now going to get a little bit of struggle. And I have seen sometimes that people take the smallest possible thing and they will suture, try to do this. And every one of us does that, isn't
Yes,
it?
yes.
And then you give that needle to the sister to tell that I am the most cost-effective surgeon in Haryana,
Right.
isn't it? But I'll tell you, by doing that, there's a big lecture I can take on that. 20% incidence of incisional hernia.
Okay.
The next time you're going to do this, remember you are making 20% higher chance that the patient will develop a hernia. So open up another foil and do that.
Right.
Next important point, when you're doing the closure, especially for the youngsters, you can see my hand, you know. When we suture, our hand is always like this. It is not like that.
Okay.
So when you take one of the edges here, okay, 1 centimeter, the default, what happens is that my hand tends to go this way, okay?
Yes, yes.
But you have to turn this way. Can you see that?
Right.
Because if I go this way, this is 1 centimeter, this is 1.3.
Right.
1 centimeter, 1.4. And this is the area where you will have maximum problems and the patient can develop a burst abdomen. So here,
Very
you can
important
see
point,
that I have turned my hand, okay?
Yeah.
Small point, especially for the juniors, not for the seniors in the audience, but this is something I take a talk on science of tissue management for abdominal wall closure, and this is where I emphasize this point. And look at this. Again, where is he assisting me? See this? Yeah?
Yeah,
And
yeah.
see how we have formed all that guchara. So what I told him was leave it, that he should assist me over there, here. Now can you see how we are away?
Yeah.
Small things, but they matter a lot. So we use a skin hook in our hospital, and one of my assistant just take the hooks and takes it away.
Right.
So that this doesn't happen. Because if this happens, then you're caught.
What all tissues you are taking in the closure?
Yeah, so we are just doing the anterior closure, anterior rectus sheath on both the sides.
Rectus sheath only.
Rectus sheath only. I'm not taking the muscle at all because here anyway it was thinned out.
Right.
Okay.
And peritoneum?
Peritoneum is no, we have already depressed it down.
Okay,
So
that
I
is not
used it-
included, right?
Yeah, so peritoneum should not be included. I have put the peritoneum down. Here I have come on this side. Now I am going to go reverse. Okay. Now this stitch, before I tighten it, I usually just tend to make it loose. Okay, leave it. And I'll just see that there is nothing below, but we have put one more layer. So you remember the peritoneum which was here?
Yeah.
So what I did was I flipped that peritoneum inside onto that bowel. So we made one more layer and then we have done this closure.
Right.
Okay. Now here again I would just highlight this closure technique quickly. Can you cut this here? Again for the benefit, because you know these are the strategies. You know we should prevent the hernia
You'll have to go
rather
there.
than creating
Or
one.
You can go there.
So again you can see there's 1, 2 and 3. Okay.
Yeah.
And then I'm putting my knot. Okay. Now here I will keep on, you know, going in a different way,
Hello.
different angles. So about 5 or 6 of
Dr.
them.
Dr. Jignesh.
Yeah.
You have a question from audience.
Yes.
I'm Dr. Umesh Singh from GMC Patela.
Yes, sir.
Sir, I have got 2 questions.
Yes.
First, this is a release very popular in midline incisional hernia.
Correct.
What about if we have a big hernia in open cholecystectomy incision?
Subcostal.
Subcostal, yes.
Yeah,
very,
so
very big hernia around
yeah.
with the defect of around 9 to 10 centimeters.
Correct. So subcostal hernia, there are two approaches. One is you go from the same incision,
Right,
okay,
right.
and you do a TAR. Not impossible, but it needs a little learning curve. Second is we go through the midline and then we consider this as a defect and then do a TAR. And nowadays what we have started doing is a reverse TAR, because the role of onlay is only limited to about 5 to 6 centimeters. The moment you have 8 to 9 centimeters hernia here, your mesh overlap will go almost till the chest. So you will have to do a lot of mobilization laterally into the subcostal area, okay, here in the chest. So options are TAR through the same incision, go from here pre-peritoneal and then do a TAR on this side, and then you can go into the reef stopper on the opposite side. But someone who is learning can just take a midline and then you can go. The only problem occurs is that when you have a midline here and one scar here, this zone becomes a relatively challenging zone. So again the trick there is remain flush to the scar, below the scar pass.
Right, sir.
Okay.
So we have to go from the midline incision only.
Yeah. But if you are learning for the first time, then that is a good idea.
Right,
Now here you can see that I have already put the knot. Now the next step is, I will tell my assistant to cut this. So you saw that loop part, he has kept it like this. One end comes from here, one comes from here. Is everyone with me on that?
Yeah.
Okay. So we come from there and now I will pull this together. Okay. So this will reinforce my scar there. Okay. So whatever knot I have taken will be either cut here.
That knot will be buried inside, huh?
Yeah. So we will just take that anyway. We will have a lot of fat there, and interestingly, just to show you, for all our enthusiasts, wait.
Sir, my second question is that up to what maximum defect can the star be helpful in midline?
Up to what maximum?
Maximum defect.
Size of defect.
Size of the defect. Like if it is 20 centimeters defect.
Sir, it is not about the defect size, it is all about the loss of domain. So if you have a 20 centimeter defect where the contents about more than 25% are out of the tummy on the CT scan, where we calculate by doing a Tanaka index, then this patient will require a preoperative optimization, and the optimization would be in form of doing a PPP, progressive preoperative pneumoperitoneum, or you will do a Botox. So it is not about the size, it is about how much is coming out of the cavity. If it is more than 25%, so some centers use 20%, some take 25%, and if the 25% is out, if I try to push it inside, I will develop compartment. So size is not a problem. So even if it's a 20 centimeter, I will still do a bilateral TAR and I can get away with it. Not a problem. Or an anterior component separation, I will get about. And you can still see that this is looking nice and pink. Yeah?
Yes.
So the edges are fine in spite of raising the flaps because we were there.
Thank you, sir.
Another thing to show is the tacker. Can you see the tacker has come in the subcute here?
Yeah.
Can you appreciate?
Yes.
So all of us who are those enthusiastic tackers, we should be very, very careful. You can see it is lying in the subcutaneous area.
Right.
Okay, we are going to take it out, but just for the information that the tackers can reach at any level, any distance.
Okay.
So
in thin patients, they can reach up to skin also.
Absolutely, and then sometimes you are in worry that what is going to happen there. Okay.
Right.
So we will change the gloves. I'll just paint this area with betadine, and then we will try to put this. And now the peak pressure, anesthetic, 21. So we started with 19, and the peak pressure is 21. Okay.
Sir, if it is 26 or 27.
Yeah, so if it is 26, 27, I will still do a lot of mobilization above. Okay. I will still do a mobilization below. But if it is 21, the difference is just 3, we are all right.
So you will manage with mobilization alone if it is high pressure?
Yes, so your mobilization will be still, so here you can see that I have gone till here, okay?
Yeah.
Can you appreciate? But this one, I will keep on extending the cut, and when you are doing an anterior component, you keep coming medially like this.
Right.
You don't go laterally, you keep coming medially. So we have done like this and this way, okay? And here you can go up to the 5th intercostal space, because the EOS goes almost up to there.
Right.
Okay?
Right.
Right. So now we will change the gloves,
right.
and I'll put in the mesh. So we are going to use a 30 by 30 mesh.
Right.
And when I come to the mesh, I just want to show you what do you mean by anisotropy of the mesh.
Right.
And how do you fix the mesh? I will just show you that as well.
So meanwhile, we will like to go to Dr. Arun for a while. Yeah.
Yes,
Thank
sir.
you.
Yes, sir. Thank you.
Dr. Arun, please.
Sir, with this, I would like to thank the moderators for the morning session. Just a second, sir.
Dr. Arun?
Yeah, hi.
Hello?
You have completed the surgery?
If you want, I can show you the final view.
Yes, sir.
You want to see the final view?
Please,
Trocar?
sir, please.
Okay, Trocar.
Yeah.
De do. Give me the 10 mm Trocar. De do. Ye laga lo ek second.
No, there is no need. We have seen it till end.
Okay, okay.
So we just wanted to give a word of appreciation in form of claps from the audience. So
Thank you, Dr. Smith. Thank you very much.
Thank you, Arun sir.
Thank you, sir.
I would like to thank the moderators for their contribution in this session, and I would like to invite the moderators for the next session.
Thank you.
Thank you.
Dr. Satpal Bhanot sir, Dr. Pankaj Hans, Dr. Kunal Chaudhary, Dr. Rajat Kelkar, Dr. Mukesh Sangwan sir, Dr. Ajay Chikaro sir, and Dr. Viking Bhanu sir. Kindly join us on the stage for moderation of the sessions.
आप कह दो अगर गायनी को दे सकते हैं तो हमारा खत्म ही हो गया. Hello.
Hello. Yes, ma'am. We have a
Yeah.
new set of
So,
moderators
yeah.
with us.
Okay.
And we have been
Fine.
seeing your surgery on the side screen.
Oh.
Yes, ma'am.
Blue done. So now, since it's a very large uterus, we have finished the TLS part, and I would just like to show the that now the uterus becomes absolutely white. This also shows that both the uterine arteries and the leash of blood vessels, which are all together form the uterine artery, they have been coagulated. So now I will go for the, now the plan will be that first we will do the colpotomy, the circumferential colpotomy with the help of some bit of monopolar and harmonic aids. Then we will have to do the morcellation, remove the uterus. The colpotomy first is needed so that it doesn't bleed. Harmonic भी लगा हुआ है ना? चल, इधर का cup, where did we see? So we have a blue colored cup. And if we detach the uterus from its attachment in the body completely, then while doing the morcellation there is no bleeding. So that is why we complete the colpotomy first and then we go for the morcellation. So this is the cup which will appear shortly. Shall I push a little? Okay. So I'll first take the superficial layer. इधर से आओ.
So excuse me, we have few announcements. We have created a selfie point at the reception area. I would like to request everybody when they leave they can have their pictures or a picture with the team. So later on we can send you on the Google Drive. So your pictures will be sent on the Google Drive. And we are not serving tea and coffee in the restaurant area no more. So I will request everybody to have their tea and coffee on the first floor of this premise in the exhibition area. And the third thing is we will serve lunch at 1 p.m. and for the day there will be no coupon. So you are all invited.
Foot pedal for monopura करती हो जब तक आ रहा है. कोई जना foot pedal नीचे से. Okay, Vishra. So we do the anterior colpotomy first, and then since it's a large uterus, a little clumsy to move around. So, but if you see that popular concept that even in large uterus, whatever enlargement occurs, it appears over the round ligament. So basically your surgery still remains at the same pedicles at the same point. Only if you have broad ligament cervical myomas, then the course of the surgery changes. So monopolar, foot switch है. अब रहने दो. So there will be a little bit fuse, but I am using here they have provided me a Achalasia smoke evacuator. It's very high setting. Need to be very careful.
So audio shifted OT3.
Yeah. हाँ कुछ कम कर दो.
Are you with me? Hello.
Yes, sir.
इधर लो.
Yeah. So this is a 30 by 30 mesh from Healthium. Okay. Now every mesh which comes, I don't know how many times the surgeon has actually seen what is known as an anisotropy of the mesh. So Prolene meshes are of two types. The original which were made in the past, they were woven mesh. And the problem of the woven mesh is that if I cut the mesh, then the fibers will start coming out. Now is a concept where you have knitted mesh available, knitted mesh. So the knitted mesh, even if you cut, they are alright. So most of the companies today will make a knitted mesh. Now this is a square, but if you can see here, can you see this? I am stretching this. It is getting stretched. Can you appreciate? Yeah, it is springing. Can you see that in the audience? Hello? Are they with us?
Sir, head table से बोल दीजिए.
Hello?
Yes.
Yeah, can you see this mesh getting stretched?
Yes, sir.
Yeah, so this is a stretchable side of the mesh. And if I go this way, this is relatively stiffer. Okay. So the stiffer side should always come transversely and the flexible side should come craniocaudal. This is known as an anisotropy of the mesh. That means linea alba is more flexible craniocaudal, so the mesh also should be coming this way. If you put it this way, nothing will happen. But your patients, you will always see one or two of them saying, I feel some foreign body sensation, some stiffness when I am doing an activity. So that means you are placed in the wrong direction. In the groin, when you are using a 15 by 15 and cutting it, the anisotropy, the flexible side should be coming this way. So next time you open up a 15 by 15 and try to cut it, see which is the flexible side. That flexible side should come parallel to the inguinal ligament and the vertical side should be the stiffer one. That is known as anisotropy of the mesh. So is everyone very clear on the anisotropy?
Yes, sir.
Okay, yeah, good. So we will be putting this mesh inside. We have changed the gloves, we have painted the area. So one of the leaves now will be coming beyond the mesh there, artery forceps. So we will go beyond the anterior component separation. And then I will show you what do you mean by physiological closure. Can you hold this? Yeah. So I have done the dissection till there. Right now I will be just placing the mesh without cutting anything and then we will do the cutting part. So this is where I have put it inside and now I will tell my colleague, I will retract and he will put it on this side. Just go beyond the flaps. Now raise this artery. Yeah, and tuck it inside. So he is going to now put it inside there. Can you see how it has got completely accommodated inside? And obviously we will be trimming it. Okay? Can you see that? Is the audience with us? Or everyone has gone for food?
Yes, sir. Yes.
Okay, okay. हाँ तो बताइए ना. मुझे लगा छोले भटूरे वापस शुरू हो गए क्या? कल से विनोद छोले भटूरे ही खिला रहा है. पकड़, पकड़. So here you can see now. So what I'll do first is I'll trim off whatever is the extra part of the mesh which is not required, and I will be suturing this edge. Can you see this edge here? So this edge we will be placing it there, and I know. So I will be suturing this edge all along in this area. Did you appreciate that? Okay. So this will be sutured from below all the way there. We will be splitting this up mesh there. We will make a part of the cut here which is remaining and put this part only. Okay, on both the sides. Can you retract this? Can you give me a monopolar? Drawings दे दीजिए दो. Drawings एक इधर डाल दीजिए. Yeah. Can I get a monopolar please? Any questions from anyone so far? Light please.
So you are so clear.
Thank you.
There are no doubts.
वो बोलते हैं ना एग्जाम में कि if there is a silence, that means you have understood everything or nothing.
Here we are the everything people, sir. I think.
Thank you so much. So this part will be coming in there. Okay, this is where we'll, and I usually don't like to fold any mesh there. So at this corner, I'll be splitting up the mesh and cutting it. Scissors. Yeah. Okay. So this is where you can see that I've done that. Okay, this part will go into that corner which we have dissected below. Okay, and now I will be start suturing from here. Prolene. Now again in the suturing I want to show you one technique. Hold this. Can everyone see this? Can you focus the light please? Can you see here? Forceps.
Can you please zoom in?
Yeah. Adson forceps. Adson. So I am taking the first loop there. Okay, ये needle holder बहुत बड़ा और बहुत भारी है. एडसेंस अगर मिलेगा तो अच्छा है.
कैमरामैन Kindly zoom in.
Can you zoom in here? Artery. छोटा वाला. I don't know why is he. सर आप बॉम्बे आएंगे मेरे साथ में, चिंता मत कीजिए. The OT team here is fantastic. I must just congratulate Dr. Batra and the entire team here. So you can see here, I am taking the next stitch. Can you see that? Just pulling up the sheet there, and I am taking the next stitch. Now when I am taking the next stitch, our normal tendency is that we will pull out and go to the next one. But what we should do is keep it there and just go through that area again. Did you appreciate this?
Yes, sir.
Yeah? So with this, what will happen, I'll show you.
So you will be taking continuous sutures?
Yeah, I'll be taking continuous. So can you see that? There is no curling up of the mesh. Because this is locking like a stapler. We'll just go ahead to see, so you'll appreciate it more. Again, he has forgotten that he's supposed to lift up there. Yeah, I'm changing his practice. In one day, we cannot change the practice. So again, you can see this lifted up there, going into the mesh, lifting up there. Again, for the benefit of the postgraduates, just see that my movements are all happening only at wrist joint. You have not seen me doing this during the surgery. So you should not move your shoulder joints as surgeons, laparoscopic surgeons, only lumbricals and wrist joint. Can you see this now, what is happening? It is getting locked.
Yes, sir.
And there is no wrinkling. So it will ensure that the mesh is flat, and more flat the mesh, the better MTI. MTI stands for mesh tissue integration. Okay, so this is another term which all of you should know, MTI. So you can see here again I am holding this, going from the same point and again lifting it up. Can you see this, how it is coming up? So this is the way you are supposed to fix the mesh all around in that area. And we will be putting in a Jackson-Pratt drain in this area. So we put the mesh according to the anisotropy. Again, important point I will emphasize when we are going to do the fat closure. So you can see this, I am just bringing in there physiological and doing this. Okay. And why I am trying to bring it here is because this is the way it is supposed to be lying there. Okay. Can you see that? Because I want to keep it physiological tension so that there is no crumpling of the mesh. And part of the lower layer flap is coming up. So you can see that we are just moving around step by step. I will tell my colleague to come there so that I can cut this part of the mesh there. Scissors, please.
Dr. Jignesh?
Yeah.
What is the maximum defect you have covered with this mesh?
So the defect of the hernia was around 7 centimeters by 6 centimeters, but we have gone almost about 30 by 30. Just leave it down. So we can cover up with ACST. You can get a mobilization of 8 centimeters on either side. So you can go up to 16 centimeters comfortably.
Okay.
And as I told you that the extent of ACST can be varied from case to case basis. Here we have not been very aggressive in the upper part, but if you have a long scar defect, then you can be a little bit more aggressive. Another thing is what you should do is that you should mark and clip, because you can see what I am doing by implanting this mesh is that I am giving this muscle EO a pulley to hang on to. So at the upper part here, I will be putting in a clip, okay, as a marker. And I will tell Dr. Vinod that after 3 months and 6 months, he will repeat a scan. And you will see that the EO will not undergo any atrophy at all. And how will you identify the EO? With the clip. Okay. So try to do that, because here you can see now it is becoming a single unit. Can you see this?
Yes.
So this is now the new external oblique.
Okay.
Got it? So that is where you have to put in a clip. So you can keep a clip ready. So that helps you to mark and identify. So this is all for your research purpose. You should know what you are doing is right. It is working for the patients. So tomorrow, when you are presenting your papers, your publications, you should have evidence that yes, you can see the clip there which we are marked, and that clip tells us that my external oblique is not undergoing any atrophy. Okay?
And sometimes you find multiple defects in the abdominal wall.
Yeah.
Then the technique remains the same?
Absolutely same. Absolutely
you
same.
connect
No
all
changes.
the defects?
Absolutely. 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 No changes at all. So the defect closure remains the same. The technique remains the same.
So can I divert a bit towards the anesthetist, the
Yes.
peep thing that you are telling, sir?
Yeah, the peak pressure, P-E-A-K, peak.
Peak pressure, sir.
Peak pressure and plateau pressure. Plateau pressure is a direct pressure. So if you do not have a facility for a plateau pressure, then you should tell your anesthetist to give stop ambulating with the ventilator and just give a pause. So plateau pressure gives a reflection of the alveoli directly onto the back area. Yeah, now you can shoot the question for her. Madam, question for you. Madam, the mic de dijiye.
Can we see it on the anesthetist monitor,
Yes,
sir?
please show the.
Because
Please
that's
show
a
where
new-
it is. Yes, you should see that.
That's a new thing, sir. Actually, we never look at the anesthetist monitor, sir.
No, we look at the anesthetist and not the monitor.
Sir.
Monitor.
So can we have a look at that peak
Yes,
thing, sir?
can you show that? दिखा दीजिए, वही उससे दिखा दीजिए. वो कैमरा उधर लेके जाइए. मैडम का मॉनिटर दिखा दीजिए. So every laparotomy from tomorrow, we make a pledge today that we will see the peak pressure, okay?
Sure, sir, sure.
And we will make it a habit, irrespective of whether you are doing a hernia or a perforation. Yeah. Can you see madam's screen, please?
Now it has become 23, 21, 22 around it is like that. Now it is 21. 21,
Can you please
22.
focus it?
Focus कीजिए,
Over
please.
here.
Yeah, 22. What's that?
Yeah.
sir?
22 is the peak pressure right now.
Can you see that peak pressure there?
Peak.
Earlier it was.
It was 19.
Okay, and the difference is of 3 only.
3, correct.
Acceptable.
Yes.
Right, sir.
5 means I have to do some more work. And 10, that means this patient goes on ventilator. Okay?
Okay, sir. Thank you, sir.
Yeah.
Good afternoon, sir.
Yes.
Sir, can we not do the interrupted suturing?
We can do interrupted suturing, absolutely no problem, but over a period of time, we have learned that this technique works very well. So yes, your choice is right. Interrupted suture is also acceptable. It is not wrong. It can be done. You are right, absolutely right.
Okay, sir.
Is that all? No? Scissors? इधर एक सीट डाल दीजिए. And now the current consensus is now again coming up that you use a suture which should be a long-term absorbable. Okay. So slowly what we are doing is we are moving away from polypropylene in this area to using in a PDS. Okay. So we are using in PDS now for many of our patients. So we are using in a 2030 PDS. Okay.
Okay, sir.
Sure. Suture. Needle holder दे दो. Just come like this. Forceps. So interrupted is also fine. It's all up to the choice. आप इधर आ जाइए क्योंकि दोनों वो नहीं कर पाएंगे. Thank you. Forceps for me. But try changing it to PDS or there's a beautiful suture material called Maxon. I don't know how many of you have used Maxon, but that's also a wonderful suture material with excellent property. Are there any postgraduates there?
So nobody is raising the hand, sir.
Yeah, because they know that I was about to ask a question.
So there are 2, sir. You can ask the question, sir.
But someone has to come forward because the question is specifically related to the suture material. So there is something which is known as, what you call elasticity of the suture material. So I just wanted to ask one of them, what do they mean by elasticity? Do they know what do you mean by the elasticity of a suture material? Can anyone answer from the postgraduates?
Anybody, please?
So because that is very, very important in the recoil phenomena, that if the elasticity of the suture material is not good, then you can have problems.
So there are 2 things like elasticity and plasticity of the
Yes,
suture.
yes. So so please ask that question. I was about to come to that. That was my second question.
Sir.
What is elasticity and what is plasticity? Very good. Because for the benefit of the postgraduates, I think we should also keep on asking and clearing all these doubts. What is important today, what we saw was that management of the subcutaneous, and you saw that everywhere I was using extensively bipolar. Okay.
Yes, sir.
So good use of bipolar, and we as training, we have not got used to that concept of bipolar. We were all those surgeons who used to create a lot of fog in the OT. So I will keep this there and I'll use another suture material so that I can finish off this part. Scissors, please. And all the time I keep asking my anesthetist, peak pressure, peak pressure, peak pressure.
It's actually very important to interact with anesthetists.
Yes, absolutely. Not only interact, I even take them for a cup of coffee after every case to CCD.
Okay.
So next time they are very friendly. And I'm fortunate to have one at home, so my life becomes very easy.
So you will be tagging the mesh to the internal oblique also?
No. So we're just taking a little superficial bite of the tissue there. Okay.
Okay.
Again, another habit of the postgraduates I've seen, they do this. Okay, which is a very dangerous thing.
Yes,
there is a paper which has recently published that in the US residency of 6 years, about 51% of the postgraduates had a needle stick injury, and out of that about 7% became HCV positive. So today's era, HIV we have a treatment, but HBsAg we have a treatment, but the moment you are HCV, needle वापस ले लीजिए, you have HCV, you have to start looking out for a liver.
Sir.
Because in 15 years, your transplant is due.
So then how do you mind the sutures then? Such a long 90 centimeters.
Yeah, so just leave it on the field. If you can see that most of the times I had asked for an Adson forceps which this gentleman doesn't have, but normally even I would not like to hold, I will just use with an Adson. You got it? So I would not even hold it this way what I am doing, and again I will tell my colleague to fill it up there, and the moment you can see that I am taking the suture, I will tell you what I am doing.
Okay.
So I have taken the suture, okay?
Yes, sir.
Just leave it loose. Let's let it go in the field. You got it? Don't try to move it in your hands. Scissors. Scissors.
That's a take-home point, sir.
Absolutely. Because, we have to protect ourselves, isn't it?
Yes, sir.
And as a surgeon, our span of working is at least about 35 to 40 years after we finish post-graduation. So those 35, 40 years, we don't want to carry a disease with us.
Yourself before the patient, sir.
Absolutely. So you can see here, I'm just gently giving a tuck and putting it. And you can see the mesh is coming absolutely flat. So this mesh will ensure a good MTI, mesh tissue integration. What this patient had, again to say, is that post-IPOM, whenever you have a hernia, that hernia is known as a margin hernia. Okay?
Yes.
That means if this is a hernia and there was a mesh of IPOM put, okay, like this, right? Because you are doing an IPOM. Now, if there is a shrinkage of the mesh and the mesh moves this way, or it moves this way, and you have the hernia coming back, this is known as a margin hernia. Okay? So post-IPOM, whenever you get a recurrence, it's usually the mesh contraction, and you have this what is known as a margin hernia. Okay?
Sir, despite IPOM, we have seen 2 recurrences in this session only, sir.
Yes. So one of the reasons being is that the patient would have an additional divarication which was not corrected along with that. That is number one. Second thing is that the overlap of the IPOM, and I think it was an IPOM and it was not an IPOM plus.
Sir.
That means there was no reinforcement. Now imagine that you have a hole and there is a mesh put in there and the patient is constantly moving. The mesh will keep on moving along with that. Scissors.
The mesh has migrated into the defect, sir.
Yes, so the mesh has migrated into the defect, the tacker has migrated along with that in the defect, and you can see here that I am trying to go as flush and flat as possible. Are you seeing that?
Yes.
Okay, so no folds for me. I don't like any folds anywhere in the mesh because folded mesh will never integrate. Okay? Yes. And here we went in a different plane. So a lot of times people have said IPOM, and after that if there is a recurrence you do another IPOM. Okay? I feel that mesh on mesh will not integrate. Okay? It never integrates.
Sir, sometimes we have seen a hernia at the margin of the mesh because of tacker.
Correct. So that is because of the tacker also and the transfacial suture also.
Yes, sir.
So a transfacial suture always should be airtight knot. Again I tell them that it should be airtight. It should not be a very rigid knot. Again that can also cause a problem. But this is something which I wanted to show you, that how you close it so that there is no, you can see that there is no wrinkling of the mesh anywhere at all. Are you appreciating that?
Yes, sir.
So this is something which you should start practicing. Again, after putting in the mesh, sometimes we tend to do a little bit of more tacking. So madam, peak pressure for us, please. 22. So we are swinging between 21 and 22. Okay.
But
so we are good.
Like in an inguinal hernia surgery, so they say the mesh shrinks by 40%, sir.
Yes.
Which causes mesh migration.
Correct. So the mesh migration today, according to statistics, is between 27 to 41% in the literature.
Yes, sir.
So the moment I find a mesh in the market, the first thing is I do and I open up and I stretch it.
Okay,
Coming
sir.
to that elasticity.
Yes, sir.
If I feel that after putting it, it doesn't spring back, I will not use that mesh. Even if he's giving me for 500 rupees, I will not use that mesh because that mesh is to be condemned. So there are certain meshes with certain brands which I don't like, and the reason being is that they do not have elasticity. And if there is no elasticity, it will poorly migrate, integrate, and then you can have a recurrence very earlier on. Okay?
Yes, sir. That's a very important point, sir, beyond surgery.
Yes, absolutely. So try to use, don't fall prey to the schemes. कि 200 के साथ 10 mesh free, 20 mesh free, don't fall into all that. Look into what you're going to do for your patient. Because I always feel, and my philosophy, maybe I don't know whether the seniors will agree, for us it may be statistics, you know. In my series the recurrence rate is 3.2, 1.1, but for that patient it is 100% problem.
Yes, sir.
It is another surgery for him. Why should he go another surgery because of your poor selection? Like yesterday we were discussing about a case which Dr. Arun had got referred. Someone had done an IPOM for an inguinal hernia. Can you believe that? IPOM.
IPOM for an
Inguinal hernia, yeah. And now the patient has got a recurrence. How can you do an IPOM? Where will you tack? Just because you want to prove some point, you know, because of some anecdotal paper, it doesn't work that way, isn't it?
Yes, sir.
Yeah. So we are done with this. You can see it's nice and flat there. Okay. And now the next step again, Vicryl 20. I'll just show you that step. Then you can go to the other theatre if required. Again, for the benefit of the postgraduates. My target audience is always postgraduates. I feel that if we catch them young, then we will catch them forever. Hold this like this. 20 Vicryl.
Sir, even the older surgeons should be caught, sir. We are also getting enlightened, sir.
I know. I'm just mentioning for the benefit of everyone. So sometimes it does happen that we take one of those stitches in the subacute and we take along, and then the sister or the brother assisting says ki sir itna acha aa gaya ki skin ki zarurat hi nahi hai.
Sir.
So what has happened on that day by accident is, if you can see here, okay, I am taking the part of the dermis. Can you see that?
Yes. Yes.
Yeah. So I have taken fat, dermis, and then fat. I know approximately I am going to come here, and why I am taking the bite upper part is because I am going to leave in a drain. And here you can see that I have taken fat and dermis. Can you appreciate this?
Yes, sir. Yes.
So it is dermis, fat, fat, dermis. Now look what is going to happen. Come close. So when I am going to close this, can you see the skin?
Yes, sir.
Yeah, it is coming so close. Okay. Now this is what is important when you are closing in the fat. The fat will always require a support of the dermis. So I always like to reconstruct this, and in cases like this we always take a consent that we may have to do an omphalectomy if required. And you can see here I am taking fat along with a part of the dermis.
So which suture are you using?
This is 20 Vicryl. Can you see that?
Do you put Romovac drains also?
We are going to put. This is just I wanted a point which I wanted to show. Okay, so I'm going to put in a drain here. Okay, but what I'm trying to show is that if you take the dermis, then your suture will hold well. And this patient, if I take only fat, then I will increase the chance of seroma formation. Okay. For some reason, if you feel that you have to excise the umbilicus, okay, then there is another technique described where you can go here like this and make a cut this way and create a lip, and that lip will now become your new umbilicus. Okay, can you show me the drain, please? So we are going to use this drain which I had specially told Dr. Vinod. This is a Jackson Pratt drain. Some of you may have used it. Can you see this? Benefit of this is 2A is that this drain has got multiple holes. If you can appreciate there, can you see this? Yeah. So the moment you put it, the chances that this patient will have any kind of a problem will be absolutely nil. So this one we will put it for the lower flap. When I put in the flap, always see inside again, okay, for the residents. In the neck, in the thyroid, they have sometimes even gone into the IJV. Yeah, so always lift it up well. See that you are not into any vessel, and I will come out from there. And this drain will be going in the flap above. Can I get the other one? and I'll just show you how comfortable it is for the patient to move around. So this is the second one. ये clip को संभाल के रखिए. Yeah. Hold this. Can you put from here? Can you put it here? ये वो लगाना है, लगाना. एक clip दे दीजिए. Just be careful. You know where it is? Okay. So this is for the left side flap. Okay. Right. Can you lift up this here? Yeah. मुझे clip दे दीजिए. So I'm putting that clip as a marker. Okay.
Okay.
Just see to it that someone informs Dr. Vinod that there is a clip. Okay.
Sir.
So that when he does a CT scan, he should know that he's going to look out for that. It's a small size clip, so I'm going to put 2. One more. आप इधर से लगा दीजिए. Just put it at the edge. Yes. Yeah, edge पे. Put it with that suture. Yeah.
Sir, where are you
put one more.
putting these clips?
At the upper end. Upper end where I have sutured the edge of the mesh to the external oblique. Here.
Okay.
Okay. Because what will happen is we will trace it from there. So on the CT scan we will see that, and then we know that whatever is beyond the clip is the external oblique. Can we fix this, one of you?
So
While
now-
I'm doing this, cut this. Yeah.
So now that we have a bulletproof abdomen, sir, with the Kevlar inside.
Yes.
Newton's, Jan's point, the Palmer's point, all covered. Now, how do we get a lap poly done on this patient after 1
So
year?
you go through the mesh. You go through the mesh, and again here. Okay.
Okay, sir.
This is the area where Dr. Jain's point she was mentioning. I usually go Palmer's, but I go a little below. But now onwards, I will start calling it as a Jain's point.
Sir.
And I also have a point, so I will reciprocate that. Madam also calls that Gandhi point when she does her cases, and we will mutually be benefited. Yeah. So you put it in this here. Okay. So yes, you can go through the mesh through and through, doctor. Even if you are doing a lap poly, no problem at all. Even if you have done a TAR surgery, you can just go through and through the mesh.
Okay.
Absolutely no problem. Only thing is when you are doing your first Nemo,
Sir.
you do an optical entry and preferably in this quadrant. Okay. Nothing in the other quadrants. Vicryl please. Silk ले लो, number 1 silk. वहाँ पूछ रहा था मुझे. So postgraduates, we reconstructed the umbilicus. Now you divide this into 2, then this into 2. Okay. I'll just show you forceps. So we keep dividing layer by layer. So with that, now since we have put 2 drains, okay. So again you can see this dermis and fat.
Dr. Jignesh?
Yes.
There is a suggestion for this. We can reverse suture so that no.
I agree. So it can be this way also. I agree with you. I was about to mention. So it can be fat dermis, dermis fat. Absolutely well taken point. No problems at all. Can you see this?
Yes, sir.
This is what I wanted to show to the postgraduates. Okay. And that day when they do this, then the sister says, "अरे बहुत अच्छा skin आ गया sir, कुछ लेना नहीं है, sericif लगा दो." But that should not happen by accident. थोड़ा छोटा.
So the
Little
other thing
small.
is,
Scissors. Yeah.
Sir,
Yeah.
I want to ask whether you do a ultrasound abdomen before hernia surgery, and if there is gallstones,
Yeah.
you do a prophylactic cholecystectomy before hernia surgery.
No, so good question. So if you have a gallstones along with that, then most of the times when you ask the patient the symptoms, they will be having dyspepsia, so it is a symptomatic gallbladder stone. If it's a symptomatic stone, then I know that whether there are any previous attacks, there are no attacks, and then in those cases, I will probably plan for a cholecystectomy first. I keep a gap of about 3 weeks, and then I call them for the hernia afterwards. If I am going to do, say, an IPOM procedure, okay? If I am going to do an onlay, maybe a small little dimple in the umbilical area, then probably I'll do it in the same sitting, because I'll just open up there and I will be putting in an onlay mesh. So it all depends on what hernia, how big.
Sir, but if you are doing an open TAR,
yeah,
then will you do prophylactic cholecystectomy in gallstone before open TAR?
No. But having said that, because of the clean contaminated concept, there has been one instance where I had to do in a patient who had a stoma. Patient over a period of time had developed gallstones. So we had to close the stoma, do a quadricolectomy and even a cholecystectomy in the same sitting, and then a TAR. But then that gallbladder is done only by me. I don't give it to any one of my team members because I don't even want a drop of bile to go anywhere. Okay? थोड़ा छोटा cut कीजिए, थोड़ा सा छोटा cut कीजिए. Forceps. So you see now we have divided this. Now we will divide this. Okay? So it is all about division.
Dr. Jignesh?
Yeah.
For the sake of postgraduates, to avoid the confusion, sometimes some resident assists the case and in ward some other resident is there.
Correct.
So make a convention left lower.
Hmm.
Put left drain on the lower side. Then everyone will be knowing which drain is on the lower side and
Correct.
which drain is the upper side.
Correct, correct, absolutely, absolutely, absolutely. So in our institution, what we do is I do a crossover. This drain will cover this side and this drain will cover the opposite side. So they are very clear. Here, because we are going in a one particular direction, I'm mentioning, but your point is well taken, that you may have team of different residents, and I always feel that the closure team should be different than the operating team. So you should have fresh batch of your registrars and everyone, especially after doing a Whipple surgery or a hemicolectomy, who should come and do the closure part. The closure part should not be the same team who has done the resection, because they are tired, they are exhausted, and this is where I start using an Adson forceps, which they don't have here, but I love Adson forceps, and I think that is the best when we are doing the skin closure. Can you see this, how comfortably the dermis is taking care of the purchase on the fat?
Yes, we are getting.
Are you appreciating this?
Yes.
So this is something which I leave to all the residents, and they are so excited, they start doing it from tomorrow, that they will do this dermis fat, fat dermis. Just remember that, one take home from this operation, anisotropy of the mesh, okay. So all these are small points. Now this thing, what I'm doing right now is okay here, taking this small little thing and trying to prove that in this hospital I'm the most cost effective surgeon. But don't do this thing when you're doing in an abdominal clot closure, because 20% incidence of incisional hernia, okay. Some more Vicryl, please.
Sir, audio shifted to OT1.
Yeah.
Dr. Jignesh?
Yeah.
Hello. Dr. Jignesh?
कोई और है क्या?
Shift away.
खत्म हो गया. Hello. So once I've done the skin closure, the concept of corset, I don't know how many of you use a corset, thoda lamba. I always insist on doing in a corset, because what I feel is, and there is even papers on that, that the oblique muscles get nicely compressed like this because of that. So it is not a placebo effect, let me tell you very clearly. And up to what time to give that? I give up to 3 months, which is midway of the proliferative phase of the wound healing. So I give corset at least up to 3 months post-operatively.
Sir, audio
it works very well.
Hello.
Yeah.
So can we shift to the other side?
No problem.
Thank you. Thank you, Dr. Jignesh.
Screw. वो ना नीचे लगाने के ना.
Dr. Nutan?
Yes.
Just completed.
और नहीं लायो वाली. Yes. So we finished the morcellation also, and now we are going to suture the vault.
Intracorporeal suturing?
Yes, intracorporeal.
Always?
Always. Right from the day I started TLH. So because before the TLH we were doing myomectomies, and TLH also we started long back. In 98 I remember the first time I showed TLH in a workshop. So this is a new needle, not new, but for many gynecs it comes out to be new. So what we did after we left with you, at first we did the colpotomy, okay? And
Yes.
now when we do the vault, it's not only the vault closure, it is also the vault suspension. So what I mean is that we take a good bite from the uterosacral ligaments. So if you see here, पीछे हटाओ ये. You come to your own point. So here, you can show the green now. First the uterosacral ligament, and can we have the green of the ureter so that we can avoid having the ureter in the deep bite of the uterosacral ligament. So whenever we have technology, it's not that it is mandatory, but technology comes to increase the safety of the procedure. And all of us are working only to make our procedures safer. So we use this technology very often, and in my theatre I work with that 4K 58 inches screen, which adds to the pleasure of doing surgery. At our age and with our experience now, what we are working for is not to earn, we is to make surgery safer and reproducible, easier for the next generation to take from us. So what imprints we will create and we will leave, that will add to the safety of the procedure. So as we've been talking about the entry, so we've been able to create a point. Now this I will show you. This is known as the 1, 2 and V. So rather than making a P, B or C, I first make a V in which both the strands are in the stranding position and you can easily see. So now we After creating the V, we come from below and take the two throws and the row. Show me clearly. Okay. Then we grab the free end. And in this, I have taken a very good bite of the uterosacral ligament, so that the patient never comes with a wall prolapse. And it's a real folly many times that the patients are complaining of prolapse and mistakenly an abdominal hysterectomy is done. So all these patients in which you do an abdominal hysterectomy for prolapse, they are bound to move around with a wall prolapse. So with the experience of whatever we had, almost 6 years after doing my MD, only I was doing open surgeries, and very early on in the early 90s, we changed over to laparoscopic surgery. So all these years and before also, we did not see vault prolapse in our own cases. Maybe the reason that we always took care for vault suspension. And also you will see shortly that I closed the vault in 2 layers. So when we close the vault in 2 layers, now if you take my tips of suturing, I'll show you that you grab the needle at the junction of 2/3 and 1/3, take a good bite, and before the needle drops, grab the needle, bring it out. You and your assistant is always working as a team, so he pulls it up and you are ready to go. So if you allow the needle to drop, every time you have to align the needle. So here, again, grab at the same point, junction of anterior 2/3 and posterior 1/3. Pull it up, and here now this side, uterosacral ligament. You can again show the ureters. Green please. And yeah. ये थोड़ा सा लाइट हटाओगे?
Sorry to interrupt, ma'am.
Yeah.
Can I ask a question, ma'am? I'm Dr.
Why?
Bhanu. I am Dr. Bhanu from Kullu, sir. Kullu, Manali, Himachal Pradesh, ma'am.
अच्छा,
I've
okay.
come all the way to see your surgery, ma'am.
Right.
And I've been following you for last 14 years.
Okay.
Ma'am, my question is
बंद कर दो.
Hello. The
Green
audience would
off
also like to know which suture you are using, the needle length, the length of suture, what you have put in, and
Okay.
by which port or per vaginum, how
Sure.
did you put it?
We can show you. No, I did not put it per vaginum. We always introduce the needle through the lower left lateral port. Okay.
That's
And
a 5 mm port, ma'am.
5 mm port, but this time it was 15 mm for morcellation. So I have
Okay, ma'am.
हटा लो, इसको suture पकड़ लो. And then I am using 1O Vicryl. The code for J&J is 2517. And I have not switched to barb sutures at all.
Okay.
Because barb sutures are at times incriminated with bowel obstructions or few other side effects. So in TLH, we've seen that we did not have wall descents, we did not have any wall prolapse. So all these reasons they tell me not to change my suture material, at least in छोटा रहेगा.
Ma'am, any difference in doing it by V-lock suture?
V-lock has barbs on the surface, okay?
Yes, ma'am.
So at times there have been literature report, and I can cite you one workshop where there were about 100 participants only, and 3 of them told the stories that they have had a small bowel obstruction because the bowel comes and adheres to the barb. So for this reason, because in myomectomy if we use the barb sutures, I always use a Vicryl layer on top of it, so that the barbs get concealed behind the Vicryl layer of the serosal layer. But here you cannot conceal the barb sutures by any layer on the top. So that is why I'm, oh sorry.
Thank you, ma'am.
I'll just.
Dr. Nitin?
Andar lao na.
Dr. Nutan?
Yes, sir.
Nicely demonstrated surgery.
Yeah.
And well closed vault with suspension.
Yeah, with suspension, obviously. And I think we do not have a weighing machine here, but the myoma definitely looks like to be like 2 kg. Chodo.
Ma'am, can we talk about the anesthesia a bit, ma'am? The pressure
Yes.
you are using, the anesthesia type of
Definitely.
anesthesia?
So the first thing which I would like to say about the anesthesia is that in the preoperative preparation for this patient, because she had a large uterus, I was very specific that they do not use any nitrous. Okay? Because the nitrous oxide bloats up the bowels.
Yes.
So this was my one suggestion, very strict suggestion.
Can we shift to the other OT for the closing remarks for the TAR?
हाँ.
ऐसे नहीं
Please
करना
shift to
है। क्योंकि ऐसे करने में सब फाड़ देगा अंदर। Especially when you are doing
Jignesh,
Laparoscopic. Yes.
Closing remarks.
Yeah, so closing remarks, we were just talking about that. Protocol wise, I wait till I do the last skin closure myself, number one. Any hernia surgery, see the CT scan and decide whether you're going to do what component separation. Here, because the posterior component was utilized, so there was a mesh there, so we did a ACST or anterior component separation technique.
That's the planning.
And the planning part. In the execution, position of the patient is very important. We discussed about that. The next part is that we raise the flaps, and whenever we raise the subacute flaps for any surgery, try to remain below the Scarpa's fascia. That is very, very important to keep all the perforators intact. Okay. Then once you have done the anterior component separation, that's a rectus muscle, go 1.5 centimeters lateral, you find the fat, and then you go between the EO and the IO, and the landmark here is that you get a perforating vessels coming in, you stop there. Similarly on this side, here you can go up to the 5th intercostal space, lower down you can go up to the pelvis. Closure, I talked about the technique where you keep on moving your hand up and down, because you get a closure where you should have equidistance from both the sides. Placement of the mesh according to the anisotropy. Stretchable side should be craniocaudal, stiffer side should be transverse. That is a fixation with a 2-0 proline. Today, if you are available with a long-term absorbable, which goes in 6 months, then a PDS or a Maxon. Placement of the drain. Once you have placed the drain, you can see it creates a trifoliate. The beauty of this drain is that there is a clip. So there is not big dabba, which you have in Romson. So here this goes and that gets clipped on the patient's cloth, and patient can move this. I would give a binder. So right now I'll be putting in a Dynaplast from here to here. So mid-axillary to mid-axillary all the way. And cleaning should not be done by any water or any saline. It should be sterilium or preferably a spirit at our place at KM when we use. I don't like water cleaning here because again a source of atypical mycobacteria. In between, the assistant did sprinkle some water inside and I was not very happy. Again a source of atypical mycobacteria. So try to prevent that, and at the time of extubation, your assistant should be keeping the hand onto the suture line till the patient gets extubated, because we don't want the patient to come out with a jerk. Okay? And when the patient is getting extubated, preferably a deep plane of extubation so that there is no jerky movements, and always monitor the peak pressure. Difference should not be more than 5. Okay? So that ends my summary.
Thank
you,
sir.
Everyone is happy. Thank you.
Sir, I have 2 questions.
Yes.
First one is that what is the upper limit of BMI in which you will prefer doing hernia surgery?
Yeah.
And second is that whether you would prefer doing bariatric with hernia or bariatric first and then hernia repair.
Correct. So I follow always the patient safety first formula. Current guidelines up to 32. You can go ahead and do hernia surgery.
Okay,
anything above than that, I will do a bariatric procedure first and do a stage repair, stage 1, stage 2. Having said that, there are some centers which do both at the same time. I am not a proponent of that. I will do a stage procedure. Okay.
Thank you, sir. Thank you very much for the nice presentation.
Thank you very much, and the audience was very nice. A lot of questions, and I hope the postgraduates.
It will be followed by a presentation by Dr. Suviraj John, the
Excellent.
senior consultant at Sir Gangaram Hospital.
Great. Nice to have Suvi here. He is also a fantastic teacher.
You're welcome, sir.
Do we get the audio to finish up?
OT1. Yes, ma'am. Closing remarks.
Yeah. So I will just like to summarize.
Then my question is, what is your preferred energy source for doing colpotomy?
Yeah,
whether it is monopolar, hook or harmonic?
I usually do with a monopolar, but I use a high-end monopolar cautery that is from Irby. It does not cause smoke and it has very fine electrodes. So nowadays, again, the world is shifting to monopolar also. I'm not saying totally, and even I use a lot of harmonic, as you have seen, for most of the applications. But for colpotomy, I've been using monopolar right from the beginning, and I have not changed it much. And only to prepare the angles, I may use harmonic. Otherwise, I use this only.
Okay, ma'am.
So-
Ma'am, whether there is a difference in the tissue charring?
No, there's no tissue charring actually, and even in the healing, we've had a lot of discussions in gynae conferences, so I'll just share my pearls of wisdom with you, that the granulation tissue which forms around the vault, which many of you might have seen that the patient comes back with some spotting, etc. So preparation of the vagina is very important.
Okay,
You
ma'am.
have to do a lot of douche, and when the date of the surgery has been given, we start giving betadine tablets. And second important thing is my technique of 2-layer closure. Many studies have come up and they have concluded that taking the 2 angles separately is also a very good thing, which I did not show here. And the second is to do a this continuous vault closure in 2 layers. So when you do it in 2 layers, it's not the charring actually, it's the strength of the and the cleanliness, because it's usually
Dr.
anaerobic
Nutan?
infection.
Okay, ma'am.
It's nicely done surgery. We are running short of time, and
Sure.
presentation will be followed.
Yeah. Thank you very much for the opportunity and great interaction.
Thank you, ma'am.
Thank you. Oh.
Dr. Suviraj.
Chalo, flu dal.
Hello, thank you very much. I must at the very outset congratulate the organizing team led by Dr. Vinod Jangra, the city-state chapter of Rohtak, as well as the complete team at Holy Heart Hospital and the Maharishi Dayanand University here. Thank you very much. And let me bring greetings to you from the Institute of Minimal Access Surgery at Sir Gangaram Hospital. And I must launch into this little video presentation first by highlighting the fact that, as Dr. Jignesh just highlighted, hernia is now a specialty. There's a structural component to it, and then there's a functional element to it. And this is even more highlighted when you look at a very functional domain of the body, that is the hiatus between the thorax and the abdomen. And I'm going to highlight this by presenting this little presentation on the laparoscopic repair of recurrent hiatus hernia. The technical aspect is highlighted in this video, but one must really appreciate the fact that this is a recurrence-plagued area with up to 95% of laparoscopic hiatal hernia repairs actually recurring by imaging and endoscopy. This is a 50-year-old gentleman who presented the recurrent retrosternal heaviness, the primary complaints with which he came, regurgitation and heartburn and dysphagia post 3 years after a laparoscopic Nissen's fundoplication and a hiatal hernia repair. On upper GI endoscopy, he had a recurrent hiatus hernia despite having a good fundal wrap, and this was confirmed on a CT scan with a cranial migration of an intact gastric wrap. So I'm going to launch straight into the video. The diagnostic laparoscopy confirmed adhesions in the upper abdomen, which we brought down by adhesiolysis, both sharp and a little bit of a blunt dissection. The adhesions were most dense actually under the left lobe of the liver with the lesser curvature of the stomach. One had to be very careful here to bring down the adhesions before actually locating the liver retractor, the Nathanson liver retractor, which will come up shortly. And this took about a fair amount of time, about 40 minutes getting this done. And you will note that the adhesions were very dense, and we had to actually take a consent from the patient preoperatively that he may actually end up with a esophageal if this whole mass was actually very, very dense and not amenable to a proper mobilization. So a combination of sharp and very careful application of energy was taken to undertake this dissection. We also did a lateral gastrolysis, and once this was completed, as you would do in a primary Nissen's fundoplication, we actually took the dissection again to the right side, moving from known to unknown. Please remember the anatomy is extremely hostile, and we know from the CT scan that there's virtually no plane between the left lobe of the liver and the stomach here. At this part of the dissection, we actually prefer cold, sharp dissection, and we actually were rewarded because we found that we opened up the stomach in 2 places, and we had to close that. When we reached the hiatal region, we found there was actually a type 2 hernia, primarily at the left lateral aspect. There was a hernia sac, which we actually later on dissected and excised. The vast amount of effort actually was undertaken on the right side between the crust, the left lobe of liver, and the lesser curvature. And you had to be very, very patient. With this dense adhesions, actually it took about 6 hours to actually cross this point. And one constantly debated whether you had to convert, but because we were making constant progress, despite in millimeters, we kept moving ahead. You really had to back out, you know, once you actually get this urge to keep cutting and moving. Put in a gauge piece, get the hemostasis, go from known to unknown, do the easy bits of blunt dissection, then the sharp. And this actually should be done when you have a fair amount of primary hiatal hernia repair experience. A note to the postgraduates and the trainees: always have the active pole of the energy source away from the vital structures, and make this as intuitive, a second habit that you don't actually compromise, and this will reward you in the future. So more of the stomach coming out of the sac. And it's good to take a break in between when you do these extremely tiring and demanding procedures. And as you can see here, we noted a gastrotomy, and we closed that with an interrupted sutures. Fortunately, we had prepared the patient well, so there was no contamination. Another gastrotomy, which again, but it's very densely adherent to the left lobe of liver, which we noted. It's worth having the benefit of an endoscopy and a gastroenterology colleagues in the OT to check this out post-operatively. So we would actually do a leak test as well as check for any obvious gastrotomies. Once we went past the right crust and the hiatus, things became more easy. We went up into the posterior mediastinum to get at least about 3 centimeters of a relaxed esophagus within the abdomen. This has to be, achieved either in a primary repair or especially in a secondary repair, and to allow sufficient, intra-abdominal placement of the stomach and the gastroesophageal junction. Anything less than that, or a tension-ridden esophagus, one would have to consider even a Coley's gastroplasty. So as you can see, the hiatus there and the esophagus within the abdomen. We did a posterior hiatoplasty, placing interrupted 2O ethibond sutures. And in this case, I think I even placed one anteriorly to avoid excessive kinking of the esophagus. A cautionary note: if you're doing an endoscopy or pushing in a bougie, please do it before you do the posterior hiatoplasty. Never, never do it after you've done the posterior hiatoplasty, or you'll have a high risk of perforating the esophagus above the hiatus. So these are issues that you will face when you do these repairs. We went ahead and actually reinforced the posterior hiatoplasty and actually the complete hiatus after mobilizing the left lobe of liver to allow placement of a parietex mesh, which was contoured to take the shape of the available space there. And that was sutured in place. As you can see, we contoured it outside the abdomen, and we had an adequate retrogastric dissection, as you would do in a primary repair. And this was brought out, and then the mesh was trimmed to ensure that you had a complete encirclement of the esophagus with a little gap between the esophagus and the mesh. And once this was done, there was a suture to the hiatoplasty as well as to the upper part, the peritoneum of covering the diaphragm. We placed the drain at the end of it, and one would argue, why did you place a mesh when you had 2 gastrotomies? We had very little contamination, or actually no contamination, and that gave us courage, especially in a patient who had a recurrence where the strength of the hiatoplasty was suspect. I'll summarize the postoperative status of this patient. He was ambulated in the first postoperative day with a upper gastrointestinal series, which showed the gastric fundal wrap to be well positioned below the diaphragm. He was allowed clear oral liquids on the second post-operative, primarily because we had this gastrotomy closure there. And he had decreasing drain tube volumes, which was, the drain was removed on the 3rd day and he was discharged. The 10th post-operative day, he was started on a puree diet, soft diet at 1 month, went a little slow with him. At 2 years of follow-up, he has been vastly symptom-free with the primary symptoms, although he did complain of some vague chest discomfort. Key points, please remember that if you do endoscopy and radiological assessment, almost 60 to 95% of hernias repairs will actually have some amount of recurrence. The key thing is, are they symptomatic? If they're symptomatic or they're large, you will have to intervene. In this patient, on evaluating him more intensely during the recurrent workup, we found that he had actually a very peculiar drinking habit for tea. He would actually throw in hot tea into his throat literally and swallow it very quickly. We suspect that could actually have caused, esophageal contractions or spasm, resulting in this recurrence. You also need to counsel these patients that a repeat procedure, maybe a simple fundoplication plus minus a gastroplasty, or may even result in a resective procedure. And they must be also counseled that a recurrence carries a high risk of a recurrence. The procedure is essentially the same to the primary index repair, with I think the key note you must know is that a well-done primary repair will be much more difficult to repair for a recurrence, because you're going to have dense adhesions and anatomy that is going to be very intense to bring down. And so counseling, communication, and consent is going to be key, because these patients can be a big pain. And I would suggest please get a psychiatric consultation for those who have borderline, functional symptoms or suspicion of psychiatric issues, because they are very challenging patients. Thank you very much.
Thank you, Dr. Suviraj. Sometimes we suture the wrap with the right crus.
Right.
So whether it reduces the chances of wrap migration?
Yes, thank you. I forgot to mention that, and thanks for bringing it up. In this patient, in the first procedure, he had a wrap to the right crus suturing. The recurrence was primarily on the left. So now actually in my primary hernia repairs, I do both a right and a left closure now. I suture the crust both on the left and the right to the wrap. Now that's my personal choice, but I think this is something you have to undertake for yourself. This is an extremely recurrence-prone area, and this must be actually counseled at the first surgery itself. Reasons for recurrence often are the size of the hernias, number one. Type 3, type 4 hernias are more prone to recurrence. Also symptomatic and recurrent hernias are also more prone for recurrence. So this must be part of your first up, your counseling and consent taking in your first surgery.
Yeah. And sir, in which patients you would do mesh repair in the primary case itself?
There was a move to do for large hernias, and also when you have a tension-filled hiatoplasty with a weak hiatus after closure. Surgeons did, but I think the recurrence rates is now divided. Some people believe the mesh really helps. There's also evidence that suggests the mesh doesn't help. And there are, of course, early publications of complications, mesh erosion, etc. happening. So in our group, the tendency to put a mesh for a primary repair is virtually nil, unless you have an extremely thinned out hiatus. So mesh placement is essentially reserved primarily for recurrent hernia situations, with the consent being taken to the patient. God forbid he has a recurrence after that, he may end up with an esophagogastrectomy and esophageal replacement, because often the quality of your wrap and your gastroesophageal junction post resection of that on a second recurrence is going to be extremely poor. So you have to look at the longitudinal. I liked it when one surgeon mentioned, what do you do if you need a laparoscopic cholecystectomy for a patient after you've done such a definitive hernia repair, I know patients who come back with IPOM whose meshes got infected after laparotomy later on. Then that's a terrible situation to deal with. So please look at the patient as a longitudinal event rather than a point event. So that's my thing. Tie mesh. Sorry?
Type of mesh.
This is the Pancreatectomy mesh. Yes, Pancreatectomy mesh. We've used barred PTFE in the past for primary weak hiatal repairs. Pancreatectomy is substantiated in some literature and some of the Indian surgeons who do recurrent hernia repairs. Yes, sir. No, I would urge against using tackers because there's, I think, some anecdotal experience of hitting and according to pericardial hematomas and effusions because you can go past the diaphragm. So I just picked up the peritoneum and sutured the mesh to that on the diaphragm. Yes, I kind of contoured it, you know, because it was actually a 15 by 15 centimeter mesh. There was a left lobe of the liver, as you saw, I had to mobilize that. Otherwise, there was no place for the mesh to sit, as well as mobilize, you know, the tissues around it, the retrogastric area. Otherwise, you won't get place to put that mesh, especially after a primary surgery. Adhesions are dense, and you have to really worry about structures below and above because you have the IBC below the right crust, you have the aorta there, and as nice as it looks in an edited video, these are real-time worries when you go in there.
I can understand.
Right, thank you.
Sir, how will you manage any esophageal injury if you had one in this?
Right, during the repair. So we have a large, as you know, a training program, and we faced one injury, and that occurred, as I mentioned to you, post-hyatoplasty. The anesthetist pushed the bougie in when they were actually finally calibrating the hiatal closure. One of the residents actually noticed that there was a movement of the diaphragm, but of the hiatus, but the bougie didn't come into the stomach. Anyway, the anesthetist maneuvered it again, and it came in. We completed it. Patient, the first post-operative day, was absolutely fine, but had a tachycardia about 110 in the evening. We were worried about the patient was morbidly a little bit obese, so we were concerned about pulmonary embolism. So we actually did a CT angio, and that showed a collection around the lower esophagus, and we did a contrast study. There was a free leak. We took them up immediately. Early patients, we undid the wrap, undid the hiatus, and took a consent even for bringing out the esophagus, cervical esophagostomy and gastrostomy, and doing a stage procedure. We actually found a 1.5 centimeter right-sided full thickness perforation. We did a sutured closure, put an omentum there, left the hiatus open, we left the wrap undone, placed drains there, did a feeding jejunostomy. She fortunately did well. There was a small mucosal stricture which was dilatable. She's doing well, of course, with some recurrent reflux symptoms. But I think the primary thing is her life was saved from a case of, mediastinus netus and septicemia. That was fortunately to pick up early. So I think even a laparoscopic cholecystectomy post 24 hours, if they're not fit for discharge, I think really consider and have a very low threshold. Go back, look at your video, listen to your team, even if they are like the most junior person, if they're first year resident or even a fellow. If they had a concern, check it out and get in it. I think treat a CT scan like an ultrasound these days, and most of them have this facility. And do a contrast study very quickly, and I think you'll pick them up. This is backed by evidence also. There's a large publication from the Cleveland Clinic, which suggests early repair you can do. The more you delay the diagnosis, it becomes difficult.
So if you have found the injury intraoperatively,
right,
do you prefer going for a biological mesh rather than a
yes,
dual mesh?
like you say, I had 2 gastrectomies there. Fortunately, no contamination. You could use a biological mesh, but again, your recurrence rates are going to be, if you're worried about the tissue strength. And I think the key thing is really counsel these patients. Make them, such patients, make them a member of your surgical team. Tell them, look, this is what's going to happen, and this is what I'm going to do if I have a perforation. I can't help it because your anatomy is that way. Please don't make it a function of your surgical, whatever, virtuosity or ego. Put the stress on share the stress with the patient. And this is what I will do in that situation. I mean, there's only so much you can do. You're doing your best to avoid, these untoward issues. But include in your consent, in fact, hernia, the society has now mentioned, please mention enterotomy as a part of your surgical consent for any hernia. And if you have an enterotomy, you back out, go in for a second stage. So, full disclosure these days. Yes, 1 in 10 patients will run away, but I think it's changing. Times are changing with very hostile, regulations coming, and I'm sorry to say there are more coming now. I'm part of some of the Government of India regulation committees, so it's going to become tough, and we actually worry when we write these regulations, because it could become a noose around our own necks. But it's one of those things we have to deal with.
Thank you, sir.
Thank you. Thank you.
Thank you very much for the nice presentation. We'll be having next presentation from Dr. Manoj Kumar. Is he here? Dr. Anamika Singh, Dr. Ruchi, poster presentation. I think they're not.
Dr. Arushi? Dr. Dakshita? Dr. Namika, kindly go to the stage for a presentation.
Good afternoon, everyone. I am Dr. Anamika Verma, JR's second year from PGIMS Trocar. I am presenting my case on vesicular cecal volvulus, a rare cause of intestinal obstruction.
You have only 3 minutes for presentation.
Cecal volvulus is torsion of cecum around its own mesentery, a condition responsible for approximately 1% of intestinal obstructions. Cecal volvulus may occur if there is an additional insult, such as scarring, adhesions, or an abdominal mass that serves as a fulcrum for rotation. Complications of cecal volvulus include closed bowel loop obstruction, vascular compromise, which can lead to gangrene, perforation. Prompt diagnosis and surgery can prevent these sequelae. Patients with cecal volvulus may present with colicky abdominal pain, nausea, vomiting, and obstipation. Obstruction similar to cecal volvulus may also be caused by the cecum folding anterior to the ascending colon, producing a flap valve occlusion to cecal emptying. This is cecal vesicule. At laparotomy, no rotation of cecum in either the oblique or longitudinal axis was found. A folding of the cecum anterior to the ascending colon with inflammatory adhesions was discovered, fixing the anterior surfaces of cecum to the mid-ascending colon. This fixation permitted massive distension of cecum. We experienced a similar case in our emergency. Patient Raghbir Singh, 77-year-old male resident of Deroli. He presented in emergency with chief complaint of abdominal distension since 6 days. Patient was a non-passage of flatus and stool since 2 days. On per abdominal examination, abdomen was tense, generalized tenderness was present. There was no history of any previous abdominal surgery. On X-ray abdomen, standing lying, the cecal volvulus was seen occupying the entire lower abdomen. For management, we did exploratory laparotomy with peritoneal lavage with right hemicolectomy with side-to-side iliotransverse anastomosis. In the operative findings, there was massive distension of cecum without torsion. Multiple intragut adhesions were present. Aberrant blood vessels were present in mesentery and mesocolon. Redundant sigmoid colon present. Multiple membranous structures present adhering transverse colon posteriorly. Jackson's membrane was also noted. Multiple fecalith were present in transverse colon and descending colon.
You have 30 seconds remaining.
In the discussion part, during embryogenesis, the cecum assumes its normal position in the right lower quadrant due to rotation of the originally left-sided colon with descent from the subhepatic to the right iliac fossa position, and finally fixation to the posterior abdominal wall. Failure of fixation, cecum mobile associated with a point of Hyperfixation to the posterior abdominal wall predisposes to the formation of longitudinal or oblique cecal volvulus and occasionally the bascule type of obstruction.
Kindly conclude.
Specific features of anterior folding of the cecum with associated formation of flap wall obstruction at the folded point on the ascending colon are emphasized, and associated fibrotic adhesions at the fixation point in combination with competent ileocecal sphincter disposes towards the formation of this entity. The treatment of choice is surgical decompression and cecopexy.
We can have just one question.
Sir, Jackson's membrane was present. It is a thin vascular membrane which was attached to the ascending colon and cecum and to the lateral.
So it was a congenital deformity?
Sir,
Malformation?
Sir, looking at in the intra, looking at the mesentery, there were certain.
What was the position of cecum intraoperatively?
It was present in the right iliac fossa.
Right iliac fossa. Okay. So it was congenital.
What's the clinical significance of the Jackson's membrane that you are mentioning? Jackson's membrane, in which surgery it helps? Open appendectomy. Put a 2 centimeter incision, put your finger behind the Jackson and you will have the appendix out without increasing the size of the incision. Thank you.
We have the next person, Dr. Rashmi. You have just 3 minutes to present. Kindly sustain to the time.
Good afternoon, everyone. I'm presenting my paper on salivary duct carcinoma, a case report. Salivary duct carcinoma is uncommon, high-grade, aggressive, malignant tumor with high rate of recurrence, having frequent perineural and lymphovascular invasion. Salivary duct carcinoma accounts for 1 to 3% of all malignant salivary gland tumors. Due to rarity of this malignancy, no consistent therapeutic concept and protocol is available in literature. However, total peritodectomy with neck dissection and adjuvant radiotherapy appears to be appropriate treatment for a salivary duct carcinoma.
There is an announcement, Dr. Bhanot, please meet at the registration center. Someone is waiting for you.
Salivary duct carcinoma is a rare tumor and accounts for 1% of all head and neck malignancy and 1 to 3% of all malignant salivary gland tumors. SDC has invasive growth with early regional and distant metastasis and should be differentiated from metastatic ductal carcinoma of the breast as well as high-grade mucoepidermoid carcinoma because of difference in clinical behavior and treatment and prognosis. A 53-year-old male patient presented to OPD with complaint of swelling in left parotid region for last 6 months. There was history of pain in the swelling. On examination, a mass of 5 into 5 centimeter was present in left parotid region. Swelling was non-tender, firm and mobile. There were no palpable cervical lymph nodes and no abnormal findings in oral cavity. There were signs of facial nerve palsy, chest x-ray and blood investigation were normal. USG revealed mass arising from superficial lobe of parotid gland with diagnosis of benign salivary gland tumor. Superficial peritodectomy was done. On gross examination, a 5 centimeter gland with 5 centimeter ill-defined non-capsulated nodular lesion is present. Microscopic examination showed malignant salivary gland neoplasm with closest resemblance to salivary duct carcinoma. Immunohistochemistry was positive for HER2/neu and EMA. Most reports indicate that salivary duct carcinoma is an aggressive tumor with the most dismal short-term prognosis of all salivary gland tumors. 3 to 5 patients commonly present with painless, rapidly growing parotid mass, often with facial nerve involvement and cervical lymphadenopathy. It frequently involves the extracranial portion of the facial nerve and has a propensity to metastasize through temporal bone via perineal spread. Gingival metastasis has also been reported. Patients are usually elderly
Dr.
men.
Rashmi, kindly come to the conclusion.
Salivary duct carcinoma is a rare, highly aggressive tumor with a short-term prognosis and high incidences of early lymph node metastasis and frequent local recurrence after surgical excision. A total peritodectomy with neck dissection and adjuvant radiotherapy appears to be appropriate treatment for salivary duct carcinoma. Thank you.
Thank you.
In this case, you have done total peritectomy after that?
Yes, sir.
Okay.
Next person, Dr. Arushi. You have 3 minutes for.
Good afternoon, everyone. I'm Dr. Arashi, senior resident in ANT. My topic is tracheomalacia after thyroid surgery for a joint goiter, a rare presentation. Acquired tracheomalacia is a rare complication that may occur in patients undergoing thyroidectomy for giant goiters. Multinodular goiters has female preponderance. Nodular goiter affects 5% of the general population. It has a growth rate of 10 to 20% per year. It is usually less than 100 grams. More than 500 grams is very rare. These cause weakness of the tracheal wall due to long-standing bilateral compression. The incidence of tracheomalacia is 0.001% to 6%. These patients pose a significant surgical challenge. A 62-year-old female patient presented with massively enlarged goiter of more than 10 years duration. She had neck discomfort and respiratory difficulty for the last 1 year. There was no symptom suggestive of hypo or hypothyroidism. On examination, 18 into 14 cm size mass was present, which was moving on deglutition. Its lower border was not defined. Blood investigations were done. Complete blood count and thyroid function tests were within normal limits. X-ray soft tissue neck revealed some compression of the trachea. CT scan revealed massive goiter compressing trachea, but there was no significant retrosternal extension. FNAC revealed colloid goiter and there was no evidence of malignancy. The patient was planned for surgery after informed and written consent for subtotal thyroidectomy. Flexible intubation was performed. The neck was extended, incision was given, sublatissimal flasps were raised, thyroid gland was exposed by dividing strap muscles on both sides for adequate exposure. Middle thyroid vein was ligated and divided. Superior pole was defined. Recurrent laryngeal nerve was identified on both sides and preserved. First, the right lobe of thyroid gland was mobilized and left lobe of thyroid was with isthmus was removed. The removed thyroid weighed 520 grams. 4 grams of functioning thyroid tissue was left on both sides. Trachea was palpated, which was soft on palpation. Tracheal rings were not able to support the curvature of the trachea, so tracheostomy was done on table. Post-operatively, it was uneventful, and after 3 weeks, the patient is now symptom-free and stable. Discussion. More than 500 gram thyroid pose specific problems such as difficulty in securing airway, adequate exposure, blood loss, and risk of injury to recurrent laryngeal nerve, esophagus, and parathyroid glands. Adequate exposure is must. It should be achieved by extending the incision, curving laterally. The removal of the gland is facilitated by dividing at the isthmus after mobilizing one lobe rather than attempting to remove in toto. The care is taken to preserve parathyroid glands and to preserve injury and to prevent injury to recurrent laryngeal nerve. In massively enlarged goiter, post-op airway obstruction may be life-threatening with a high mortality rate of 44%.
Please conclude.
My conclusion is thyroidectomy for massively enlarged goiter, especially more than 500 grams, is technically challenging. Post-operatively, trachea should be looked for if there is any if the wall collapses post-operatively. It can collapse as late as 48 hours. So it may be possible that the trachea is not collapsing on OT table, and we are able to see in the post-operative recovery room. Airway management, integrity of adjacent structures, as well as anticipating the possible complications should be considered a high priority. Significant risk of tracheomalacia is present. So if trachea should always be palpated after surgery for a large goiter. If it feels soft and tracheal rings are not supporting the curvature of trachea, then tracheostomy should be done to prevent post-operative respiratory obstruction.
Your
Thank
time
you.
up. Any questions?
Before putting the tracheostomy in,
Yes,
and when you felt that it was very soft, did you ask the anesthetist to take out the endotracheal tube and check it?
Sir,
Sometimes it is very soft, but it
yes,
will not
sir.
collapse, and patient will end up with an unnecessary tracheostomy.
Yes, sir. Sir, we do tracheostomy simultaneously. We put the tracheostomy tube, and as soon as we enter the trachea, then we ask the anesthetist to pull back the endotracheal tube. And if the airway is secured, then we ask the anesthetist to take out the tube.
But the
endotracheal tube.
tracheostomy is already in.
Sir, we just, the endotracheal tube is gently pulled out a bit, and we put the tracheostomy tube inside and see if that is airway is proper, and we see the ventilation if it is proper, then we ask the anesthetist to completely take out the tube. We don't initially remove a whole of the tube because there can be a tracheostomy tube might land up in a false track, or there can be, it can land up in a false track. So to ensure that airway is properly maintained.
But again the tracheostomy tube was in. Then
Yes,
you
sir.
asked him to pull the
Sir,
endotracheal
it
tube
was, the
out.
cuff was above the level of the trachea, above the level where the tracheostomy set is, tracheostomy tube is placed. It was just above that level. The cuff was deflated and it was above that level.
Okay.
So sorry to interrupt. Case is ready in
Thank you,
OT2. It's hiatus hernia fundoplication is planned. And please shift to OT2.
So this is the case of 65-year-old lady who presented to OPD with vomiting and nocturnal reflux for last 6 months. Since then, patient was on PPI but was not managed. Patient had no comorbidity, no operative history. Upper GI endoscopy showed large hiatus hernia. Plan is laparoscopic Nissen's fundoplication. Thank you.
Hello, am I audible?
Yes, sir.
Hi. So, very good afternoon to all of you. This is
Good afternoon,
Dr.
sir.
Randeep Vadhavan, and
Welcome, sir.
thank you so much. And at the outset, I'd like to thank first and foremost a very dear friend, Dr. Praveen Bhatia, who's a patron for this workshop, Dr. Vinod, and team of Holy Heart for inviting me here. It's an honor to be here. I've spent nearly 10 years of my life at Rohtak because this is my alma mater, so it's good to be back here. So this is a case which
Sir, I just like to interrupt for a minute. We will like to thank the moderators on this dais, and for the next session, we'll invite Dr. Pardeep Garg on the stage, Dr. Ankit Bhardwaj, Dr. Ritesh, and Dr. Anand Yadav.
And Dr. Pawan Malik. Dr. Pawan Malik is a consultant in surgery in Railway Hospital. He is doing good work there. Now to OT2.
Yes, before Dr. Randeep Vadhavan starts, I would love to introduce him, though I should not have, but I am. Can you imagine that today he was supposed to be in Mumbai, and he is the convener of Falls Group, and what he had done.
Sir, voice is not clear. Please make mask out of mask.
Yeah, I am speaking in the mic only.
Yes.
Am I audible now?
Now it's better.
Yeah. So my thinking is that I must thank Dr. Randeep Vadhavan for being to his parent institution, that he has passed his MBBS and MS from Rohtak, and he has come. And frankly, I am much thankful to him for last so many years that he is an excellent giver. He is an excellent human being. But more important is, can you imagine that day before yesterday, yesterday and today, he was supposed to be in Mumbai, but he finished his job in Mumbai in Falls. He is a convener of Falls Group, but he finished his job and then he took a flight and he is there with us to demonstrate the hiatus hernia, and he is demonstrating bariatric surgery today. Randeep, shall I say thanks 1,000 times?
Sir, it's my honor and privilege. Thank you.
Thank you very much. And Randeep is holding chairmanship in Manipal Hospital with his excellent team. And one of my fellows, again, Arun Bhardwaj is also with him, and he has a lot of praises for him. Thank you. Over to Dr. D. Badawan now.
Thank you, sir.
Thank you so much for the introduction. And at the outset, I'd also like to send my regards to Dr. Pradeep Garg. I can see him on the dais. He's been my teacher and he was my co-guide in my thesis. So regards to you, sir.
Thank you, Dr. Randeep. Nice to see you here.
Thank you, sir. So this is a patient. History has already been described that 63 years old. She had been taken PPI for almost 6 months and intractable. She responded to PPIs but continued to have symptoms, reflux symptoms, and upper GI revealed a large hiatus with a grade A esophagitis, and so we are going to do a hiatus hernia, the crural repair, along with a Nissen's fundoplication. So far what we've done is we've just put these 5 ports. I'll just show these 5 ports from the outside. So can you pull out the camera? So I have on the camera Dr. Naveen Verma. He's again a alumni of Rohtak, and he's with me. He's done his FNB after that. He's with me for the last 4 years. So that's the camera port, which is 1/3, 2/3 from the xiphisternum to the...
Sir, we are not getting the view.
So this is the outside view. You would get the camera view is there.
Take on camera view.
So can you see that? Yeah. So can you see now?
Now we are getting it.
Yeah. So this is my camera port, which is in the midline. This is 1/3, 2/3 of the way between the xiphisternum and the umbilicus, and then the 2 working ports. I have one 10 mm port on my right side, patient's left side, mid-clavicular line, almost on the line of where the camera port is, and this is where I'll part the sutures, if required a gauze piece and so on. So that's why I have a 12 mm there, which is a disposable port. Similarly, I have one on the mid-clavicular line on the right side, my left side, patient's right side, same line, and then I have the assistant port, which is again mid-clavicular line, and this is just the subcostal, which is the left subcostal. And then I have the Nathanson in place, which is retracting the liver. So these are the 5 ports by and large I would use for all my upper GI surgeries. So the liver is retracted well, and you can actually see a large hiatus right there. Can you appreciate the hiatus?
We are not getting the camera view.
So can we have the inside view, please? Once you have the inside view, you can tell me and I'll start the procedure.
Okay, sir.
Can we have somebody from the endovision? Please ensure they have the inside view. We need the camera view. Have you got the camera view?
Now it is visible.
Okay, good, great.
Yeah, now got it.
Great. So you can actually appreciate the hiatus right there. That's the hiatus. Can you appreciate the hiatus?
Yes.
So what we'll do is our first step is mobilization from the gastrohepatic omentum. Can I have the harmonic? So
You are using pars flaccida technique.
that's correct. So the first step here would be to identify the right crus of the diaphragm.
Sir, there is some question from the audience side.
Yes, please.
Good afternoon, sir. I'm Dr. Rajat Kelkar.
Yeah, please tell me.
Yes, sir. Sir,
Yeah,
I
hi
want.
Rajat, how are you?
Yes, sir. I'm fine, sir. Sir, I want to ask whether you do manometry and PS study in every patient before taking up for surgery.
Good question. So I would do a pH study in all patients. Manometry is not mandatory. I would not do a manometry. Yes, but pH, at least if I'm doing these hiatus hernias, manometry, only if I feel that these patients will have some kind of motility disorder, would I opt to do that. But by and large, I would not do it. pH study, I would do it. It's not been done in this case. The patient is quite symptomatic, plus a large hiatus, so that's an indication enough. But yes, I would still like to do a pH, ambulatory pH. Probably a pH impedance is what I would do these days.
Thank you, sir.
So, so that's the right crus of the diaphragm.
It's sliding type hernia.
Yeah, yeah. This is the phrenoesophageal ligament. Just like to mobilize this. Then take down the peritoneum between the right crus of the diaphragm and the esophagus. So this is a dissection which I try to complete as the first part of this surgery. I would like to mobilize the esophagus to at least have an intra-abdominal esophagus of nearly 3 to 5 centimeters.
Sir, Ray's tube is inside or you asked to remove it?
No, Ray's tube is inside. I will, once I'm starting my fundoplication, I'll ask her to remove it. I don't keep Ray's tube in the post-operative period. There's no need. So I will ask her to remove it. So that's the anterior mediastinum. That's the left crus of the diaphragm. इसको छोड़ दे बेटा इधर आ जाओ So you can see there's a large hiatus right there. Can you appreciate?
Yes, sir.
That's the left crus, this is the right crus, this is the hiatus. So then I'll start the dissection on the left side before I pass a sling here. So I'm almost dissected onto the other side, but I do not pass the sling at this stage. I'll just do a little more mobilization. And what I do is then I do a mobilization on the left side, and that I start with dividing the short gastrics. So I will be doing a fundoplication, and I will just keep dividing the short gastrics, go up to the hiatus right there, and then pass a sling and do the final dissection and take the crural stitches. So where I would go into the lesser sac, can you get your camera back? So this is the incisura. Somewhere just opposite the incisura is the best area where you can actually enter into the lesser sac. So somewhere here.
Liberal gastrulresis.
Yes.
It's the basic difference between sleeve gastrectomy gastrolysis and now.
Yeah,
you have to save
yeah, the arcade. That's
arcade.
Yeah. So it's easier to enter into the lesser sac when you are going closer, but then So I'm already into the lesser sac right there. So Dr. Shamshur is there assisting me, and he's again been with me for nearly 5 years.
Well matured team.
So I would, you know, there are two schools of thought. Some say you don't really need to mobilize the short gastrics. You don't need to do too much of a gastrolysis. While I am quite comfortable doing a good gastrolysis and good mobilization of the greater curvature, my fundoplication then is very floppy. In some cases where you know, the manometry has been done and there are some there are motility disorders, I may opt to do a two-phase as well, a 270-degree wrap, but more often than not it would be a niscence, a good floppy niscence. We really don't get too much of a dysphagia. What we've started doing is that closing of the crural repair again is extremely important. You don't need to go too tight on the crura. I'll show you what we do generally to ensure that we are not very tight on the crura. So this would be similar to any of the sleeve gastrectomies or any other, you know, the gastrectomies that you're doing. The gastrolysis is quite similar. Only thing is I'm going a little away from the greater curvature. That's the only difference. And having good assistants makes your life very easy. You really don't need to speak. It just goes on automatically. And another thing what we started doing in our department is that the camera person, in this case that's Dr. Naveen, he's actually on a stool. He's sitting down very comfortably on a stool. Then the hands don't, you know, the hands don't, the surgeon's hand and the assistant's hand, they don't clash. So he's very comfortably sitting, and so to that extent we've just made it for all our bariatric procedures also, we do the same. Of course, I do with all the standing in between the legs. So good mobilization here is absolutely essential. Can we have the umbilical tape? We are almost ready. And open the suture as well.
Sir, in cruroplasty, you use all the posterior sutures or sometimes anterior also?
Very rarely anterior sutures. I would always prefer to use the posterior sutures, but sometimes if you know the lie of the esophagus is it's being tented there at the hiatus, then I would probably use the anterior sutures, but by and large I would prefer to use only the posterior ones. So like I said, a good mobilization here is extremely important. I would like to have a 3 to 5 centimeters of the intra-abdominal esophagus. So for that, a good mobilization is required.
If esophagus is not coming down so much, then?
So we've never had a problem as such, but yes, the treatment then is Coley's gastroplasty. You would need to fire a couple of staplers there at the fundus just to ensure that you have a mobilized and So that is absolutely essential. But if you do a good dissection, there's no reason why you shouldn't have a good esophagus.
Good afternoon, sir. This is Dinesh this side, sir. And first I would like to, yes, I'm very fine, sir. First I would like to thank you to sparing time, and you take a lot of hardship to attend this program, because I know the history, how you travel in the last few days. So we are very thankful. And at the same time, I would request, can you explain the hiatal anatomy for the beginners who are sitting in the auditorium? Where is the vagus nerve and everything?
Sure.
In the short, sir.
Yeah, I'll do that. So let me just dissect this, pass a sling, and I'll show you.
Yes, sure, sir. So my view on bariatric surgery, if someone is interested in the bariatric surgery, who is going to start the bariatric surgery, they have to start with the hiatal surgeries first. Okay, I think this will help in the RYGB and the sleeve gastrectomy and all, because hiatal anatomy is very important for all the upper GI surgeries laparoscopically.
बेटा बाहर निकल रहा है, this is not, ये देखो, yes, ये ठीक से नहीं फिट हो रहा है, इसको ठीक से लगाओ. Sling देना, काट दो.
And as we are seeing that sir is not handling the esophagus at any point of time with the instrument. So I think that is important, that we have to be safe with that, so there is no inadvertent injury to the esophagus.
Absolutely. Give me the harmonic, please. So you should have a very good retroesophageal window. Harmonic, please. This is the posterior mediastinum, just dissecting enough so that I should have a good length of the esophagus. So I've got a very decent length of the esophagus right there.
Nicely mobilized.
Yeah, so that is, this is the right crus, that's the left crus, that's where it would meet the median umbilical ligament and median arcuate ligament rather. This is where the median arcuate ligament, the aorta would be right here, just passing behind the left crus. If you can see show you the pulsations. just behind the median arcuate. You would see the pulsations of the aorta right there. You can
Yes,
see the
yes, we can see, sir.
Yeah. So esophagus we've mobilized. I'll just show you the posterior vagus. Posterior vagus is right here, this white structure here. That's the posterior vagus. Anterior vagus, of course, you need to just dissect a bit here. I would get the anterior vagus here. This would be the anterior vagus here. Need to pick it up. So I don't want to remove the sheath over it. Would probably need to just do a bit of dissection and I'll get the anterior vagus here. So that's by and large we've dissected good enough. The length is pretty okay. It's almost to the tune of 3 to 5 centimeters. I will start closing the hiatus from here and then go upwards. What I generally do is that you can either put in a 56 French bougie, which generally is not available, and want to go loose on it just to ensure that you're not tightening the hiatus enough. Or otherwise, what you do is once you've fixed the suture, you give me the suture. No. उधर जो है ना मेरा फाइल में मेरे वो एक कागज कहाँ था? इसके नीचे इसके नीचे ले लीजिए, पाउच के नीचे जस्ट टेक आउट द सुचर, सारे निकाल दीजिए. इसमें जो है ना मुझे 20 वाला ये एक खोल दीजिए. हाँ, ये खोल दीजिए, बाकी रख दीजिए. So what I generally do is I close the hiatus with a V-lock suture. Now V-lock non-absorbable 2O suture is what I generally would use. 15 centimeters is what I generally use to close the hiatus. It's a continuous suturing. It's easy. You'll find it a lot easier here as compared to any other suture. Yes, you can use the ethibond. Then of course you can use it as interrupted, which I will do of course when I'm doing the fundo. But for this I would generally use the non-absorbable V-lock 2-0 continuous suturing.
So is it wise to use a silk suture instead?
Yeah, any non-absorbable is fine, but ideally silk is not something which we would prefer using. Much happier using either ethibond or proline or one of these barbed sutures.
Is it only because of the comfort or anything else which makes the silk?
See, I've had, I've revised a few of these fundoplications as well. And during revision, I found that all along where the silk, if at all silk has been put, then there is a, just a small kind of a little pustule kind of thing there. But in these proline sutures, it never happens like this. So I would be more happier using one of these. But yes, it has to be a non-absorbable suture. So to that extent, silk is all right. It is a non-absorbable. But I've not seen anyone use a silk though.
You will be taking interrupted or continuous?
I would be taking a continuous suture right from this fork, right from the apex here, and then go upwards. And again, ensuring on the right side there is a sheath over it. I would like to take the sheath just to ensure that it's a good closure. The advantage here is that you need to be careful here once you're taking this bite because aorta is right behind it. So that's another thing. It's got a loop, so you really don't need to tie anything. Just pass it across the loop and you are done. It's locked here. And right at the end as well, you don't need to actually tie it. Just need to...
Sir, you are taking continuous because it's barb suture, or in all cases you take continuous?
I am generally using this suture now for last several years. And
Okay.
I've had no problem really, and very comfortable to use. And if you see most of the data which is coming out, continuous suturing is equally effective. There's nothing to say that you need to have interrupted suturing here. Only thing is you don't need to be too tight so that the patient in the post-operative period should not have dysphagia. But besides that, there is nothing to suggest. And how do you ensure? One, of course, is a 56 French bougie. If you have access to it, even a 38 French is fine. Normally, these 38 French are available. You can pass a 38 French and go loose on it. What we generally do is, what is recommended as well, once you've passed three tight, depending upon the size of the hiatus, once you've thrown these 3 bites, just go loose on it. Ask your assistant to loose, to basically go a little loose. Once he goes a bit loose on the esophagus, and if it fills it up, the hiatus, don't go anymore. That's good enough. You don't need to go further tight on it. I'll just pass one more over here and just lock it, but below it, not above it. I don't need to go further tight on it. This is good enough. So that is, this is, you can always argue that this is more subjective, while passing a bougie of 56 or a 38 French is probably a little more objective. But yeah, with experience, we generally do this. Just go loose on it, and then after that, if we feel that it fills up the hiatus, we will not put any more stitch. Something happened. Just bring it up. Sorry, just bring it up. Actually, the needle turned on the so again, I don't need to tie it here. I'll just lock it, and that's good enough in a barbed suture. So I'll just lock this.
And again, at this point of time, we need to be careful about the swathed end of the needle also. You should not do any injury with the swathed end of the needle, backside, into the esophagus.
Okay, so once we've done that, then I need 2 graspers, please. One more. So we'll just have a look at a retroesophageal window, which is pretty big. And that's, so we know in a fundoplication, what happens is that the anterior wall of the stomach, let's do it like this, forms the left limb of the fundoplication, and the posterior part of the stomach forms the right limb. So we'll, so once it's mobilized well, it should come out well. Then after that, of course, you all would have seen it many times, the hunter's shoe shine maneuver, just to ensure that it is loose. It seems pretty loose actually. And once you've done that, leave the stomach here. If it retracts and goes back, that means it's not loose enough. If it doesn't, just stays here, that means it's pretty okay. So it just stays here. So that means it's pretty all right. We'll put about 2 to 3 sutures. Generally, you require about ethibond, please. This I would do it with an ethibond. Ethibond 2O suture. So ethibond 2O suture is what I would use here, and I'll just show you if I was doing a toupee what I would do, and if I'm doing a Nissens, you'll in any case have a look. Oh, Maryland, please. So 2 to 3 centimeters of the fundoplication actually generally suffices. So if I was doing a toupee, what I would do is I would suture it leave a strip of the anterior esophagus free, suture it here, suture the anterior part of the stomach here onto the esophagus, and then suture it here and leave the anterior part of the esophagus free. That's a 270-degree wrap. For 360, I will go all the way through. So again, the other thing which you need to, please center likho. Piche karo camera. So you need to see, this is good, you get about 3 to 5 centimeters right there. What you need to do is the wrap has to be around the esophagus, not the stomach. You don't need to do a wrap here. If you do a wrap here, it's useless. You need to do a wrap around the esophagus. You're making the LES. So, so I'll take about 3 sutures at best, not more, and then fix this wrap to the right truss of the diaphragm. Now that's again something which is not written in the guidelines. Some say you should do it. I generally continue to do it, so that's a routine protocol that I would follow.
Sir, usually you take fibers of esophagus with it or no?
In my second and third, not in the first one.
Okay. It's the lowest stitch, no?
Yeah, this is the lowest one. One sec, it's got, sometimes what happens is that the suture may just get entangled in the Maryland. So, that's what happened. There's a problem in the Maryland. It's getting entangled in the Maryland. You have another Maryland, please? There's some problem with this Maryland. It's getting entangled in the Maryland.
It's open jaw Maryland, that's why it's sticking in.
Yeah, no, I generally use it with the Maryland. I've never had a problem.
That's the
So sometimes it can happen.
different instrument probably.
That's okay, we'll manage. Yeah, so I suppose what's happened is with, with laparoscopy coming in, there are many more fundoplications. I mean, it's not like a huge number, but at the same time, as compared to what we were doing in open surgery and this, of course, there are many more happening because, these are simple procedures. They don't take too long. The hospital stays anything from 24 to 48 hours. We would actually start all these patients liquids in about 6 hours time, and thereafter we would they would be well mobilized. Maximum they'll stay for another day, and then they can go home. They would be given a soft diet for about a week, and then they can get back to a normal diet with a small divided meals.
I invite Dr. Virender Chauhan to the dais.
So this is the case of 47-year-old male presented with pus discharge around perianal region since last 3 years. There is no comorbidity, no operative history. On examination, there is external opening at 9 o'clock position 2.5 centimeter from anal verge, and internal opening at 7 o'clock 2 centimeter from anal verge. On MR fistulogram, there is right transsphincteric fistula with opening at 8 o'clock extending superiorly and posteriorly to intersphincteric plane with internal opening at 7 o'clock 2.5 centimeter from anal verge. Plan is surgery for fistula in anal.
I think वो बोल दिया उन्होंने. We're live now?
Yes, sir, history given.
Okay. So I'm Dr. Sanjay Singla from OT3, And the patient is a 47-year male presenting with a perineal abscess 5 years back, which was drained on the right side of the perineal area. And then after 1.5 years of that, he had a persisting discharging sinus from the right gluteal area. And we present before you to do this case is Dr. Arshad Ahmed. He is professor of surgery from KGMC Lucknow, a gentleman and a person I love for minimal access fistula and neurosurgery. So over to Dr. Arshad Ahmed.
Thank you, Dr. Sanjay, and thank you for inviting me. So good afternoon, everyone. So we are going to deal with this patient who is having this chronic disease of perineal fistula for last 5-6 years. Am I audible in the hall?
Yes, sir.
Okay, is this visible? This area is visible?
Yes.
So we all can see this external opening. So majority of patients with fistula, they will have some one or more than one external openings around the perineal region. And since this is communicating inside the anal canal, so this doesn't heal unless we take care of the disease. So now few things I would like to tell you that you can see this is the anal verge, the point white line of Hilton, which is the junction of hairy and non-hairy area. Now if the external opening is within 1 centimeter, then usually these fistulas are intersphincteric fistulas. If external opening is 1 centimeter, that is line of Hilton, 1 centimeter and beyond that, then this is not intersphincteric fistula. This may be a low transsphincteric, intermediate transsphincteric, high transsphincteric, suprasphincteric, extrasphincteric, but not intersphincteric. So this is not an intersphincteric fistula, obviously, because the external opening is beyond this point. Now, second thing is we will palpate between external opening up to anal verge, we will palpate this area. If it is a low transsphincteric fistula, which is crossing only the subcutaneous part, then we will be able to feel a cord-like structure just below the skin, running from here up to here. So if we feel a cord-like structure, then this will be a low transsphincteric fistula. So we don't feel any cord-like structure in this patient from here up to anal verge. So this is not low transsphincteric fistula. So this is not intersphincteric fistula. This is
Then
not low.
plan will change in any way.
Pardon?
Then plan will change in any way.
Obviously, because all the fistulas, whether complex or simple, that is how you differentiate between a simple and a complex fistula. A simple fistula, the treatment is most of the time a simple fistulotomy. For a complex fistula, so many times you have to adapt a sphincter preserving procedure, or you may have to, if you are doing a fistulectomy, sometimes you may have to combine it with a sphincter reconstruction. So that definitely makes a lot of change. A simple fistula treatment is very simple. So you see cases which can be very complex, cases which can be very simple. Now I am doing PR examination and I can feel some dimpling over 6 and 7 o'clock position. That should be the internal opening. So if the internal opening is here at the pectinate line, then it should not be an extrasphincteric fistula. So we can say by clinical examination only, this is not an intersphincteric fistula, not a low transsphincteric fistula, and not an extrasphincteric fistula, because extrasphincteric fistula will have internal opening which is high up. But in this patient, I can feel this induration here. So far, now we are left with a high transsphincteric and a or a suprasphincteric fistula. Now for that differentiation, we need to see MRI. So can you bring the camera here for the MRI? Give me the thumb forceps. Thumb forceps. Thumb forceps या कोई भी चीज़ दे दीजिए pointer के लिए. Can you bring the camera over the MRI? So, can you see the MRI? Please focus here.
Please focus.
So this is an MRI picture, and this actually three views are important. One is axial, one is coronal, and another is sagittal. But for lateral fistulas, sagittal view can be omitted. We have to focus on axial and the coronal view. In axial view, we see the transverse spread of disease, and you can see this is the disease outside the sphincter complex. As we go up, the fistula tract moves towards the sphincter complex. You can see this coming closer to sphincter complex, and now it is almost very close to sphincter complex, and here it is entering the intersphincteric plane after crossing the external sphincter complex. And here you can see this tract is coming from almost 9 o'clock position towards 6 o'clock position in the intersphincteric plane. So it's a semi-horseshoe kind of fistula. Here also you can see. So it's a transsphincteric fistula That is what axial film says, with a semi-horseshoe tract in the intersphincteric plane. This will tell us about the transverse extent of disease. And this is the coronal section. In the coronal section, you can see this is the pelvic floor here, and this is the medial most part, that is puborectalis, and this is the lower part, that is the anal verge. So this part, from pelvic floor up to anal verge, we have to take this into consideration. So sphincter complex is from here to here. So now you can see the disease is in the intersphincteric plane, reaching up to, if you see 50% of this, half of this, then this disease is slightly above that. It is not going up to pelvic floor, slightly below pelvic floor, but crossing more than half of a sphincter. So we can say it is a high transsphincteric fistula. If this tract was touching the pelvic floor or going beyond the pelvic floor, then this would have been a suprasphincteric fistula. So this is how we can differentiate. Put that thumb forceps there. Give me a new glove, please. So this is a high transsphincteric fistula with a semi-horseshoe tract going from right side to posteriorly. This is what we could interpret with our initial clinical examination and MRI picture. Now we will further examine the patient. Can you give me a probe? Now probing is something very important. Never allow your resident or junior doctor to do probing before you come, because many times people see a virgin fistula and they start putting a probe while the surgeon is scrubbing up. That may create false tracts. So probing should be very gentle and should be done only by the experienced person. Okay, you can see now probe, if the probe goes straight towards anal canal, it is going and stucking at some place. So if the probe goes straight towards anal canal, then these fistulas are again not very high ones. For a high fistula, usually this probe will go up to some distance and then the resistance will be felt. And also you should see this angle between the skin and the probe. Okay? For a low fistula, this angle will be very acute. For a high fistula, this angle will increase. You can see this angle, so it will become less acute. More acute angle, so the tip is going towards anal canal. That is likely to be a simple fistula. If this angle is more, slightly inserted probe, and you see this angle. So now what we will do, we will not push the probe. We will take some water or betadine solution or methylene solution, and we will inject it from the external opening.
Dr. Ahmed?
Yeah.
Can we take a while? Dr. Randeep has just completed the surgery.
Sure, sure.
Yeah. To the OT2.
Yeah, we are back.
Dr. Randeep?
Yeah, can you hear me?
Yeah, yeah.
So you can see actually the wrap is pretty loose, in the sense that if you can pass your grasper all the way through, then
yes,
it's all right. You can pass my grasper all the way through. It's pretty loose there.
Sir, can you show the points where you have fixed on the crus?
Yeah, I fixed on the crus. So there is one trick to fix on the crus. So what you need to do is, when you fix the first one, which is down below, try to rotate the wrap a bit and bit onto the other side, so that it should, so you might just try to fix this with this area of the wrap, which is by and large the right side of the wrap, to the crust. What would happen is that the wrap would actually tilt towards the right side. So
yes,
what I've done is I've actually taken right below and tried to get the wrap completely in the midline, and then taken the bite onto the right crust, just ensuring that the wrap is right in the middle, in the midline, and then fixed it. So it's a 2-point fixation that I've done. The hiatus is loose, the bolus can go through safely, the fundoplication is loose, it's well mobilized, and that's all. No drains, nothing is required, and we've ensured with the umbilical tape that the wrap is actually on the esophagus and not on the stomach. And
yes,
we have a good, so if it's 2.5 centimeters, we probably have about a 5 centimeter of the esophagus right there. So good intra-abdominal esophagus. That's all what is required. So the principles of surgery are all complete here.
Sir, what you have sutured some fatty tissue in the first suture on the crust?
There's no fatty tissue. There's actually there's no fatty tissue. That's just the part of the fat.
This
which
one,
is
this
stuck
one.
to yeah, it's stuck to the stomach.
Okay,
so
okay,
it's
okay,
part of
okay.
the stomach.
Yeah.
It's not anything, not sutured. It's just the stomach.
Okay.
It's attached part of the. So we left a part of the, the greater omentum. We went a bit loose, That's the fat attached to the stomach.
Nicely done surgery, sir.
Thank you.
Thank you. Now we can shoot to Dr. Ahmed.
Okay, so are we connected?
Yes.
So now we did not put the probe because it was not going easily. Resistance was felt, so stop negotiating the probe further. You can see now we are instilling some water with slight of methylene blue and some hydrogen peroxide in it from the external opening, and you can see it is coming from the internal opening. Is that visible?
Yes.
Can you see that solution, that hydrogen peroxide mixed solution is coming from the internal opening?
Yes.
Okay. So we have been able to localize the internal opening, which is almost at 7 o'clock position. But because this is not a simple fistula where the probe cannot be negotiated directly from here to here, so we are not doing straight away fistulotomy. What we are going to do in this patient, first we will slightly mobilize this tract from the subcutaneous tissue, and then we will proceed with the fistuloscope to see any secondary extensions. Give me a monopolar. Monopolar cautery de diye. In the meantime, I will show you what a fistuloscope is. So this is a fistuloscope. Can you see? So this length is almost 18 centimeters. This is the handle. This diameter is 3.3 into 4.7. This is oval, and the angle is 8 degrees. Okay, and you can connect glycine solution in it. Glycine we use because we use monopolar cautery also for debridement of the tract. And this is also a working channel here through which you can put forceps or you can put a endo brush to debride the tract, and you can also use the probe of monopolar cautery for de-epithelialization. So sometimes the tracts are curved, so it may be difficult to pass the fistuloscope directly, but here we are able to insert it. So now we will see how far we can go. So isko on kar dijiyega zara, glycine solution.
Please show the camera view.
Glycine on है? Okay. इसको पकड़िएगा जरा. एंडोविजन आ रहा है क्या? नहीं नहीं, इसमें लगाना पड़ेगा ना कॉर्क, इसका कैप होगा. Just a minute. अब लगाइए. Okay. So can you see? Can you focus on the inside view? On the there. So you can see the tract. Okay. ऊपर की लाइट थोड़ी सी ऑफ कीजिएगा. ये लाइट ऑफ कीजिएगा. ठीक, ऑन कर दीजिए. पकड़िए इसको. एक एलिस फोर्सेप दीजिएगा. मेन एलिस फोर्सेप. Hold this. So sometimes the tract is very curved, so we have to give some traction over the tract to make it straighten up. Okay. So sometimes we can negotiate. You can see with the artery forceps we are slightly giving traction. So is the tract is visible? Is the inside
Yes.
view visible?
Yes.
You can see this is the inside of tract, but it is curved here, bent here, so we are not able to go right up to internal opening. So we are taking out the fistuloscope now. Okay. So that was just a simple fistuloscopy. We could not reach up to internal opening because internal opening, the tract is curved and the fistuloscope is also rigid. But internal opening we have found, it is at 7 o'clock. इससे बड़ा दे दीजिए ज़रा, वो वाला दे दीजिए. नहीं, प्लास्टिक वाला दे दीजिए. Butterfly. Yeah. So So far what we have done is all examination under anesthesia. Now what we do in this patient is first we try to do a lift procedure. See, whenever we are doing sphincter preserving procedure, what is very important is elimination of central disease and ablation of internal opening. Now this is the most important step whenever we are doing a sphincter preserving surgery. We have to eliminate the central disease, which in this patient and in majority of patient lies in the intersphincteric plane. So we need to open the intersphincteric plane. Either we go from the internal opening and just core it out up to internal sphincter, or we go directly in the intersphincteric plane as we do in lift procedure. So now what we are going to do in this patient, we are going to start with, now you can see, because the internal opening is here at 7 o'clock, so this is the intersphincteric groove here. Can you see the intersphincteric groove? This is the intersphincteric groove. Is it visible? Yes. So what we will do, we will give an incision over here and we will do dissection in the intersphincteric plane. Internal
Hello.
sphincter. Am I audible?
Now it's okay. Now it's okay.
Okay. So what we are going to do, because the internal opening is here, so we will give incision over here over the intersphincteric groove in order to dissect the tract in the intersphincteric plane. So this is what we are initially planning in this patient. Now if the tract is mature in the intersphincteric groove, then we can simply ligate on both sides, and if we find an abscess cavity in the intersphincteric groove, then we will lay open this part, that is we will do a sphincterotomy, internal sphincterotomy to drain that area. That is the area of intersphincteric space. हमको छोटे retractors चाहिए होंगे, छोटे retractors दे दो, ये वाले. इसको ऐसे कर दो. Just hold it like this and give me a small gauge here. Gauge. So we are entering in the intersphincteric plane. After giving a small incision over here, and sometimes also you can वो दीजिएगा ये वाला hook. So you can sometime able to probe the internal opening also. एक गॉज दे दीजिए, फ्रेश गॉज दे दीजिए, यहाँ सेक्शन लगा लीजिए. So we are doing dissection in the intersphincteric plane, and we will try to mop कीजिए, find the tract in this plane. Section लगा लीजिएगा. Hold कीजिए. Section टिप वाली नहीं चलेगी. You hold this. Let him. वो छोटी section टिप हो गया. आप retractor पकड़ लो. आप retractor पकड़ लो. आप section लगा लो. Gauge.
Hello. Sir, is I'm audible?
Yeah, you are audible.
Hi, sir. Dr. Pawan this side. Sir, is there any role of putting dye before, making an incision?
We already put that betadine hydrogen solution. We can put some dye as well. That actually makes the identification of the tract easier. Some dye solution was there, दे दीजिए, dye दे दीजिए, syringe में दे दीजिए. Because when you divide the tract, you can see that dye. So they have mixed everything in this. A cocktail is made. It has hydrogen peroxide, it has saline, and it has methylene blue also. थोड़ा सा less diluted. Now you hold this. Thumb forcer. Give me thumb forcer. इसको आपको ऐसे रिट्रैक्ट करना, रिट्रैक्टेड अवे, इसको ऐसे रिट्रैक्ट करना और हमको दिखाना। हमें थंब फोर्सेप दे दिए भैया, गिव मी थंब फोर्सेप। नहीं, थंब फोर्सेप दे दो यार। So we are going dissection in this plane and we will try to be close to, भैया जरा टच कीजिएगा भैया, आप उसको छोड़ दो भैया, लीव इट, जस्ट टच टच कॉटी टच करना। राइट एंगल फोर्सेप ले लिया आपने? छोड़िए, इसको छोड़िए, शो में लाइक दिस, ओके। राइट एंगल ले लिया आपने, सक्शन लगा दिया, सक्शन लगा दिया आपने। हमें राइट एंगल ले लिया। So we are trying to do dissection in the intersphincteric plane, now with a right angle forceps, trying to go behind the tract. इसको ऐसे रखिए, hold it like this and hold it like this. So there is some fibrotic tissue in this area, so we will try to hook the tract here. इसको निकालिए retractor अपना।
Dr. Arshad.
Yeah.
How could you identify that the tract has been identified in the intersphincteric plane?
That's the fibrotic tissue actually.
Acha, fibrotic tissue,
Yeah.
if you see, then you hook around it.
You hook around it.
Okay.
And then further you confirm, because once we have divided the tract, then we will again push the saline from here.
Okay, okay.
It should come from here, not from the internal opening. We will not ligate it, first we will divide it. And we will see whether this methylene blue or whatever solution we are putting, it is coming from the intersphincteric wound now, instead of from the internal opening which was earlier. Suction लगा लीजिए यहाँ पर। So that will confirm. Unless we are confirm that what we have divided is the tract, we will not stop. थोड़ा इधर लगा लीजिए। Retractor. Suction. Suction.
Can sir, we have a zoomed view, a broader view? Actually, it is not very much visible basically.
Section, let it be zoomed.
Also you can see there is some dimpling here. See here. Can you put the focus the camera here?
Yeah. Now it's
Towards the internal opening? So some dimpling is there when I am pulling this tract. But we are not sure. Unless we divide and we see saline moving here, saline coming here, we cannot be sure. इसको ज़रा tight कर लीजिएगा। एक हाथ से एक्चुअली सक्शन चाहिए ना, continuous सक्शन चाहिए। So we are hoping that this fibrous whitish tissue should be the tract. Is it visible?
Yes, 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 yes.
This. Okay. So now we are slightly mobilizing it from both sides, from the external sphincter side also, so that we can remove some of the diseased tissue. Okay. एक हमको हाल वाला सूचर मिल जाएगा क्या? So you can see very clearly here, the internal sphincter is here. Please. बेटा ये हटाइएगा भैया, इसको हटाइएगा. So you can see the internal sphincter. Can you see the internal sphincter here? This is the internal sphincter. And on this side is the external sphincter complex. So we are actually dissecting in this plane, that is between the internal sphincter on this side and the external sphincter on the other side. So without cutting the sphincters, we are, camera आपका अभी ऐसे दिखाइए.
वो थोड़ा ट्रैक्शन ये बाकी दिख रहा था.
Is it visible now?
Yes.
Yeah.
Yes,
This
sir,
is the internal sphincter here, and that side is the external sphincter. And this tract is actually in the intersphincteric plane. So हमको दे दीजिए जरा, सूचर दे दीजिए, लोड कर दीजिए सूचर, सूचर को लोड कर दीजिए प्लीज. हाँ यही चाहिए, इसको लोड करिए, आप इसको होल्ड करिए. हाँ. अब सूचर लोड हो जाने दीजिए, फिर टाइट कीजिएगा. So in fistula management, either you do a complete fistulotomy where you have completely removed the disease from inside out, or if you are doing a sphincter preserving procedure, then you have to ensure that you remove the central part of disease. You remove the central part of disease, and mostly this central part lies in the intersphincteric plane. ऐसे ऐसे करिए, इसको रोटेट कीजिए, इंटरनल स्फिंक्टर को रोटेट कीजिए. So you can simply cut and then ligate, or ligate and then cut. It's not a blood vessel, it will not bleed. So simply we will take one suture towards the attack. One suture through the tract, and then we go across the tract. कैमरा आ रहा है, दिख रहा है कि नहीं? है सर, दिख रहा है कि नहीं? रिट्रैक्शन का प्रॉब्लम आ रहा है ना, रिट्रैक्ट कीजिएगा. So now what we will do, we will divide the tract, whatever tissue this is, we will try to divide it, and then we will see, cautery दे दीजिए, cautery, diathermy, हाँ. हमको दे दीजिए ये. Now again, after dividing it, again we are instilling some solution. No, so still it is not divided. ऐसे पकड़िए, उसको होल्ड कीजिए.
Excuse me, there is an announcement to make. The one with car number 0700 in the parking area. 0700. Car number. Kindly shift the car from the parking.
Section दीजिएगा, section.
Dr. Arshad.
Some person दीजिएगा.
Are you audible, Dr. Arshad? Am I audible?
You are audible, sir.
Okay. That's what I was saying. Is there a short method of identifying the tract in the intersphincteric vein? Only by fibrous tissue you guessed it is a tract. Is there a
If you can pass a probe, it will make easier. Okay. But if you can pass a probe, then usually it's a simple fistula.
Naturally, if it's curving, then it will not pass.
So or you can pass the probe from the inside. Sometimes you can pass the probe from the inside also, but here because the tract is curved, so we are not able to
pass from inside also.
From inside also, neither from inside nor from outside. So you have to rely on the tissue consistency and इसको hold कर लीजिए. You have to see gauge. हाँ एक उसमें रख दिए वॉश करने के लिए. So again, what you see in this patient. सिंपल सलाइन दे दीजिए हमको. सलाइन दे दीजिए. एक सिरिंज में सलाइन दे दीजिए हमें बस. नहीं नहीं हमको दे दीजिए.
अब इधर से आ गया.
Now you can see it is coming from the wound, not from there. Is it visible, sir? Is it visible or not?
Yes, sir.
Yes, sir. Yes, sir.
ऐसे कर, नहीं इधर से, वो तो उससे जा रहा है ना. अब सलाइन दे दीजिए, सिंपल सलाइन दे दीजिए. सक्शन छोटा वाला नहीं होगा आपके पास जिसमें ये टिप लगती है. होल्ड कर लीजिए इसको. होल्ड कर लीजिए.
Since it is coming from the wound, that
इसको होल्ड कर
means
लीजिए सर.
the tract which was excised was possibly the tract only. Dr. Sir?
Pardon, sir?
क्योंकि अब ये the saline is coming from the wound, means whatever you excised was the tract only.
You can see actually the tract you can see here. I can show you. आप उधर से saline push कीजिएगा. Where the tract has been divided, you can see. Can you focus the camera inside? आप उधर से push कीजिएगा. ये देखिए. You can see this movement. I can see the tract from in the intestinal.
Covering the entire
No.
area.
Can somebody focus the camera here? Okay. हाँ. दिख रहा है कि नहीं?
अब दिखाई पड़ा.
एक सेकंड. अब कीजिए. आप रोटेट कीजिए इसको ऐसे. हाँ अब दिखाइए. See, it is coming here.
Yeah.
This. So this is where we will put a suture. Okay?
Right.
Suture दे दीजिए हमें. यही suture दे दीजिए हाल वाला. यहाँ से काट दीजिए इसको. यहाँ से कट कर दीजिए. So we have divided the tract. Now we will ligate it towards the external sphincter. Because after cutting the tract, we put the saline from here and we saw where it is coming from in the external sphincter. So we will put a suture there. Thumb first. Thumb first. Okay. So rotate कीजिए. So we put the saline from there and we saw from where it is coming. At the same place, we are putting the sutures.
Excuse me, sorry to interrupt you, sir. There is a car number HR12T 0700 Skoda. So may I request to clear the passage because it's just in front of the reception. Skoda car है HR12T 0700. Thank you, sir.
So, but now we will not tighten these sutures. What we will do, we will divide it from the external opening and in the end we will tighten these sutures. जी sir. अब इसको छोड़ दीजिए. हमें वो दे दीजिए कॉटरी डायथर्मी. So we have. आप इधर से ले लीजिए. हाँ ले लीजिए. तो हमको दे दीजिए गॉज दे दीजिए गॉज. So we have disconnected this tract from the internal opening and we have divided the tract in the intersphincteric plane. Now what we are left with one tract which is going from here up to the external sphincter complex. we have put this suture on this end, that is the end toward the external sphincter. Now what will we do? We will simply excise some portion of it, and the remaining part of the tract up to here will be curated. And we will also do some ablation with the fistuloscope. So first we are excising the external opening and some portion of the tract which is only in the subcutaneous tissue. We will not cut any sphincter. So far we have not cut any sphincter. एक एलिस दे दीजिए हमको.
Good afternoon, sir.
We have not cut any sphincter so far, and we will not cut in this patient any part of a sphincter. First we divided the tract from the internal opening, so disconnected it there, and now the remaining tract, after slight mobilization only in the subcutaneous part, we will debride it, deepithelize it, ablate it with the help of a fistuloscope, or you can use a mechanical curette also.
Good afternoon, sir.
Good afternoon.
Sir, one question. Sir, if the tract breaks off in between, then what to do? Hello?
Pardon?
Sir, if the tract breaks off in between during the surgery, it is friable. It is not as fibrotic as you have shown.
Then you have to keep the intersphincteric wound open. If the tract is very fibrotic, then you can simply divide it and ligate towards the external sphincter and the internal sphincter. If it is very friable or you find some collection, then you have to keep this wound open for the drainage. And if you find a frank abscess, then even you can do an internal sphincterotomy to allow free drainage of the portion of the tract which is towards internal sphincter or towards anal canal.
How far we can go up, sir?
How far we can go up means?
For the...
थोड़ा बढ़ा दीजिए sir. I could not understand your question.
Sir, the fistula is high, actually.
See, high fistula does not mean the internal opening is high. High fistula means the tract is high. Okay. The internal opening is at the pectinate line. Only in the extra-sphincteric fistula, the internal opening is high, and usually they are secondary fistulas, or the opening may have been created iatrogenically during previous surgery. So what you can see, we have mobilized some part of the tract, and the remaining part we are doing curettage with a curette. This is what we are doing mechanically. This is what we are doing mechanically. इसको hold कीजिए, इसको पकड़िए, fistuloscope दे दीजिए. Give me fistuloscope. Now we will use a fistuloscope to further debride the tract.
Thank you, sir.
या मॉप कीजिएगा. Fistuloscope helps in not only identification of internal opening and secondary tracts, हटाइएगा, but it also helps एंडोव्यूज में दिख रहा है हमको मोनोपोलर कॉटरी दे दीजिए. मोनोपोलर कॉटरी, अरे नहीं, इसकी एंडो कॉटरी फिस्टुलोस्कोप वाले को नहीं, इसका इलेक्ट्रोड दे दीजिए मोनोपोलर. कनेक्ट करवा दीजिए इसको और सेटिंग चेंज करा दीजिए कॉटरी की. यहाँ ट्रैक्टर लगाना होगा. नहीं, कुछ नहीं करना, बस ऐसे रखिए. आप एंडोविजन दिखा दीजिए. लगाइए. Can you see this endo view? वो दिखाइए ना वहाँ. Okay. So we are using this monopolar cautery to नहीं setting change, हाँ ठीक है, to ablate the tract. So further the unhealthy granulation will, the idea is to remove all the unhealthy granulation. The healthy granulation fibrotic tissue can be left behind, But what we are doing with the monopolar cautery, simply ablating all the unhealthy granulation and then we will curate it out. So this will lead to a thorough debridement of the remaining tract. Because we have not completely excised or removed the tract, so whatever portion of the tract is left behind will be debrided, and fistuloscope can help us in doing so. If we don't have a fistuloscope, we can simply do it with a mechanical curate as we are doing. So you can see now we are removing, again putting the curate to remove whatever tissue we have left behind. इन दोनों के बीच का curate नहीं है कोई. So you can see all this granulation which is coming out through the tract.
Endo view हटा दें सर.
Fistuloscope दिए.
Please remove the endo. Please remove the endo.
This procedure can be repeated 2 or 3 times to accomplish proper debridement of the tract.
The open view can be fixed. The endo view or the camera view can be removed, sir, from the screen, because we are not able to see anything actually.
You can see now the tract is cleaner than before, what you saw earlier.
Dr. Arshad, can you ask the cameraman to, now it's better.
So you can see the endo vision, the tract is now cleaner than before. Whatever tract which we are leaving behind is cleaner than before, and we are doing further debridement. इसको होल्ड कीजिएगा, होल्ड कीजिए, इसको बंद कर दीजिए, ग्लाइसिन बंद कर दीजिए. सारी शीशा लेदर मची जो है वो ग्लाइसिन की वजह से मची. अब हमें वो दे दीजिए, कॉटरी दे दीजिए. Now we will excise this part of tract which is extra sphincteric. यहाँ लगा लीजिए retractor. So we have tried to remove as much of disease as possible and without damaging the sphincter. So this is the extra sphincteric portion of the tract which we have excised. And the portion of the tract which was going to the external sphincter has not been excised but has been debrided thoroughly. And the central disease has been taken care of by entering the intersphincteric plane and disconnecting it from the internal opening or from the anal canal by a lift procedure. So this portion of the tract which was extra sphincteric, that is outside the sphincter complex, has been removed, and this will also be sent for histopathology. Now we will come back to the intersphincteric portion where we had taken this suture but we had not ligated. Why we did not ligate it? Because we were putting glycine through the external opening. So if we put this suture before, so that will have been loosened up by now. So we did not. हमको speculum दे दीजिए. Speculum नहीं, वही दे दीजिए plastic वाला. हाँ, ये दे दीजिए. Now we will again see in the intersphincteric plane, थोड़ा सा इसको clean करा दीजिए, wash करा दीजिए. जली लगा दीजिए थोड़ी. So now we can simply tighten this suture, which we did not tighten earlier.
The suture which you applied towards the internal opening, is it a sort of transfixation suture?
Yeah, transfixation suture is better because it doesn't slip away.
Yeah.
Otherwise, you can simply go around the tract and ligate it. But little holder दे दीजिए, ये दे दीजिए artery fossa.
No, you applied in a sort of transfixation manner. It was not covering complete.
No. One through the tract and one across the tract.
Okay.
So that the tract is completely taken in the suture, but doesn't slip away. थोड़ा सा इसको वॉश कर दीजिएगा सिंपल सलाइन से. और इसको कट कर दीजिएगा. So now you can see the two sphincters very clearly, the internal as well as the external, and you can also see the intersphincteric plane. So I will show you the, हमको वो दीजिए thumb forceps, anatomy, इसको ज़रा clean कर दीजिए और इसको ज़रा सा mop कर दें. भाई स्पेकुलम दे दीजिए, क्लीन करके दे दीजिए. ओके, सो एक हमें थंब फोर्सेप और एक गॉज दे दीजिए बस. एक थंब फोर्सेप और गॉज दे दीजिए. यार इसमें से कोई गॉज दे दीजिए. इसको पकड़िए, होल्ड कर लीजिए इसको. थंब फोर्सेप दे दीजिए. So our job is done in this patient. You can see the anatomy here. Can you focus, zoom in the camera here? Okay. So you can see this is the pectinate line over here. Pectinate line, basically you can see one anal column, another anal column, and these anal columns are ending here, and this is pectinate line. From pectinate line downwards is anoderm up to the junction of, up to the place where hair start, appearing. So this junction of, this is pectinate line. This junction of hairy and non-hairy is called as white line of Hilton. Between pectinate line and white line of Hilton is the anoderm. And you can see this internal sphincter here, and this is the intersphincteric groove. Still you can see the internal sphincter is standing out because we haven't cut it. And now here what we did in this patient, you saw the internal opening was here at 7 o'clock. So we gave an incision just outside 7 o'clock, and we went in between the two sphincters. You can see this is the internal sphincter and this is the external sphincter complex. This is internal sphincter, this is external sphincter complex. Now if you see the external sphincter complex, you will find the lower part is subcutaneous. This is the subcutaneous, almost 1 centimeter. Then this is superficial. Okay, आप राइट से दिखा रहे हो? हमको वो दे दीजिए, retractor दे दीजिए, यही पतला वाला. So you can see this is the internal sphincter on this side. Is it visible, sir? Yes. And this is intersphincteric groove where we did all this surgery, and then you have the external sphincter complex. So the lower part is subcutaneous. As you go up, this would be the superficial, and further up this would be the deep part. So this tract was crossing actually the deep part of external sphincter. So we ligated it somewhere here and divided it in the intersphincteric plane. So what we have done in this patient, that we have disconnected from here. So no communication with internal opening. Then this tract which was coming from here up to here, this subcutaneous portion outside the sphincter complex has been excised. Then this portion of the tract which is between the within the external sphincter complex has not been excised because we did not cut the external sphincter. So we have done a thorough debridement, and fistuloscope has been used to assist that debridement. Or you can also do a laser ablation for the same also. So you can see this intersphincteric wound which has been opened, or rather separated. We can simply close it with 2 or 3 loose vicryl sutures. If somebody has said earlier that you find sepsis in this plane, then you don't close this wound. You leave it open so that that will drain spontaneously. And if there is a large abscess, then what you can do, you can cut this internal sphincter. That is what internal sphincterotomy or Troppis procedure, or opening up the intersphincteric plane from inside, from within. So this portion can be, you can do. So in that case, what you are doing, you are only compromising the internal sphincter and you are saving the external sphincter. So that will be a partial sphincter sparing procedure. What we have done in this patient is a complete total sphincter preserving procedure, because we did not cut the internal sphincter, we did not cut the external sphincter. But if we cut this part, then this will be a partial sphincter preserving procedure, and there is no harm in doing that. But in this patient, because the tract was fibrotic, so we are not doing that. However, if we find there is collection, there is sepsis, there is, the tract is not mature, you cannot do proper suturing of the fibrotic tissue, then there is no harm in, just cutting this tissue, so that this will only lead to damage or division of internal sphincter. And that in cases of fissure also we do internal sphincterotomy, and patient does not have any incontinence. So even if in this patient you do a sphincterotomy of this part, patient will not have any incontinence. So now what we will do, we will simply wash this and to put 2-3 loose sutures here so that this wound closes, and this external wound will remain open, so that if there is any secretion, those secretions can be drained from here. Because we have left behind some part of the tract that is within the external sphincter complex. However, we have debrided it well to the best of our resources, but still some collection can come, and if this external wound is open, then it should not collect inside, it should drain outside. थोड़ा सा वॉश करा दीजिए सिंपल सलाइन से, और फिर हमको एक सिंपल वाइकल 20 सूचर दे दीजिएगा. और yeah. See, glands, usually you don't find gland when you do dissection, because gland was the place where abscess started. So when the abscess formed, the gland was gone. The gland was consumed in the formation of abscess. So you don't find the culprit gland, because the culprit gland is no more. That abscess is actually the dead tissue. The dead tissue of what? That gland is dead. That gland is no more. During intersphincter dissection, if you are very careful, you can do a microscopic dissection, you can find some healthy glands in the vicinity, but the gland which was actually culprit will not be seen because it is not there anymore. That gland was consumed in the process of abscess formation. So all you have to remove is the dead tissue. You have to try to remove the central disease from the intersphincteric plane and eliminate it from the internal opening, and then the peripheral part should be debrided well. And for that you can use anything. You can do a mechanical curettage, you can do partial excision, coring, you can do fixision, and you can do ablation with and debridement with a fistuloscope, and sometimes you can also do a laser. You can use laser fiber for the same also. But if you have removed the central disease, that is and eliminated the internal opening, then the peripheral part of the disease you can take care with anything. It is going to heal. But if that central part of disease is not taken care of well, no matter what you do waft, you do laser, or whichever method you use, there is high risk of recurrence because the central part of disease has not been eliminated. So that source of infection is still there. So the idea is to enter the intersphincteric plane either by directly or by from the internal opening up to intersphincteric plane, you divide that part of internal sphincter. So both the things you can do. Either you do directly in the intersphincteric plane, or you divide the internal sphincter between the internal opening up to the intersphincteric plane. So in both ways you will enter the intersphincteric plane, you will take care of the central disease and also the elimination or disconnection of the tract from the internal opening. Once we have done this, then there can be many tracts all around, maybe bilateral, horseshoe, anterior, posterior, whatever. All those tracts need to be thoroughly debrided with whatever tool you have. The subcutaneous part can be excised, the part which is not going into the muscle, that part can be excised, the remaining part can be debrided well, and the external opening should be left open. So this is the basic principle of any sphincter preserving surgery. Tools.
Dr. Arshad, am I audible?
Yes, you are audible, sir.
Yeah, vital suture, where will you put, what is the plane of application of vital sutures? The white line? Can you listen to my question, sir?
No, I could not understand your question, sir.
The white line which was incised to reach into intersphincteric plane, are you going to close that white line?
In the anal canal?
Yeah.
मतलब inside the anal canal?
No, not inside the anal canal. ये जो आपने the incision which you gave.
This incision we are going to close, yeah.
Close. Oh,
yeah.
That's what
but we will put only few loose. जरा सा wash करा दीजिए फिर close कर दें.
Vital sutures.
With vital suture, yeah. 2-3 interrupted loose vital sutures. Yeah, doctor.
No point stitching the external and internal sphincters.
No, because we are simply giving 1-2 sutures and they will be approximated. We did not cut anything. which only went in the plane between the two sphincters.
Exactly, that's what I am asking.
Yeah.
Internal sphincter, external and internal sphincters are to be approximated or not? You are
Simply
approximating
put 1-2 loose sutures in
Okay.
the lower part,
Okay.
close to skin. No need to put many sutures over the sphincters. Because that is only once the pressure inside the anal canal takes over, that space will be obliterated on its own, unless there is sepsis. Unless there is sepsis. Now, Dr. Singla wanted to ask something. इसको कर दीजिए कि what we do on this part of tract. This part of tract we have taken care of. But what we do for this part of tract? What he is asking, whether we should close this opening also. Now the answer is, this was the primary opening of fistula, and the primary opening of fistula is actually the opening of anal gland. So from this opening, the infection goes. This is the opening which allows the infection to enter. And from here, infection enter into anal gland. This anal gland may be lying in the intersphincteric plane or in the submucosal plane, or sometimes outside the sphincteric plane, which is very rare. Now, submucosal abscess which forms because of presence of gland in the submucosal plane usually resolves, because these abscesses usually resolve because from this opening infection goes into submucosal gland, abscess forms, and then the abscess drains back into anal canal through the same opening. These abscesses usually resolve. What happens when this gland is lying in the intersphincteric plane, and from here infection goes in the intersphincteric plane and abscess forms there. Now when abscess forms here, that is in the intersphincteric gland, in the intersphincteric plane, because of inflammation, this internal sphincter undergoes a spasm, and because of that spasm, that tract which was from here, that is from the primary opening up to here, is compressed. So this pus is not able to go back into anal canal from the same opening. Infection came from this opening up to here, but now the pus cannot drain back because of the spasm of internal sphincter due to inflammation, and that tract is compressed. So the abscess forms in the intersphincteric plane, and from there it tends to spread either downwards, forming a small intersphincteric fistula or abscess, or goes across laterally into the ischiorectal fossa, forming a transsphincteric fistula, or sometimes it ascends cranially into the supralevator space, forming a more complex suprasphincteric fistula. So what he is asking ki whether we should do something. Now this is only physiological. This opening and this tract is physiological. Everybody has it. So even if you don't do anything, no harm. But sometimes you can do some, if you find some inflammation there, you can cauterize that area so that fibrosis will.
My question is the tract in between 7 o'clock to 9 o'clock, which was traversing through the intersphincteric space.
Actually, this is that is why we had difficulty, because it was going like this.
Yes.
We had to go in two ways, right? So that tract has been, taken out. That tract has been taken out. That is why, because it was not going straight, it was going like this.
Clear this.
Yeah, that is why we had some difficulty in doing dissection and finding the tract. Yeah, otherwise the tract is going straight, then the procedure is a lot more simpler, as it was in this case, because the tract was going obliquely. Pardon? From the external opening. No, we have left behind some part because we have not cut the sphincter. We have only cut some part of the subcutaneous tissue and removed the tract which was only from skin and in the subcutaneous plane. But we have not removed that part of tract which is behind or within the external sphincter. We have left, actually we have left and we have derided that part. That part, the part which has been removed, why would we debride that? That has been removed completely. The part which is left behind, only that part is debrided. Debridement means we have removed the dirty granulation.
just very superficial, 2-3 sutures. हाँ वो तो जब अंदर से ऐसे होगा ना सर, छोड़ देते सर। कई बार होता है यहाँ से एक फिस्टुला बन जाता है तो उसमें आप ले ओपन कर दीजिए। कई बार यहाँ भी फिस्टुला बन जाता है, ये फिस्टुला के बजाय ये फिस्टुला बन जाता है छोटा सा, वो उस लोकल में उसको कर दीजिए, वॉश कराइए। और दीजिए सर, सलाइन इसमें ले लीजिए। You can stop the transmission now. ट्रांसमिशन आप बंद कर सकते हो।
Okay, thank you, Dr. Arshad, for nice demonstration.
Thank you, sir.
Thank you.
जेली थोड़ी दे दीजिए, जेली थोड़ा दे दीजिए। थैंक यू सर। क्यूरेट दीजिएगा जरा सा, क्यूरेट क्यूरेट क्यूरेट। जो ट्रैक निकली है ना उसको भिजवा दीजिएगा।
Good evening, everybody. There are two cases left. One is RYGB, bariatric surgery. One is RYGB, going to be started in the next 10 minutes, and other is left distal pancreatectomy. Both are going to be started. Hello. There are two cars. One is Skoda Octavia HR12T 0700 0700. And second one is Innova Globe HR37D 3908. 3908.
So good afternoon. We are winding the lunch by 3:30 and then we will have high tea at 5 p.m. Okay. And now we are going to start the paper presentation. And one more announcement, we have the pagdi on the reception counter now available. Those who has been prized last night, they can have back then. Thank you.
Good afternoon, everyone. I am Dr. Aditya Kumar, second year PG resident at MMC Agroha. I am presenting a poster on the topic of role of surgical intervention in the management and prevention of recurrence of diabetic foot ulcer. The prevalence of diabetes mellitus is increasing throughout the world. About 15% of the people with diabetes will develop diabetic foot ulcer during their lifetime, and between 14 to 20% of patients with diabetic foot ulcers require amputation. Now, diabetic foot ulcers happens due to neuropathy, ischemia and limited joint mobility, which eventually causes changes in the biomechanics of joints leading on to ulcers. And the offloading is the gold standard treatment in the management of diabetic foot ulcers. And it is of two types. First one is the external or non-invasive offloading, which is done by total contact casts, orthosis and footwear. The second one is the internal or surgical offloading, which helps to restore the mobility of the stiff joints, restoring correct posture, correcting deformities and maximizing the preservation of the contact surface of the foot. Our main stress is to realize the biomechanics of joints in such a way that Diabetic foot ulcers can be healed and recurrences can be prevented, which in turn will help us in preventing the amputations. Now the case presentation: a 60-year gentleman presented with complaint of ulcer on the base of left great toe for last 3 months, which is gradually progressive in nature and associated with pain and discharge for 5 days. The patient is diabetic for last 8 years and was on oral hypoglycemics and HbA1c was 7.5. We investigated the patients, and after PSC clearance, we operated the patient, and the procedure done was Keller's arthroplasty with plantar fascia release. The first peak is the pre-op peak of the patient. The second peak is the intra-op peak in which Keller's arthroplasty was done, and the third peak is the second 2 months post-op peak. The Keller's arthroplasty, Keller excision arthroplasty of the first metatarsal joint is done for patients with a hallux rigidus and recalcitrant interphalangeal ulcers, which is unresponsive to conservative measures. The proximal third of the base of the proximal phalanx of great toe, along with the insertion of the intrinsic tendons, is excised through a dorsal or dorsomedial approach, and the wound is closed primarily, and the patient was put on non-weight bearing mobilization until the suture removal, and the ulcer was left to heal spontaneously. Now the conclusion is the correction of etiopathogenesis of the ulcer and the altered biomechanics of the foot in the form of surgical offloading will not only help to heal the ulcer and prevent its recurrence, but will also help in avoiding many needless amputations. And the early and aggressive surgical intervention of the deformed foot is much better than many months of unsuccessful conservative care.
Hello.
Yes, sir.
These are the routine procedures at your institute?
Sir, mainly the Keller's arthroplasty and Jones transfer for repair of in cases of diabetic foot ulcers.
If abscess forms at that place, then what to do?
Do you have any role of hyperbaric oxygen therapy?
No, sir. No, it's not available in.
Okay. Thank you. Thank you so much. Next is Dr. Ankush. He'll be presenting a paper on gangrenous jejunum with multiple diverticuli with diverticulitis with omental bend causing obstruction leading to perforation peritonitis. Dr. Ankush.
Good afternoon, my respected seniors and my colleagues. I am presenting a poster on a case of gangrenous jejunum with multiple diverticuli with diverticulitis with a omental band causing obstruction leading to perforation peritonitis. Diverticulosis is a sac-like outpocketing of the bowel wall that can affect the small bowel through the large bowel. Small bowel diverticulosis is rare and not as common as colonic diverticulosis, which is an important diagnosis for hospitalization. Moreover, jejunal diverticulosis is a rare among cases of small bowel diverticulosis and can occur anywhere in small bowels. However, occurrence in the small bowel is rare and usually discovered through endoscopy or radiological imaging methods. The incidence of small bowel diverticulosis ranges from only about 0.3% to 1.3% in general population and in 2.3% in the autopsies, whereas the colonic diverticulosis prevalence rate ranges from 5 to 45% and is thus an important diagnosis for hospitalization. Here I present a case of 51-year-old male who presented with complaints of pain abdomen and not passage of flatus in stool since 5 days, followed by complaints of abdominal distension and vomiting in last 2 days. Patient was a chronic smoker and alcoholic of past 30 years, has a history of laparoscopic cholecystectomy 6 years back. A CECT scan of whole abdomen was done and showed small bowel obstruction with mesenteric lymphadenopathy. We did an exploratory laparotomy with peritoneal lavage with dissection and anastomosis of gut with loop ileostomy was done on the patient. On operative findings, about 10 cm distal to the DJ junction, a segment of jejunum of about 45 to 50 cm having multiple diverticuli along the mesenteric border showing diverticulitis was seen. A mental band was present around this segment of the gut, which was causing gangrenous changes and thus leading to perforation. Lymphadenopathy was also seen in this segment of the gut. About 1 liter of fecopurulent fluid was seen in the peritoneal cavity. In my conclusion, there are some pics, pics of the patient showing multiple diverticuli in the jejunal segment. In my conclusion, unlike the more common colonic diverticulosis, jejunal diverticulosis is a rare form of bowel diverticulosis. Diagnosis of jejunal diverticulosis is usually an incidental, as the majority of patients are asymptomatic. Initial diagnostic modalities include radiography and contrast-enhanced computed tomography. Enteroclysis is most reliable and accurate diagnostic modality, but is not available in all urgent settings. So recently, endoscopy has replaced radiological studies. Conservative management is usually adequate in uncomplicated patients. However, in complicated cases such as perforation, obstruction, or any abscess formation and volvulus, emergency surgery is mandatory or the mortality rate will be higher. Thanks.
Okay, so in your case, the patient has a mental band which leads to, basically it leads to strangulation, right?
Yes, sir.
Which further leads to perforation. So, is there any finding you find, this thing relative to the diverticula?
Sir, there were multiple.
Was there perforation in the diverticula, or it was just a gangrenous bowel which leads to perforation?
It was just a gangrenous bowel that led to the perforation, ultimately, sir.
Okay, and there was no. Just a second.
What was the procedure done? Can you tell me again?
Sir, exactly, we did exploratory laparotomy with a lavage, peritoneal lavage, and we did a resection of that segment of about 45 to 50 centimeter, and we did a RA jejunostomy, and as the gut was edematous and gangrenous, we took out a loop ileostomy distally.
What is the role of anastomosis and ileostomy in same patient? Either you should go for anastomosis primarily or ileostomy.
Sir, anastomosis was to...
If gut was edematous, you could have made a loop ileostomy or end ileostomy. What was there?
Sir, we did a loop ileostomy.
After making an anastomosis?
Yes, sir, because it will lead to short bowel, sir.
Usually we do either anastomosis or this so-called barrel ileostomy, both the ends outside, and later on we can anastomose from the same side.
Yes, sir. Okay. But in this case, we proximally did an anastomosis, and distally we took out a stoma, sir.
Chalo, no issue, because operating surgeon has something in mind and he has done the procedure.
Yes.
Thank you.
Thank you, sir. Added advantage of loop ileostomy, sir. Yes, sir. Yes, sir. Anyway. Yes. Thank you.
Thank you. We will take 5 minutes to start the case, live case presentation.
Now I would like to invite Dr. R.K. Kadwasra sir for his words of wisdom for all the students as well as other junior faculty members. Thank you, sir.
Thank you, Vinod, and good afternoon.
Good afternoon, sir.
See, it is the interest in the surgery which is important to excel in the surgery. Surgery is a skill, and skill, it is not that casually you go through and you get the skill. Unless until you devoted, you concentrate, you keep on watching carefully, seriously, then on you learn. Even I have already 63 and completed my career almost. I have done every surgery, but still in these 2 days I learn again. There are some tricks from some other surgeon. I am not a laparoscopy surgeon, I am not operating that. But even I was watching that with interest, because something you will learn, some or other thing, if you are keenly interested. So it is important for a surgeon to be a keen observer. That is one thing. And another thing is that a surgeon should relish his work. Relish means fully interested, जिसको कहते हैं कि दिल से काम करना सीखो आप. हमारी मेडिकल साइंस में इवन नॉट सर्जरी, यदि फिजिशियन का काम भी है, तो जो काम दिल से करता है तभी उसमें एक्सेल आने का तरीका एक ही है. चाहे वो भजन गाता तो भी वो दिल से गाता है तो उसी को एक्सेल वही करेगा. इट इज़ नॉट कि यार ये एक प्रमोशन लेना है या ये थोड़ा सा 2 पेशेंट इसके फालतू आ जाएं इसलिए करना है, तो एक्सेल नहीं करोगे. आप थोड़ा काम सीख जाओगे, काम चलाओ तो जरूर कर दोगे, बट एक्सेल करने के लिए आपको ये ज़रूरी है कि ये उसको डेप्थ में रखो, उसको दिल से करने की कोशिश करो, कंसंट्रेट करके करो. एंड ऑलवेज ए वॉचफुल ऑब्जर्वर. इवन यदि कोई दूसरा हो रहा है जो आप काम नहीं कर रहे हो, किसी दूसरे को, इवन आप किसी और किसी भी हमारे खुद के लाइफ के अंदर बहुत सी ऐसी चीज़ें हैं, आप किसी को भी कोई काम करता देखोगे तो ऑब्जर्व करो तो कुछ उसमें ज़रूर सीखने को मिलेगी. यदि आपके दिमाग में सीखने की इच्छा है तो कुछ ज़रूर मिल जाएगी. जैसे मैंने अभी खुद यहाँ सीखा, अभी अरविंद को मैंने देखा पिछले दिन कि वो स्टेपलर के ऊपर डाल के और उसके ऊपर स्टिच लगाया उसने, जबकि हम नहीं लगाते हैं और मैंने ज़्यादातर लोगों ने हमने नहीं लगाया. बट आई रियलाइज कि दैट मे बी ए गुड थिंग कि आपने स्टेपलर को फायर करने से पहले उसके ऊपर सिरोजा टू सिरोजा स्टिच पहले ले लिया. एंड दैट मे बी ए बेनिफिट, बिकॉज उन फायर करने के बाद में लगाते हैं तो खींच के या कैसे न कैसे मिस हैंडलिंग से वो गैप होने का चांस रहता है. But then it will be advantage, maybe advantage. I can try myself, but there is something you learn always. There is some or other thing you can learn if you are watchful. So every stage that is. So what I feel that, and another thing is that I have been the secretary of the ASI, and because with the moral duty I have to stay there. But I realize that majority of the doctors, see, like 2 days, if we are really interested, then we should have dedicated these 2 days fully to this workshop and like this thing. Come at well in time in the morning and till sitting late. It is important. It is, they say, all other things you are daily doing, you will not get the opportunity. Now this 2 days opportunity will not get soon. It is not there that whenever you want you can get this opportunity. You can get the opportunity to gossip with your friend, to watch movies, so many other things which we are today, to sleep at length. Every day, every week there is a Sunday you can sleep leisurely. But this type of things, opportunity you are not getting. And in the life is very short. If you want to learn, there is time is limited. I trained myself in Tata, and what I just tell you, how I learned when I went. I was not belong to Maharashtra and this thing, so I have to stay on Saturday and Sunday in the hostel only. So there were many majority of my colleague, the SR, they were from the Maharashtra or like Bombay. Many of them, they used to naturally they would like to go on weekend to their house or somewhere or to their friend or some fulfill the social obligation. So there were bleep pages we were having, bleep system at that time. So they kept on giving me bleep. यार मेरा काम देख लेना. मैं 4-5 bleep टांगे घूमता था और सबकी इमरजेंसी देखता था. सवाल ये नहीं है कि वो गधा मजदूरी थी, कोई दोहराई नहीं है, मेरी कोई जिम्मेवारी नहीं थी, मैं तो किसी ब्रेस्ट की यूनिट में था तो मैं जीआई का काम जाके क्यों देखूं। लेकिन मेरे को क्या फ़ायदा हुआ उसका कि जब भी कोई इमरजेंसी हुई जिसकी भी, वो मैंने जाके अटेंड की। मैं तो आया तो सीख नहीं था यहाँ पे, मैंने तो वो समय सीखने के लिए पहुँचा हूँ, मेरी ड्यूटी भी नहीं थी। लेकिन मेरे को ये सवाल थोड़ी था कि ड्यूटी है कि नहीं है मेरी उस ऊपर, लेकिन जो मैं वहाँ उस अवेलेबल रहा तो मैंने अपने उसी समय के अंदर 24 घंटे में डेट चेंज हो जाती है, उस 24 घंटे में ज़्यादा सीख पाया। वीकेंड पे मैं टीवी देख लेता, पॉलिटिकल डिबेट सुन लेता, क्या हासिल होना मेरी लाइफ में, तो उसने कुछ कंट्रीब्यूट नहीं करना। मेरी लाइफ में तो जो कंट्रीब्यूट कर सकता है ये यही कर सकता था, ये सबसे ज़्यादा इंपॉर्टेंट चीज़ है। तो मैं यंग पर्टिकुलरली रेजिडेंट डॉक्टर्स एंड दिस थिंग, यंग एज के अंदर तो ये बहुत ज़रूरी है कि बाकी सब चीज़ें बाद में की जा सकती है, मस्ती बाद में मारी जा सकती है। एक बार आप अपने पाँव पे खड़े हो जाते हो तो सब कुछ आप कर सकते हो, ऐसा नहीं है हम भी, लेकिन कुछ मौके ऐसे होते हैं कि उनको मिस नहीं करना चाहिए। और ऐसा रेजिडेंसी का पीरियड, मेरे रेजिडेंट रहे हैं, उनको मेरे ख्याल से याद भी होगा, मैं उनको कहता रहता था कि ये जो 3 साल हैं ये लाइफ में दोबारा नहीं आने वाले, ज़िंदगी में ये रेजिडेंसी दोबारा मिलेगी नहीं। तो इसको जितना यूज़ कर लोगे वही तुम्हारा है, जितना तुम टाइम पास कर दोगे वो बेकार है। जैसे मैंने अपना एग्जाम्पल दिया, टाटा के अंदर यदि मैं वहाँ था, वो मेरे को तो ये था मैं 3 साल से ज़्यादा मान नहीं रह सकता, तो उस 3 साल में जो सीख लूँगा वही मेरा है और किसी का नहीं, और मैं जो वेस्ट कर दूँगा तो मेरा गया और किसी का नहीं जा रहा, ठीक है ना। सो विद दैट इंटेंशन इफ़ यू लाइक दिस, ये 2 दिन यदि ये मिले हैं तो 2 दिन आप ऑर्गेनाइजर को सोच नहीं सकते कि कितनी मशक्क़त से ये चीज़ ऑर्गेनाइज होती है। इट इज़ नॉट कि चलते हुए ऑर्गेनाइज हो गई, इसके लिए बहुत मेहनत, फाइनेंस, सो मेनी थिंग्स आर हैव टू बी डन। बट फॉर एज फार एज वी लर्नर इट इज़ इम्पॉर्टेंट, दिस इज अपॉर्चुनिटी वी शुड यूटिलाइज एट द मोस्ट, दिस at maximum, this type of such type of opportunity. Not today, there are so many other time you will have in your life. So this is my word of advice, and I over to Vinod to watch the next.
Thank you, Dr. Kadwasra. I have been the resident of Dr. Kadwasra, and whatever he is saying, that's the true things, and we all worked in the unit as such.
AV team, please connect to OT1. The RYGB bariatric procedure has been started with Dr. Vadhavan, and now I would like to invite, along with Dr. Kadwasra sir, Dr. Sushil Mangla sir, please chair the session. Dr. Manoj Khurana, Dr. Rajesh Yadav, Dr. Rajat Kelkar, please honor the stage, and Dr. Pawanjit Rohila. Thank you.
So this is a case of 36-year-old male, morbidly obese with BMI 47.4 kg per meter square, known case of diabetes. Patient has undergone tonsillectomy 2 years ago, open reduction internal fixation plating 13 years ago, tympanoplasty 15 years ago, and open only meshplasty for umbilical hernia 6 years ago. Now patient is planned for gastric bypass.
Are we connected to OT?
Yeah, can you hear me? Hello?
Yeah, good afternoon.
Good afternoon. So good afternoon to the chairpersons. I'm back with a gastric bypass. Now the thing is that this gentleman also has had an open umbilical hernia surgery, because of which what has happened is that he's got massive adhesions just supraumbilical, and there is a huge amount of momentum which is stuck to that, and there is again an umbilical hernia also, there is an incisional hernia also. So there's an incisional hernia because of the open surgery that he's had. He still has an umbilical hernia, so as a result he's in that region there is the momentum which is completely stuck. Now I do not want to release those adhesions. Releasing those adhesions means I'll have to do a repair. Okay. I'll have to do some kind of a repair over there.
Can we have the inside view?
Yeah, we'll just give you the inside view. Actually, the
then what was the entry point, sir?
So what I did was I went through the Palmer's point.
Okay.
I went through the Palmer's with a 5 mm telescope, And once I saw those adhesions, I've made a supraumbilical midline port. So this is the supraumbilical midline port. Can you see the inside view?
Yes.
So this is the no, you can't?
Yeah, now we get now.
Yeah, so this is a supraumbilical midline port. So there are a few additions here as well. But more importantly, I'll just rotate my scope and I'll just show you. These are all the additions. As you can appreciate, this is the incisional hernia, which is just caudal to where I've made my entry port for that camera. And as I go further caudally, I see one more, that is the umbilical hernia also. So this patient has got an umbilical hernia, has got an incisional hernia, and that was the first entry port, which was at the palmars. This was a 5 mm, and then under vision. So generally what I would do is that since I have got these long telescopes, I would actually go about 20 centimeters down. Now 20 centimeters down from the Zifi, what happens in bypasses is the life becomes a lot easier because I can actually get to the gut and all that. But here, because of the fact that there is incisional and umbilical hernia, I've had to go a lot more
Lower down.
Higher.
Higher.
So I've gone a lot more cranially because
so it will be difficult.
Yeah, so first umbilical hernia, then above the umbilical hernia is the incisional hernia, and I've gone much above that. So I've gone a lot more cranially. What I will do is I will make my working ports and then see if I have access to the gut. Because for any kind of bypass, first I need to be absolutely certain that I need to have access to the gut. Once I have access to the gut, then it's fine. Then I can do the bypasses. So that is, this gentleman has got diabetes. He's just been diagnosed, and he's had his HbA1c was quite high. It was, I think, around 8.3 or something, and 9 point something, 9.1, and yeah. So he
uncontrolled diabetes.
Yeah, uncontrolled diabetes. So a bypass for sure would do a lot better than any kind of sleeve. And so my intention would be to do a bypass, but I need to have access to the intestines. We'll make the 2 working ports. I'll just show you the working ports once I want a 12 mm. Open another 12 mm, please. Huh? नहीं गन जाएगा. I don't need a green. I don't need a green. Yeah, yeah.
Good afternoon, sir.
Yeah, good afternoon.
Sir, Dr. Rajat here.
Yeah, hi Rajat.
Sir, hi sir. Sir, what's your take on MGB if bypass is not possible in this
Yeah,
case?
so if a Roux-en-Y is not possible because of the fact that I may not have access to the full small gut, then I may opt to do a OAGB. But let me just get both my graspers in, and let me see if I can mobilize the. लेना आता है आपको ये? इसको ऐसे लेते हैं. So we are just putting the 2 working ports. I'll show you all the ports. So whether I'm doing an OAGB or an RYGB, generally I make these 5 ports only. I don't require, more often than not, don't require a 6 port. And so what we'll do is we'll just hold this.
You will be using Nathanson's?
Yes, yes, for sure. So Nathanson is an absolute must. And for liver retraction, yes, you can use other methods as well. You can use an Ellis forceps and hold it, hold the the crura from there. But I generally would prefer the Nathanson for sure. And for Nathanson, what I do is I go high up in the Zifi. Then with just the trocar, I make a small hole, dilate it with a long artery forceps. Long artery forceps, please. Thank you. Nathanson.
As Nathanson's is fixed and no assistant is required, that's why it appears to be more promising.
That's correct. So for all our upper GI surgeries now for a good decade and a half, we only use Nathanson. And the position of the Nathanson is slightly different than what we get. So we get a very good retraction. If you can actually appreciate good retraction is, and this is a 50 BMI patient. So you'll need to put the, for Nathanson we'll require these so once we have the Nathanson in place, I'll put the graspers, look for the bowel. If I have access to the small bowel, full small bowel, we'll go for a Roux-en-Y as is planned. If not, then let's see what kind of access I can get. So actually, as per, if you are to dislodge or you need to dissect all that omentum from the defect, then you will definitely need to, such large defects, you will need to cover it with a mesh. There is no way out.
Sir, in this case, the liver parenchyma looks good, but if this patient would have nodular cirrhotic liver, then what was your preferred procedure?
Then, so we know that all patients having liver disease, renal disease, we would prefer to do a sleeve gastrectomy. Yeah, so yes, that would be my ideal procedure. Yes, one can argue and say that even a Roux-en-Y by and large is a restrictive procedure. One can do a Roux-en-Y, but I would still prefer to do a sleeve.
Thank you, sir.
Sir, why?
And take a liver biopsy.
Sir, why RYGB is your first choice over MGB in this patient?
So, see, most of the patients where, so by and large, if we see diabetics, both procedures will do very well. This patient, I had a discussion with him, and he said he has some reflux issues, though of course the upper GI endoscopy is by and large okay. Then I had a discussion regarding his eating habits, and in his eating habits he said he's a vegetarian, but he takes egg, and he actually is able to take 2 eggs, 3 eggs. So, so to that extent, yes, his protein supplements can be completed, and OAGB would also be all right for him. But so my first choice procedure for as a bypass would always be a Roux-en-Y. OAGB, I reserve it for patients who are super obese. And malabsorptive procedure in Indian patients is not the best option. And even if I'm doing those, my biliopancreatic limb would not exceed 150 centimeters. Very rarely over 60 BMI would I go to 200 or for revisions. But by and large, I would confine myself to about 150 centimeters.
Now, what's your plan in this case? How much is the limb length?
Yeah, so if I'm doing a Roux-en-Y, it would be, I would make 100. If I'm doing a OAGB, then I would select, because he's a 50 BMI, then I would, can I have a grasper please? Grasper and harmonic please. So then I would go for anything between 150 to 200. 200 is too much for this gentleman, particularly because he takes egg. So maybe we can call him an eggetarian. And then I would generally go for anything around 175 is what I would stick to. So it would be a 175 biliopancreatic limb. Roux-en-Y, it would be 100 biliopancreatic, 100 elementary limb.
It's routine in all cases, 100 or?
By and large, in most cases, it would be 100. So we've, we have a data of more than 15 years now. These patients do very well. There's no problem at all. So they all have a set point. So biliopancreatic limb at 100 centimeters and an elementary limb at 100 centimeters is very safe for Indian patients. For, I would say, go ahead and say almost all patients up to almost 50 BMI. Beyond that, you may have to, actually, if you want them to have a good response for weight, people may argue and may say, why increase the biliopancreatic limb, increasing the nutritional issues, but then the fact is we'll probably still not get a good weight loss if we don't increase the biliopancreatic limb.
And sir, what's your indication in for banded bypass? Putting a band in.
So banded bypass as primary, I do a lot less. This is again slipped. This is slipped. Can I have the bowel grasper?
It's the Phobes band that
Yeah,
is
I've been putting 1 second. Let me just see this thing and we'll continue with our discussion. 1 second, just let me see the small bowel. So that's the transverse colon. That's the omentum cannot be retracted beyond this because of the fact that it's stuck to the anterior abdominal wall. That's the transverse colon there. This is the transverse colon. So we can go down and see if I can get access to the small gut here. If I can get access, I am good to go for a Roux-en-Y. Yeah, so now Dr. Shamshur is holding that part of the transverse mesocolon. I'm just looking at the
probably
DJ.
part of DJ.
Yeah, I'm just, so I'll just see for the DJ. I am sure I will not have a problem here with the DJ. So if I have access to the DJ, I'm good. Yeah, that's the DJ there. Yeah, that's the DJ. So I'm pretty okay. All right. So because what I do is I don't make the I don't do a jejunocleidostomy. I actually do Roux-en-Y with an omega loop fashion. Now omega loop is something similar to what you would do in an OAGB, and I make it quite simple because what I would do is I will take the loop onto the supracolic compartment, and then all my surgery would be in the supracolic compartment.
Single quadrant.
Yeah, single quadrant then. So I don't really, what I'm doing here is just mobilizing the omentum a bit more so that when I'm taking the loop up, I don't have a problem. So nearer the transverse colon, I had the active blade going up. So this is just mobilizing from the lateral abdominal wall so that if I can just push this part of the omentum up, I'll not, because I don't want any tension on the anastomosis while I'm taking the jejunum for the anastomosis. So I have some more excess now.
You will be going anticolic?
Yeah, definitely anticolic. These days nobody is doing retrocolic. So retrocolic is by and large now kind of obsolete, rarely done these days. It's always anticolic, anti-gastric.
Then you are planning to make a tunnel in this.
Yeah, so that is, let's see if I need to make a tunnel or I can just retract it well. Otherwise I won't make a tunnel, I'll split the omentum. No way of,
split.
Yeah, I'll split. I would always do that. Splitting of the omentum is kind of a mandatory thing that we always do, but you can see after mobilization things have become a little easier, but I may still like to just split it up a bit.
It
So wha-
reduces the traction on the anastomosis.
Correct, correct. I think we are quite okay to go ahead with a. So there have been instances where all the adhesions, all the adhesions from the hernia have been removed. It has been left open or sutured with a non-absorbable suture, and these patients have actually come back within a few days with recurrence and obstruction and so on and so forth. So if you have an omentum there, don't touch it, just let it be. If you have a gut over there, then there is a problem. So if the patient, then you need to remove the gut and obviously do a hernia repair there.
Sir, audio shifted Dr. Arvind.
Sorry?
Sir, audio shifted Dr. Arvind, OT2.
All right.
Dr. Arvind?
Dr. Arvind?
So this is the last case of our conference, and the case is solid pseudopapillary neoplasm of pancreas. Patient is a 26-year-old female presented with pain abdomen left lumbar region since 3 weeks. Patient is known case of type 2 diabetes and no operative history. Our plan is left distal pancreatectomy.
Are we connected to Arvind?
Yes, sir.
Good afternoon, Arvind.
Hello, sir. Good
We are
evening,
waiting
sir.
all the day since
Yes.
morning for your
Sir,
this surgery.
I was waiting. But sir,
So,
it is really.
you entered the
I am
abdomen
so
and now
hap-
what is the stage?
I am so happy, sir, to be here and operating in front of my teachers and my seniors. It's give me a great pleasure. सर थोड़ी बहुत गलती हो तो सर माफ करना सर. सर ये ट्यूमर come back.
Now where you are?
Sir, this is the tumor, sir. I have done already, I cut the gastrocolic omentum.
Okay.
And then with the suture, I retract this stomach. I take out the suture and take out the suture outside the abdominal wall.
Okay.
So this way my stomach will be up. So it will not, I don't have to use any of my instrument. So one hand it gives me one hand free. So I will plan this anterior ramps for this case, sir.
Okay.
Here, so I am mobilizing this part.
The lesser momentum side.
Yes, sir. Go in, like this. Hold it like this. Yes. Sir, this is okay. Sir, we can see here. This is the porta, sir. HDL ligament. This is the HDL ligament, sir.
Yes.
And this is the vessel. Maybe this is left gastric vein.
Left gastric.
Left gastric vein, sir.
Yes. So you are just superior to the
Yes, sir.
pancreas.
I am standing right now on the left side of the patient, sir. My camera person, Dr. Zubair from Bhopal, he is on the camera, and my assistant, Mr. Virender, is on the patient right side, sir. He is retracting the stomach for me.
Okay. So stomach is lifted anteriorly
sir.
up.
Yes, sir.
And you are working behind the stomach,
Yes, sir.
anterior to the pancreas.
Yes, sir.
And
anterior
you
to
are
pancreas.
entered this area already by dividing the greater omentum.
Yes, sir. So
So I will save this left gastric because come, go.
Are you going to trace the splenic in continuity?
Not right now, sir. I am just create a plane. This is a hepatic artery proper, sir.
Yes.
This is the common hepatic. Sorry.
Common hepatic.
Yes, common hepatic artery.
Yeah.
So my line of dissection will be here, somewhere here.
Okay.
I will make the tunnel at this thing, portal vein or supramesenteric vein. So I am little created this dissection so that when I come and create the tunnel, so it will be easier for me to come. I have to cut this peritoneum, dissect this part. This
Right
is
now-
a station 8 node, that is a hepatic node, sir.
Yeah, common hepatic.
Yes, common hepatic node, sir.
So, does this indicate some malignancy or what is this in some
Uh,
reactive node?
I mean, you will find always this node enlarged. It rarely it is positive, but you will always find this large node here.
So, most of them they are
Most of
reactive
them,
nodes.
Yes, sir. Most of them reactive nodes, sir. So you can see, I think, gastroduodenal artery here. This one. Anyway, come back. Come back. Hold it like this. That's it. Bible ready करो. Bible ready. Pass. Go near. Yeah. Focus. Clean camera. Focus.
If it would have been a
Yes, sir.
Whipple, for Whipple and this thing, what is there any difference of the line of where you are going to divide?
No, sir. It's the same.
Same.
Because the tumor is very near to the body.
So in
and-
this case, you will be removing the distal. In Whipple, you would have been removing the proximal.
Yes, sir.
That the line of cleavage or division is the same.
Yes, sir.
Okay.
Come back. Picha. Going. Hepatic artery area. ये गर्म पानी दो जरा कैमरा ठीक से नहीं दिख रहा मेरे को भी. Clean it. Focus.
Dr. Arvind, can we
Sir.
shift to the other OT
Please, sir,
because
please,
it's
please,
at
please,
the critical step?
Yes, sir.
Shift to the other OT.
Come अंदर.
Dr. Andeep?
Stick window, and now I'm firing the stapler transversely. So to cut the stomach, what I intend doing here is that to close. What I intend doing is that I'll create a pouch which would be anything around 20 to 30 centimeters and no more. So this is the size of the pouch that I would be creating. So what I'll do is I'll fire a transverse stapler and thereafter I'll fire 2 verticals. That's the pouch that I will have.
Sir, can you demonstrate how much distance from the G junction?
This is the G junction. So you are roughly about 4 centimeters down. If I was doing a banded Roux-en-Y gastric bypass, I'll just go a little lower, because here means my band comes here. The left gastric is right there. So that means I'm going very close to my left gastric. So that I'll go about 1.5 to 2 centimeters lower, say about 6 to 7 centimeters here. But when I'm doing just a simple Roux-en-Y gastric bypass, yeah, yeah. So this is a powered stapler by Medtronic that we are using. I'm using a purple stapler here, and
what's your choice in Ethicon then?
So Ethicon, it's blue.
Okay.
Yeah, so Ethicon, it would be a blue stapler, and here of course I'll use a purple or a blue. I could have used a blue as well. Now what I'll do is I'll just mobilize the my pouch a bit before I fire the next stapler. This is the pouch. I'll just mobilize this a bit.
And you will leave this posterior adhesion as such?
No, no, I will take down the posterior adhesions. If I don't take these posterior adhesions, then the pouch will become a very huge pouch. And there is enough evidence to support that a bigger pouch means that you've got more parietal cell mass. That means you've got higher chances of marginal ulcer, weight regain, and so on and so forth. So I will take down these posterior adhesions. So there is no way that you can leave these posterior adhesions and make a good pouch. So these posterior adhesions have to be taken down. Yeah, purple is fine. Hold it beta here. Wait, hold, just hold it. Just, yeah, okay, good. Come here, and just push it in.
This is the narrow space and patience is required for this
step. Yes, that's true. Because if you try to hurry it up over here, you can have excessive bleeding.
And it's really difficult to control.
Yeah, you're right. So this is, you need to be a little more patient.
So is this the left crus?
No, this is still the fundus of the stomach. We still not reached the left crus. What I will do is I will do a bit of dissection on the top, get the left crus, just dissect around the left crus as well, and then go back again down there, and then fire the next vertical stapler. Hold this beta. Yeah, so this, just mobilize this a bit.
Spleen is very near, no?
Yeah, so I don't need to go nearer. See, if I was doing like you saw in the fundoplication which we did, there of course, in this I don't need to go nearer the spleen. It is more towards the hiatus that I have to go.
Okay.
Actually, because of the fact that he's had an open surgery, there are more adhesions than normal. So you know, at this area, if you I don't have the gold finger here. The gold finger works very well. Gold finger is for the hiatal dissection, particularly in this area. So that actually helps a lot. So we are approaching, that's the left crust there. So now I'm dissecting over the left crust.
For the sake of audience, gold finger is a curved instrument and that can be hooked from behind to hiatal area.
That's correct. So basically it was like a band passer.
Yes.
Yeah, but now these days rings. So somebody had asked me, do you put rings? Yes, we do in our revision surgeries. We also do in super obese, let's say young super obese who are coming where we don't want to do one of the bypasses. We are doing a sleeve. I've been putting in these rings for now 5 years. We've not had a major issue. Of course, they are loose, and the long-term weight loss is pretty good. Much better than regular sleeves because we know the sleeves will regain weight. Okay, let's go down once again, and then we can fire the next one.
What is the size of ring, sir, you are using?
So these days what we have is that most of these rings, come here beta. Most of these rings actually are adjustable ones. I mean adjustable in the sense that they are
maximizer.
Yeah, minimizers. So these are known as the minimizers. So you can adjust from a ring of 8 to 6.5. I normally would go with 7.5 in most cases.
Okay. Any cases of ring erosion or obstruction?
See that, so the data is clear on it, that the data says very clearly that there could be a, these days 1%, less than 1% chances. We've not had any in our series. The reasons could be that we go a little loose in the ring. So most of these erosions were by and large because of the fact that the rings which were being used at that stage were 6.5 and all. These days, of course, they are the rings are much wider, 7.5. So maybe that is the reason we've not had erosions. We fix them well, so there is no chance of slippage. Yeah. Can you put in the bougie now? So what I'll do is I'll put in the bougie now. I'll ask our anesthetic colleagues to put in the bougie, and then I'll fire the next one. Just close to the bougie. And then generally, more often than not, my pouch would be complete with three fires, one transverse and two vertical. That would be what would be an ideal pouch. Sometimes you may require one extra, but by and large, 3 is what is an ideal. So I'll ask our anesthetist colleagues to just push in the bougie and yeah, push. One sec. Where is it? Just withdraw a bit. Should not have. Withdraw. Yeah, 1 second. Yeah, come. So as you can appreciate the bougie, slow. The bougies come. 1 second. Bit up. क्या कर रहे हो आप?
For the sake of audience, this what we are discussing, the band is like the friendship band. It's the friend of ours to
push.
Avoid the weight regain after when patient forgot he has undergone the bariatric surgery.
Withdraw.
Because weight regain always happens to be a later phenomena.
अब आप push करो. देखो अब इधर आ रहे हो ना. I have to be here. Okay. Push करते जाओ. Push. Don't withdraw it now, beta. Keep pushing it. Bas. Just bas. No. 1 second. So just withdraw, beta. Yeah, now push it. It's not being dissected well, I think. Yes, just a little bit. Push. Let's just stay there. Okay, just stay there.
Sir, what is the size of bougie you prefer in
Cartridge.
RYGB?
So it's 38 French is what we get over here. So 38 French is what we use.
Okay, sir.
And
In
we can
India, it's the
36 to
GCT
40.
36 or 38 is available.
36 to 40 French we can use.
yeah, so you can use, you know what is the difference between if let's say a pouch of 38 and a pouch of let's say a 40 or a 36. So a dia of a bougie which has a pouch of 1 second, let me just fix it and I'll tell you the data. No. I think we are fine. Yeah. Huh? Okay, that's fine. Yeah, it's just 1.3 centimeters and 1.2 centimeters dia. So that's it. The difference is just 0.1. 36 to 38. 38 to 40, again it's about the same. So it's hardly anything, it doesn't make any difference. But generally 38 French is what we get in India, so that's what we have been using. You got green button dabao. Is it okay? करूँ खोलूँ शिफ्ट करूँ शिफ्ट
Dr. Randeep, can we shift to other OT
Yes,
till you
please.
make the pouch?
Yes, please.
Yeah. Shift to other OT.
Dr. Arvind,
Yes, sir.
what you have just now divided?
Sir, just a feeding vessel, sir. Maybe because of the tumor.
This
yes.
is the portal vein, superior mesenteric vein
Yes,
coming up.
This vein is coming up, superior mesenteric vein, sir.
And before reaching this, what you have divided just now?
Sir, it may be middle colic. Come back. There are so many vessels. That is the DJ, sir.
In the
This is the
deep part, which vein is visible?
This is DJ, sir. This is the
No,
DJ.
beyond DJ?
Yes, sir. This is the DJ.
This is the DJ, but
That can be, sir, inferior mesenteric vein. I don't know, sir. Let's अभी देखते हैं, sir. I have to clear my playground first. I think that this is the mesenteric vein, sir. Superior mesenteric vein here.
can you adjust the mic little bit, Arvind?
पहले सक्शन दे हाँ सक्शन गोस पीस दो नहीं है मेरे पास दिखा गोस पीस दिखा अंदर है दिखा ना हाँ। बाइपल जरा मेरे को गोस पीस बस come back so
Dr. Arvind,
G.
which is this area? But
This is near the supramesenteric vein.
okay.
Maybe has some inferior pancreatic vein which come. Come back. आराम से. Yes.
Now it's stopped.
Yes. Come. Focus.
You are planning to dissect splenic at this point only?
Yes, sir. I will go to tunnel, portal vein.
So right now you are working in the tunnel.
Yes, sir.
And this is superior mesenteric below.
Yes, sir.
And on where the bleeding point was, it was the right colic or some.
Yes, sir.
Right side or some duodenal gastroduodenal.
Yes, maybe gastroeploic.
Gastroduodenal.
Yes. Come back.
you are going to remain bit left side of this vein.
Yes, sir.
बनाओ छोटी सी रीड करने वाली वो.
Come back.
Dr. Arvind?
Ji.
Can we shift to...
Please, sir, please.
Shift to other OT. Dr. Randeep?
No, ऐसे नहीं. एक ऐसे रख इसको बस.
Dr. Randeep?
ये है बेटा, इधर पड़ा है धागा. छोड़ो छोड़ो बच्चे, ये है धागा. Hello, can you hear me?
Yeah.
One second. So like I told you, I used 3 cartridges to make the pouch. Now what I'm doing is I'm doing a gastrotomy here. So I'm just preparing the stomach for the bypass. And this is a posterior gastrotomy that I'm doing. Maryland.
You do gastrotomy at this time only before making the
That's correct.
jejunum?
That's correct. So I'll show you why I do that.
Okay.
Harmonic, please.
Sir, is it preferable to walk the bowel completely, to do a bowel walk before making a gastrojejunostomy?
Not required. Not required, because if you've seen that your bowel is okay, it's not stuck anywhere. I've done a diagnostic laparoscopy on this patient. Only thing which is stuck to the anterior abdominal. बेटा क्या दे रहे हो आप? Scissor नहीं चाहिए. ऐसे काम मत करो बच्चे. Maryland दो. So once you've ensured that it's not stuck anywhere, then you can go ahead and do a gastrotomy. So there's just been a little leak. Generally, you don't even see this. And I'll tell you why we prepare it. So in the technique that I do, you generally would prepare the bowel. What I have also done is bowel grasper. I have already prepared the omentum. I don't need to do that. I'll go straight to the small gut. So I will go straight to the small gut.
Straight to DJ and length measurement.
Correct. And then do a enterotomy there and straight away do a GJ. So my
yes. Now I got it.
Yeah. So my
why were made.
Yeah. So my it's already prepared. I don't have to do anything much. The problem here is this part of the omentum which is stuck to the anterior abdominal wall. Otherwise, I wouldn't have had that much of a problem also. This is the DJ. That's the DJ.
Yes.
So that's 5 centimeters. I'll go at 100. So 5 more, that makes it 10. So again, let me count and I'll tell you what I do in this to avoid any confusion. 20, 30, 40, 50, 60, 70, 80, 90, I go at 100. So now what is happening here is the biliopancreatic limb is on my right side, on patient's left side, and the elementary limb is on my left side, patient's right side. So this is well oriented. So this has to be very well oriented. I want a cartridge, purple cartridge, please. Purple 60, harmonic. So now what I'll do is I'll just make an enterotomy here and go ahead and just fire the stapler.
For the sake of audience, it's very important what sir has done. He has thrown that biliopancreatic limb to the left side. of the patient.
Sir, what's your tip or trick to avoid blind O or Roux
Yeah,
and O?
so that doesn't happen in this. It happens once you're doing a JJ in the infracolic. Then, once you made the JJ, then you come up and then you make the GJ and stuff. But if you are just in this fashion, there is no possibility that you'll make a Roux and O.
In this, there is just the orientation of bowel. Which
That's
is
correct.
important.
That's correct. Yeah. Can I have the cartridge, please? So, and what I'll do now is that I generally would also convert this into fire a stapler. Once I'll just show you. So
You have taken same stapler, 60 length?
yeah, so he doesn't have a 45. Otherwise, I would have taken a 45.
And
He
how
told-
much is the length of anastomosis?
So I'll take it at 3. Once I close the enterotomies, once I close the gastro J, it becomes about 2.5, which is
Yes.
adequate.
Yes.
Can you withdraw the bougie, please? So at this stage, I've asked the anesthetist to withdraw the bougie. Where is the... This is it. बेटा इधर पास आना. So the other advantage is that it's never in tension. You can take the jejunum right up to the hiatus, there's no problem at all.
Always posterior anastomosis.
Always posterior, 100% of the times. Never an anterior. The drainage is a lot better.
Yes.
And yeah, so always a posterior anastomosis. No. Roughly about 3. Green button दबा दो. छोड़ दे बेटा आप. ऊपर है पहले ऊपर वाला नीचे वाला. You press this or this for firing. Yeah.
You really think size of this anastomosis will affect the weight loss?
So, see, one can only go by what the data says.
Yes.
So, data says that anything less than 2 centimeters causes narrowing and stricture. That is why these circular anastomoses, which were made with 21 mm, caused all those strictures and narrowing and so on and so forth.
Yes.
So, then they shifted to 25 mm where the chances are less, but then suction, please.
Yes,
But if they still compare it with 25 mm versus a linear where you make about 3 centimeters, the stricture formation is a lot less, the problems are a lot less, and the weight loss is exactly similar. So there's no difference in weight loss. So really at this, it would not make any difference. PDS 20, please.
The size of anastomosis does not affect weight loss.
PDS 20, please.
If you make more than 3, then dumping syndrome is also common.
Absolutely.
And reflux.
Absolutely.
Biliary reflux are also common.
So what I will do here is, I will put just 3 sutures of PDS 20 just to relieve the pressure on the anastomosis. One at this edge, one at this edge, and one at this edge. So once I've made these 3, then what I will do is I'll fire a stapler here to make it this as the biliopancreatic limb and this as the elementary limb, and then close the gastro J. So the reason for this is that, when I'm closing it, I would want this to be separated and then I can do the JJ after that. And in any case, what happens here is I'm not cutting the mesentery. So there's no cutting of the mesentery. As a result, the mesenteric defect, which I'll show you, both the mesenteric and the Peterson's defect are a lot smaller. नहीं है आपके पास PDS? बेटा और तो तब तक ये दे दो, ये भी कर देते हैं. We'll white cartridge भी दे दीजिए. We'll just fire a stapler, and now again what I do is I fire the stapler right here so that the candy cane would be a lot less. So the jejunum beyond the anastomosis is going to be very less. So chances of weight regain with leaving a large amount of jejunum is not there in this kind of method. I'll just fire it right here. इसको खोल लो बेटा. There's a vessel there. One sec. Let me see if I have to avoid this vessel. Yeah, I can go here. Okay. अब इसको पकड़ लो. इसको पकड़ लो बेटा. PDS 20 है बेटा. $25 centimeters चाहिए PDS 20. Bowel grasper देना. So once I fire a stapler here, this would the biliopancreatic limb would be separated from the elementary limb. Yes, that's it. नहीं. There's some problem. Why is this happening? Huh? One sec. इसको just पकड़ना बेटा. इसको जैसे ऊपर करो. चलो दो PDS दे दो. Doesn't matter, we'll come back. We'll just suture this and then we'll come back and make this. ओहो, इसको नहीं कुछ पता भाई. There is no clue. कैसे दे रहा है? काट ले, वैसे ही काट दे. ऐसे ही काट दे. Yeah, so what I'll do here is that just take this is a PDS 20 suture. बेटा laparoscopic scissor दे दे बेटा.
So is this tension relieving suture?
Yeah, just tension. You don't need to put it, but we generally as a protocol we've been doing it, so yes, I don't want to change that, and just 2 or 3 sutures and that's it. Just tension relieving, and sometimes it also helps. You'll see it would help when Dr. Shamshur would be holding it and just retracting it a bit so that my suturing of the GJ becomes a lot easier. So that's the only thing. Those are 2 things only. Cut please. Yeah, and also what we've started doing now for several years now, we close this with a V-lock suture, V-lock absorbable. and we would always do a methylene blue test. Anesthesia, madam?
Sir, these sutures can be applied after firing the stapler, after completion of gastrojejunostomy?
No, see, after completion, you know, these would help us also for retraction. So,
Okay.
you know, how do I apply a suture here? The only way I can apply a suture here is if I have a good traction and the gastroj is kind of, you know, the stomach and the whole complex is kind of retracted. So that Dr. Shamshur would be doing. So that is why then it becomes easier once I always do a leak test. So methylene blue leak test we will be doing. We would want a 50 cc syringe, methylene blue, and so now Dr. Shamshur would be retracting with that PDS suture, and then I can put a suture. So unless I have that suture, I cannot put a suture beyond the right side. See, this side I can only put once he is retracting it.
Yes, sir.
So that is why it is essential, and I would always want to put, because these angle of sorrows you don't want. So this suture can only come if he is retracting and showing me well. Some people would, you know, they would start with a Vicryl, or they would not put these sutures, but I generally prefer to put them, though there may be some technical difficulty at times. I would have wanted a slightly longer suture, but that's okay, we'll manage using half moon of the.
This is the most difficult angle to suture.
Yeah, yeah, so this is, but this is important, very, very important. So initially we would do again a CT gastrographin one day after the procedure. We stopped doing it. Once we've done a leak test, we know we are fine. Patients are in any case allowed orally after 6 hours after the procedure, are mobile. We don't put any drains, any catheters, no drains, no pipes. So we started following the ERAS protocols, and patients are allowed 6 hours after the procedure clear liquids, and then and next day morning the patients are allowed liquid diet. So we've actually made it needle holder, made it as simple as possible. Suction, please.
For the audience, its ERAS protocol is enhanced recovery after surgery, and it's usually followed in bariatric and rest of the colorectal GI surgeries to make hospital stay less and faster recovery.
Bowel rasper. Yeah. Abhi nahi. Abhi we'll require it only after 10 minutes once I've closed the gastrogy. V-lock suture, 15 centimeters, we've got it with us. V-lock suture, V-lock 15 centimeters, 20.
It's PDS only?
Yeah, so it is. What is happening here?
Sir, so you will make BP limb first, then close the gastrojejunostomy?
Yeah, so I'll tell you why I do it. Yeah, so white cartridge, please. So what happens is that Once, let's say I've closed this, okay? Once I've closed this and then I'm doing this, and then the cartridge goes in and it tries to rotate like this, and I've already closed this. So I'm putting a little tension on this anastomosis. As a result, what I do is, initially we were closing it later, but then I realized that it's much better to close it earlier. Once I've, fire this and make the, the limb, because after that then there is no tension on the anastomosis.
Yes,
the anastomosis is kind of done.
This traction of jejunum is also relieved.
Yeah, yeah.
Half side tension relieved.
And how much, sir, candy can length is acceptable?
Yeah, so I just take about 0.5 to a centimeter, not more.
Okay, sir. But 1 centimeter, less than 1 is acceptable.
Yeah. So see, you're very close to it. Sorry, आपने कुछ बोला?
Dr. Andeep, can we shift to other OT?
Yes,
It's
please.
on
Yes,
critical
please.
step.
Yes, please.
Please shift the OT.
हो सकता है.
Dr. Arvind?
Yes.
Please describe what all you have
I am
done.
just trying to go with the vessel, supramesenteric vein. It is adherent, tumor is adherent, it is getting difficult.
So, you are moving towards splenic vein.
Yes.
So this is the splenic, and now this is the becoming portal.
I think this is loop of Henle, I think, this one. And स्प्लिनिक ऐसे जा रही है ना, ये ऐसे जा रही है, तो हमको थोड़ा और उधर जाना है, इसका मतलब ये दिखाओ जरा हार्मोनिक दे. Yes, this is portal vein.
Yeah, that's now. Here is the plane.
Yes, that is the portal vein. Suction दो. पीछे come down. एक गॉस पीस दो छोटा सा काट के. And this we have to take down. ठीक है ना, ये हमें लेना पड़ेगा. I think this is the splenic vein.
Yeah, this is splenic, and now if you divide this bridge a little, that earlier was bleeding.
Yes.
Will it not make your life easy?
Yes, sir. I will just I'll put one small gauze piece there. इससे छोटा देते तो अच्छा रहता. Show me here. देखो center. So I'll make this part. वो दो Maryland दो. आजा आजा. अंदर 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 अंदर. क्लिप दे.
टोटल वो ऊपर टोटल वेन हो जाएगी. ये कॉन्फिडेंस है ना. बोलने का जो ऊपर जा रही है वो तो टोटल वेन है ना. टूवर्ड्स हाईलैंड. वही मैं बोल रहा हूँ जो ऊपर जा रही है मतलब टूवर्ड्स लीवर जो आ रही है वो टोटल वेन है. ये स्प्लेनिक वेन है और यहाँ से असेंबली है. ये जो एक जो क्लिप ये कॉन्फ्लुएंस जो जहाँ क्लिप्स लगी है ना वो कॉन्फ्लुएंस है. हाँ नहीं ऊपर जो है टोटल वेन रेड हाउस.
Bipolar.
Dr. Arvind?
जी sir.
You will transect first?
Yes. No, I will dissect it. I will not transect. I will pass a feeding tube or something like to retract up.
Yeah, then only.
To get hold of pancreas.
Because I want to know the first resectability of this tumor. Suction. I think what is this structure?
Must be part of pancreas only.
Part of the tumor, sir?
No, tumor is a part of pancreas, I think maybe. Yeah. For the nodal tissue.
Let me first
and superior pancreas.
try to
complete
pass,
the tunnel.
Yes, make a tunnel complete so that I can pass. Pakdo, pakdo aise. आराम से.
जो
I think this is a gastroduodenal artery.
Yes. Yeah, visible.
And here is the, will be the portal vein in this. Bipolar. ट्यूमर की वजह से न्यू जेनेसिस है ना काफ़ी, ट्यूमर की वजह से न्यू जेनेसिस है काफ़ी. सक्शन दो. सक्शन. Bipolar. The pancreatic tissue is
What are these? Are they lymph nodes?
no, it is pancreatic tissue, sir. Tongue of the pancreatic tissue.
No. But to make the tunnel is a little bit not on duodenum side.
Yes, but it looks to me pancreatic tissue, sir, only. See, that is a portal vein. Right, sir?
Okay. So that tissue was overhanging this thing.
Yes, so that is the pancreatic tissue, tongue of the pancreatic tissue. It was creating little problem. ये portal vein आ गई. Okay, sir?
Yes.
So that is the portal vein. ये नीचे नीचे ये hepatic artery है ये. Hepatic artery है वो. Come back. Back. Give me one वो दो मेरे को जरा.
No, इसको debate इधर laterally deviated
एक वो दे दो मेरे को फीडिंग ट्यूब या वो अम्बिलिकल टेप दे दो. अच्छा थोड़ा पीछे देखो अंदर
पोर्टल वेन के तो लेफ्ट में
सी आई हैव कम
स्ट्रक्चर है.
पीछे और आ गया. ठीक है आ गया इंस्ट्रूमेंट. अम्बिलिकल टेप दो. Umbilical tape, please. So tunnel is done, sir, complete.
Yes.
So I will pass one umbilical tape and I will hold it anteriorly.
Okay.
And then I'll dissect this splenic vein, and then this retroperitoneal RMPS I will go.
And if the splenic vein is adherent, then splenectomy.
Yes, splenectomy has to be done then. But I think it is better to do splenectomy because I have tried to dissect tumor from the splenic vein. It is not possible because that was adherent the tumor is adherent with the splenic vein, sir.
Yeah, appears to
So
be.
in this case, we have to do splenectomy along with this distal pancreatectomy, sir. So you also think same, sir?
Yes. In open,
Right.
I would have done like this thing.
Yes, sir. I'm going to tape, please.
Because there are lymph nodes, and if it appears malignant, then it is better to do splenectomy along with this thing.
So much. चल 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 आजा 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 ठीक है देखा देखा So this is umbilical tape, sir. Come back, come back, back, back. Now, give me वो दो ये क्या कहते हैं ये दे ना नाइफ दे दिखा इधर इधर देखा इधर 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 इधर
Holding with what?
Yes, sir.
Another pot or what?
No, no, sir. I will put one nick like hernia needle, sir, suture passer needle.
Okay.
This will come out, sir, with that. Artery. Clean the camera. White भी चाहिए, blue चाहिए. चल चल चल.
Dr. Arvind?
Yes, sir.
Can we shift to the
Please,
other
sir.
OT?
Please, please, please. I think video is running there, na?
Yes, yes.
Yeah.
Yes.
It is going on. We are watching otherwise.
Dr. Randeep?
Yeah, hi, can you
We are
hear
with
me?
you.
All right, thank you. So we are already done with closure of the gastro J. I
Single
took two-
layer or double
yeah,
layer?
single layer, single
Okay.
layer. I don't do double layers, and all my GI anastomosis generally just do single layers. So I used two V-locks, one from each end, because I just felt that was a better idea. And sometimes if the enterotomies which have been made are not big enough, then I may use just one suture. But this time I just felt I probably required more. Cut, please. So what we'll do is we'll do two things here. One, we will check for the patency of the anastomosis. To check the patency, we'll ask our anesthetist colleagues to pass the bougie beyond the anastomosis. So once the bougie passes beyond the anastomosis, I know the bowel rasper, please. We are good. Number two, we'll do the leak test. So those two things are absolutely mandatory. We always will do those two tests. Gauze piece, please. First suction and then gauze piece.
बाईपास में एक ये भी चीज़ है कि अगर इसमें थोड़ा बहुत लीक हो भी सकता है ना तो इसमें कुछ नहीं होता नीचे जीजे है डिकम्प्रेस सिस्टम है नीचे तो स्लीव में पैंक्रेटिक तो आगे चला गया स्लीव में पाइलोरस है तो वो हाई प्रेशर सिस्टम है
Then give me the bowel rasper.
इसमें लीक कैन बी मैनेज कंजर्वेटिवली चला गया ना सब कुछ बट इन स्लीव इट इज वेरी डिफिकल्ट टू मैनेज कंजर्वेटिवली
So what I will do is I'll just put the gauze piece beyond the anastomosis, just posteriorly, just for staining of the dye, if any. Meanwhile, ask our anesthetist colleagues if they can pass the bougie beyond the anastomosis. Would you push it, please? Slowly push the bougie. Can you come, beta? Come, can you come? Yeah. Yeah, keep pushing.
सर साइड में स्टेपलर भी फायर कर देते हैं तो वो कंटेंट तो नीचे जा ही रहा है डिकम्प्रेस कर ही रहा है
Keep pushing it.
अनएक्सप्लेनेबल थिंग
Yeah, more डालो. Yeah, push. One sec. Yeah, so you can see the bougie is right here. It has passed the anastomosis and it has reached here. So that means the anastomosis is good patent. One sec. Just withdraw a bit. Very little. But that's all. Just do the leak test now.
Sir, you are doing leak test with methylene blue?
That's correct. So you can do it with methylene blue. There are three ways you can, various ways. So three ways that we are doing it, either methylene blue, underwater air insufflation, or ICG. So we are doing it by ICG as well. So you can inject ICG and then see for the leak as well. That also shows it. हाँ बेटा डालो.
Sir, any difference between methylene blue leak test or air inflation?
No.
Endoscopic guided?
Yeah, it's both the same. Can you put it, बेटा? डाल पाओगे? डालो.
Sir, there is a consensus nowadays that many surgeons are not doing leak test. So what's your take on this?
They are brave surgeons. I'm not brave enough. So even if I catch one leak, I'm happier that way.
Yes.
पूरा डाल दीजिए. डालो. And then put some air in it. बेटा इतनी टाइम नहीं लगता है. पूरा डालना होता है. आपने धक्का देना है, बोलस देना है.
और अभी लीक निकल गया तो क्या करोगे?
First, regards to you, sir. Dr. Kadwasra, sir, is my teacher. So, regards to you, sir.
Thank you.
Sir, so leak hai to, sir, we've had that. We've had on table and we've just sutured that leak. So, you can actually identify and again, sir, the process will repeat. So, I'll suture it. I will have the bougie again being passed through it to ensure I've not narrowed the anastomosis. Again, do a leak test till it's bone dry.
No, but you will open the suture already placed or over?
No, sir, over suture. Over suture,
okay.
sir. Yes, sir.
Now no leak.
Yeah, so I'll just, we'll see once again. Give me a gauze piece once again.
Where the leak is there.
Only where the leak is there. Yeah. Just a figure of 8. So we've just had 1 or 2 instances where we've had to put a figure of 8. Please don't do anything. I'll tell you what to do. Come here, beta. So we are good. There is nothing there. There is nothing here. Okay. So what you need to do is just suck out the methylene blue and take out the, so I don't require the bougie. Okay. We are done. The bougie work is done. You can take it out. Please take it out. Yes, please. इधर दिखाना एक गॉस पीस इधर था कोई नहीं डोंट कॉन्सेंट्रेट हियर बस सक्शन दो आप इधर आ जाओ सक्शन दे दीजिए so next what I do is again we prepare the jejunum so for a jejunostomy I will prepare the jejunum first. The other thing what we normally do is, give me a bowel grasper, I'll show you what we'll do to prevent a gastrogastric fistulization. So I'll put the omentum in between the remnant of the stomach and the pouch.
Okay.
So that prevents the...
behind the stomach.
So I really
to make your life easy.
Yes, so you can actually have 6 ports. Most people would do a Roux-en-Y with 6 ports. I continue to do with 5 ports, and I don't find any difference. I'll just take this out and convert this and put a 5 mm instead. And now the assistant will go in the middle. I go on the right side of the patient. And so I'll measure 100 centimeters.
Dr. Randeep, can
Yeah.
we shift to other
Please-
OT
please, sir,
for
please.
some time?
Yes, please.
Yeah.
Can I have another grasper, please?
Dr. Arvind?
Dr. Arvind?
Okay, yes.
So I am taking the zeroter fascia with my specimen.
You are taking with specimen?
Yes, sir.
Why?
Sir, RM. Clean, clean, clean. बेचारा ये छोड़ इसको छोड़ो 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 पकड़ इधर पकड़ ले बस पकड़ बस अंदर आ। I mean, this is spleen is coming with the fascia, sir.
Yeah, this spleen probably, yes.
हाँ पीछे कम बैक इधर 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 Come back. Suction, please. Sir, hello.
Hello.
Sir, I have already clipped inferior mesenteric vein.
Inferior mesenteric, okay.
Which entered the splenic vein, sir.
Yes.
Yes, I have already taken that. Harmonic. A clip दे देना और यार. Give me one clip.
What is this symbol? Otherwise,
Yes, sir.
Tissue only. Or
yes, sir. Tissue, but still.
Better to.
Yes, sir.
Okay.
दिखाओ दिखाओ. आप मेरिलैंड दो. मेरिलैंड. एंड मेरे को 10 mm का हिमोलॉग चाहिए होगा. दिखा दिखा.
Sir, you are going to divide this spleen vein here.
Yes, sir. This is the tumor, sir.
Yes, yes.
So I have to. I mean, once this is taken, so I can lift this tumor from this portal vein, sir.
Yes. So it's justified to divide the do the splenectomy.
Yes, sir. Come back. इधर इधर. Pass. I think
this is a lymph tissue or what is this?
Maybe, sir. Give me suction go. I am taking this vein, sir. Unless until I took this vein.
Yeah, you will not be able to proceed further.
I cannot proceed, sir.
Yeah,
and that the flow of the splenic artery.
One in Dr. Royla is saying, why not take the artery first?
Yes, sir.
We can go upside.
Yes, sir. I will try that also.
Side.
Yes, sir.
This is the celiac axis.
Yes, sir. This is celiac axis, and this must be the splenic artery, sir.
No.
No, sir. This is the gastroduodenal artery here. Can you see this?
Yes.
This is the gastroduodenal artery. This is hepatic artery, common, portal vein, and here it is a splenic artery. I will just show.
On that side.
Yeah, this one, sir. This one. Bipolar. Because it will rotate then laterally. I think we have to take this first.
Yeah.
Then only.
Then you will be able to expose
yes,
this.
Sir.
Nicely.
Yes, sir. Harmonic. Only thing I have to save this left gastric now, because all short gastric will be taken. Suction. एक मिनट. Leave it. छोड़ दे इनको. छोड़ दे इसको. Leave it. छोड़ना. तूने पकड़ा हुआ है. देख पकड़े. खोल दे. पकड़. दिखा. पकड़. सक्शन. एक मिनट. हाँ चल 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 चल. ले ले गरम पानी.
फायर का ट्रिपल स्टेपल कर रहा हूँ. Just stay suture.
I'll come from that side.
Stepler से डन कर रहा हूँ.
देखता अंदर से ले सकता हूँ क्या?
स्टेपलर के थ्रू. स्टेपलर क्लोजर कर रहा हूँ.
डायग्नोस्टिक की जा रहा है इधर. और बनेगी. I'll go that side. तू इधर आ. कैमरा लेके उधर आ. छोड़ 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 उधर जा. इस पे रिड्यूसर लगाओ.
Dr. Arvind?
जी.
Till you find splenic artery, we can shift to other OT?
Yes, please, sir.
Yeah. Dr. Randeep?
Yeah.
We are with you.
Yeah, thank you. And I'm just trying to close the mesenteric, this defect.
You always do this part with stapler only?
No, I don't do with stapler. I may just do with suturing actually, to be honest. But it's fine. I can do with either one. Just trying to see that I don't want to fire 2 staplers in this. So that is why I'm just taking a little extra time. Actually, I will do with a V-lock suture normally. And that is fine. Yeah? Just ensuring that I get adequate tissue, that's all. I think we are fine there. Green button. हो गया. Wait a second, हो गया. I had crossed it actually.
एक बार शिफ्ट करवाना ऑडियो.
Give me another white. Give me LT 300 या 400 quick clips हैं.
Dr. Randeep?
Yeah.
Dr. Arvind, that a critical step we can
Yeah,
shift
yeah,
to
please,
the other
please,
OT.
please go ahead. Please go ahead.
Please shift to other OT.
Arvind.
Yes, sir. This
where
is the
are
splenic,
you
sir.
now? That is the splenic.
Yes, sir. So what I'll plan is give me a metal clip. यार सक्शन काम नहीं कर रहा, प्लीज देखो.
It is adherent here also.
सक्शन देखो प्लीज. सक्शन देखो प्लीज. नहीं हो रहा ना, अभी कनेक्ट नहीं है. ये ब्लॉक हो गया सक्शन. चेंज द सक्शन प्लीज. Sir, what I'll do is I just put a clip so that I will stop
Yeah.
the inflow.
And then
Yes.
divide the vein and
Yes, sir.
complete the process.
Yes, sir. अरे ऐसे मत कर, तुझे कहा ना, दे दो यार, सक्शन दे दो प्लीज. Sir, waiting for the suction, it is get blocked.
I
हो
think
गया?
you, a surgeon, should have patience.
Yes,
if
sir.
you want to become laparoscopic
I am sorry,
surgeon.
sir. I am going very slow.
In open, we have no patience.
Yes, yes, sir. Give me Maryland. Maryland, please. Yes. These are the nerve plexus. Give me suction on my right hand. Show me. Give me bipolar. Bipolar दोनों को right left. Bipolar दो. Bipolar यार. पैडल दो मेरे को bipolar right foot पे. अंदर अंदर अंदर. Bleeder is there. Bleeder is there. Please. Give me here. देखा. इसको उधर कहाँ खींच रहा है यार, इसको उधर खींच.
Isn't some branch separate?
Yes, sir. Sub branch, sir.
Dr. Arvind, you were asked to do both the difficult cases of the...
All the
Yes,
three
sir.
rather.
Yeah, bipolar is not working. पैडल देखो यार भाई. हाँ. एक मिनट.
Are you not going to clip this?
Yes, sir. I'll going to clip it, sir. Give. La. Give me one clip. Actually, I will not clip it, sir. The reason is, give me harmonic. Because if I put a clip, then it will be difficult for me to dissect around. Because it will create a problem for me for
Okay.
dissection. So if ligature would have been here at this point of time, it would have been better, but
So you are using bipolar.
no, sir, harmonic, sir.
This is harmonic.
Yes.
For these type of vessels, you are using setting at 1 or 3?
1, sir.
Okay. It's routine for you.
Yeah, routine.
1-5?
All laparoscopy I put harmonic on 1 and 3, sir.
Okay.
Pass it. ना अच्छा एक 5 का पोर्ट और मिल जाएगा क्या मुझे? हाँ? This is celiac axis.
Sir, there is a small suggestion.
Yes, sir.
If you release the upper margin,
yes,
furthermost part also,
okay,
then probably retraction will be better.
I have all done that. इधर आओ वापस. Come this side.
Actually, सब paper and
I will need a metal clip here. On this artery, I will put one metal clip because that will be easier to apply.
Dr. Arvind?
Yes, sir.
Can we shift
please.
to other OT?
Yes, sir. Please,
they are just completing the procedure.
Yes, yes, please, sir.
Dr. Randeep?
Hi. Hello. So I've just closed the mesenteric defect. Sorry. So this is the mesenteric. I'll just show you the mesenteric defect.
Yeah, for the sake of audience, just show the defect and where is the elementary and all the limbs.
Yeah, yeah, sure. So this is the camera piche beta. This is the elementary limb which is going. That's the elementary limb.
Okay.
This is the biliopancreatic limb. This was the mesenteric defect which I have completely closed. And the common channel, I'll show you the common channel once I've just closed this.
Okay.
So I just have to take 2 more bites. I will take the bite from the bowel as well. So once I've taken from the bowel, that will be it. And then I will show you the last step of a Roux-en-Y gastric bypass, closure of the Peterson's defect. So I will close the Peterson's defect also because there is, in spite of when they were not closed, the chances of internal herniation were nearly up to 20%. Not all data showed that. Up to 20%, but even after good closure, you can still have about 2 to 3%. So these, in some studies, we ourselves have had only, out of whatever about 1,000 Roux-en-Ys that we would have done, we'd probably have had 2 Peterson's defects, which we had to close. So
sir, there is a series of a study of around that's around 50 patients, if I am remembering correctly. They studied the patient of Roux-en-Y gastric bypass, and laparoscopy was done due to any other reason.
Yeah.
And they found the well closed defect. They were also open when patient has weight loss and all the things.
Yeah, so that is
in
why
a significant number of the patients.
Yeah, so if you see, so why I am closing it like this? Why am I taking the bowel? So taking the bowel is extremely important. That's the most important step in the mesenteric defect. 1, taking the fork here, which I have completely closed. Taking the bowel, what happens is, bowel is an anchor. So even if the weight loss happens, the bowel will hold the sutures there. if my last bite was somewhere here, camera piche karo beta. My last bite was here, and there was a weight loss. The suture would have dropped down till here, and the
Yes.
defect would have been this much. Now, since I have anchored the bowel, the suturing to the bowel, it would not close up. It would not open. Chances are less. Like I said, I've had only 2 in more than 1,000 Roux-en-Ys that we've done. So, and generally now the data coming in, earlier it was 20%, then it dropped to 6. Now most of the studies are reporting, in fact, less than 1%. The latest one from 2020 onwards. So the mesenteric defect is closed. Again, I would come in the middle and just close the Peterson's defect. So one, identification of the Peterson's defect is extremely important. Most people are unable to identify the Peterson's defect, and that's why they don't close it. We would always close all our defects, irrespective if we are doing GI surgery or otherwise. We would always close all our defects as far as possible. So there's nothing here. We'll take out this gauze piece. We'll check for any kind of yeah, this looks good to me. Maybe once more we'll just put a gauze piece here and then take it out right at the end. There's a small, then you can clean the, then we'll show the audience the Peterson's defect. So the Peterson described this defect, German guy, described this defect, you know when? 1897 or maybe early 1905, something like this. It's much before 1910, and it's got 2 components. It's got a supracholic component and an infracholic component. So we do not close the supracholic component of the Peterson's defect, obviously because it's big and loose. There's no reported hernia with that. We only will close the infracholic component of the Peterson's defect. Supracholic is this. We are not closing this.
Yes.
What we are closing here is, so we'll need to, why it is difficult in this case is to identify the Peterson is going to be
probably
difficult.
it will be difficult.
Yeah, because of the fact, harmonic, because of the fact that this gentleman has got a incisional hernia, has got a umbilical hernia, and the omentum is stuck there. So to identify is not going to be very
So we
easy.
need to divide omentum to identify the transverse mesocolon.
Correct, correct. So that probably is the only way to do it. Let's see. I'll see how I can identify. I mean, as far as possible, I would like to close the Peterson's defect.
If it is not possible, then we can leave as such.
Yeah, I mean, if that's not possible, I mean, dividing the omentum completely, I don't want to cause ischemia of the omentum here.
Yes.
Because that is, yeah, it's going to be very difficult.
It would not be possible in that way.
Actually, in this Peterson defect, there is omentum.
Yeah,
so
till
bowel, hopefully bowel will not enter into this.
Yeah, so actually the thing is that this is where the Peterson's defect would be. So let's see. Give me a harmonic. Yeah, so this is our jugaad.
Sir, if
See, we can identify.
Sir, if we are opening up this omentum, then we are making another window.
No, there's no window here. Nothing will happen here. This is the transverse colon.
3 विंडो है, एक तो ये वाली विंडो, एक इसके पोस्टीरियर विंडो जो एक्चुअल पीटरसन है, एक ये विंडो क्लोज करने के लिए वो दूसरी विंडो बना है। हाँ, लेकिन अब 3 विंडो हो गई, एक हो गई बिटवीन द एलिमेंट्री लिंब एंड द ओमेंटम,
बाउल गैस पे देना।
एक विंडो हो गई बाउल और ओमेंटम के बीच में, इधर से हो गई।
हेलो, अंदर हेलो, हार्मोनिक। हेलो
हेलो
हेलो,
कौन से माइक पे बोल रहे हैं?
हेलो हेलो यार आवाज देखो ना आ रही है कि जा रही है क्या हो रहा है
Dr. Arvind?
Yes,
Hello.
sir. So what
Yes.
I did is, your suggestion was good. I clipped the splenic artery distally, little distally from the origin.
Okay.
The purpose is to block the blood flow to the spleen.
Okay.
Okay, so that when I decided that there is no backflow, I mean ooze, more of the ooze, so I clipped this splenic artery here, sir.
Okay.
Can you
Beyond
see this
that.
is the
Yes,
splenic
yes.
vein below?
We were just observing.
Yeah, this is the splenic vein below and this is the artery.
Okay.
So I've clipped it here. Now I take this this vein and I'd cut this pancreas. Come back, back. Give me the stapler for cutting the pancreas.
Choice of stapler?
I will take a blue stapler.
Routinely blue or specifically for this case?
Yes, sorry sir?
Routinely blue or specifically for this case?
No, routinely blue. But only thing is I have to wait, for at least, one should wait for at least 10 minutes before firing the stapler. 5 to 10 minutes.
Again, patience will require.
Yes, sir. Go. Idhar. Give me the artery. Oh, Maryland. Dekha. I don't know यार क्या है ये. I don't know क्या है ये. What is this structure? These are the veins going into the tumor, sir?
Something unusual.
Yes, sir?
Something unusual. What should it come? It is not... huh? Any branch going to the tumor feeding vessel?
Yes, sir. And this is very
possible.
big vein.
But it doesn't appear to be arising from the splenic, no.
It is
some
a tumor.
tissue is behind this.
This is all tumor, sir.
This is all tumor basically.
Yes.
It has gone. So right now, if you moment it divide, it will separate.
Yes,
around.
I am taking
Yes,
this
here
splenic
only.
vein. Yes, sir.
Yes, better take this.
Give me the clip, 10 mm.
Because the tumor only, which is appearing like this.
और दो. Clean camera. वो ट्यूमर की वजह से ना सक्शन पहले ये दो सक्शन राइट में दे सक्शन अंदर हार्मोनी को पहले ये काटूंगा नीचे वाली पीछे यार एक क्लिप वेट यार क्लिप बहुत सारे हैं
One more. एक और दो. Huh? Hello.
Yes, sir.
So we finished. I'll just show you.
Sir, this bleeding is because.
No, this is just a little oozing from the staple line.
Okay.
So just the staple, nothing else. So the staple
You
line.
ask anesthetist to increase the BP or it's by itself?
No, the BP is about 140/90, so it's fine. I don't. This is just a little oozing from the staple line. Otherwise, you can see a small pouch. Just
Okay.
required 2.5 cartridges, and this is the gastro-J. That's the jejuno-jejunosmy. That's the mesenteric defect which has been closed completely. I'll show you the Peterson's defect. Actually, the Peterson's defect is completely obliterated
in this
by
case.
the omentum.
Yes.
So just give me the bowel grasp. I'll show you where the Peterson's defect is. So this is the mesentery of the elementary limb. This is the transverse mesocolon right there. And this omentum is completely occupying this defect.
Yes.
See?
Yes, yes.
This is the Peterson's defect. Now I
Yes.
can't take this omentum out. That's the transverse, that is the transverse colon.
Transverse colon.
Yeah, so with completely obliterating it, there's no way that you can take even one suture.
Yes.
So we'll
Sir,
just
yes.
leave it as such.
Sir, can we suture omentum with the mesentery of elementary limb?
Yeah, we can do that. How would it benefit us?
Sir, if the patient has weight loss and if this defect becomes significantly big.
Okay. So you suggest we suture this to this. That's
yes,
it.
Sir, yes.
Okay. I take your idea. We'll
This
take
will
a
be a
figure
risky
of 8.
affair.
Why not? Why not? Okay. Yeah.
This is the defect anyways.
Yeah. Sure. No, I'm done. We'll just take a figure of 8 and suture it. At least from our side, we've completed our job. Yeah. So that's the last bit of the surgery. Thank you very much, and thank you for your patience. And again, I would like to thank the organizers, Vinod, then the whole team of Holy Heart, Dinesh in particular, very responsible for getting us here, motivating us. Motivation in any case was there because it was Rohtak, my alma mater, so I had to come. And thank you all for chairing the session. And I would also like to thank the OT staff here. They've been fantastic. The anesthesia team, my own team, which came with me, Dr. Naveen and Dr. Shamshur. So thank you all.
Thank you, sir.
Thank
you
you,
have
sir.
demonstrated surgery very well.
Thank you.
Thank you,
Now it-
Lavan. I
now
am
it
very
appears
happy that
easy.
you all people progress so much. It was not part of training which you get under me, but you progress and learn a lot of things and establish as a very excellent laparoscopic surgeon.
Thank you so much, sir. Thank you for your best wishes and always, sir. Thank you so much.
Then big round of applause for you.
Thank you. Thank you.
Can we shift audio visual to Dr. Arvind?
Yes, sir.
Where are you digging out?
I have taken the splenic vein, sir.
Okay.
And this is the adrenal gland.
Padawan sir? 40 second. Can you correct me to the OT second? 42 please.
OT2 है सर.
पदावन सर से बात हो सकती है?
Okay sir.
Yeah, Dinesh.
Yes sir, thank you very much.
Thank you very much, Dinesh. Thank you for the invitation and thank you.
And thank you for showering the blessings, sir.
Thank you.
And the weather has changed according to you, sir. And we are waiting for you in the auditorium.
Thank you.
So please come for just for 1 minute.
All right.
We
all
would
right.
like to see you here.
Thank you so much.
Thank you, sir.
We'll
Thank
join
you.
you soon.
Thank you, sir.
Close it, please. This switch, cut it, please.
Dr. Arvind?
Yes, sir.
So these are the I think lymphoid tissue. No?
Yes,
Don't
sir.
you think so? In
Sir, I have taken this
continuity-
tumor. This is the tumor only, sir.
Upper.
Yes, sir. So I am taking this all lymphatic tissue also. No, sir.
Yeah, yeah. Why not go close to this thing, vein only now?
Yes,
you
sir.
can go here like this. Because it is going behind this thing, no? Then
Go near. This is the vein, sir. That
Yeah?
one. This one is the vein,
Mhm.
and I will clip that.
Some branch, yes.
Yes, sir. I can take this tissue. Come back, come back. Clean the camera. Clean the camera and give me the clip.
Dr. Arvind?
Ji? Yes, sir.
Technically, it's distal pancreatectomy or subtotal pancreatectomy?
This is, you can say subtotal pancreatectomy, but I mean there is no such term basically. So this is also, this will be called, unless until you are taking head out, it will be called as distal pancreatectomy only.
Okay.
So these are the
Subtotal,
veins,
I
sir.
think,
Ji, sir?
Subtotal, I think word used is when we are leaving only a rim of this thing.
Okay.
And taking out that. But it is a.
Maryland, please.
We are keeping significant part. Because head and uncinate is still there. So it will be distal, not the subtotal.
These are
So
two
this
veins
means
here,
the
sir.
Additional feeding vein.
Yes,
like
sir.
Dr.
These are
Godara
two
was
veins.
telling.
Two veins, sir.
The new vascularization probably.
10 mm clip. Clip. दो एक और दो क्लिप लोहे वाली दे दो मेटल क्लिप अरे देख ला गिव मी सीजर और हार्मोनिक सीजर दो फास्ट डाल के देना भाई मेरे मैरीलैंड देखो
Dr. Arvind?
Yes, sir.
Now probably it's the splenic artery remaining.
Yes, sir. Give me the clip, please. Hemolock, big size. One more. Clip. है ना हिमोलॉग की क्लिप जल्दी और मेरे को स्टेपलर दे दो अभी हाँ ब्लू ले एक सेकेंड लेट मी फायर दिस फर्स्ट विल टेक केयर देन
Dividing the pancreas?
Yes, sir. Because that vein will, I'll take a vein later. अंदर आना एक मिनट अंदर आ छोड़ना तू तो इधर है पकड़ पीछे थोड़ा सा दिखा किधर पीछे हाँ
yes it's through
sure पीछे
is that it is coming in between
through. Yes sir
no
I am way beyond the tumor
yeah please remove the tape before firing thanks
Sir, is this the right position? Hello? Karwasa, sir?
Yes.
Sir, margin is adequate,
I think
sir?
margin adequate. Adequate margin, yes.
So, I am taking the hair, sir?
Yes.
So, I will wait for at least 5 minutes. Please घड़ी से देके 5 मिनट बताओ.
Before firing, you will wait.
Yes, sir. Because वो tissue will be devoid of edema and then will fire.
उसका पैनक्रियाज का सारा जूस बाहर निकाल देना उसके बाद.
Yes, sir.
Okay, that's the point.
Sir, I think we are margins वगैरह all clear.
Margins clear. Yeah, I think. Yes.
Anterior, this is proper and RAMPS.
It is a malignant. It is
Yes.
a malignancy, not benign. But you have done a good job, I think.
Thank you,
and
sir.
It is very. It was one of the very difficult case.
Yes, sir. दो मिनट हो गए.
What I feel, Arvind, you
Yes, sir.
have a technique to dissect out all small vessels.
Yes, sir.
That's how all these things, complicated case, you could have, like yesterday also.
सर आप बैठे थे ना सर उधर इसलिए हो गया सर. मुझे मालूम था कुछ भी होएगा तो somebody is there to help me and take over the case.
Yes, that is the sometimes. तो 10 मिनट वेट करना बहुत लंबा है.
सर 5 मिनट बस सर. सर और 2 मिनट रह गए सर बस.
नहीं मैं वैसे ही मजाक कर रहा हूँ.
जी जी.
But and you till that you cannot do any other job.
No
also?
sir, I cannot do anything else, sir.
So you are yesterday you gone back or you stayed?
No sir, I went back sir because गंगाराम का मेरे डिपार्टमेंट का सर एक कॉन्फ्रेंस था ब्रेस्ट कैंसर का.
Okay.
तो देन वो शाम को गेट टुगेदर था तो उसमें सर वो एक इनॉग्रल फंक्शन में जाना ही था सर मेरे को.
Okay.
So I came in the
so
morning.
after the surgery you are coming here or going straight from the hospital?
Sorry sir?
Now after the surgery.
Sir, I am going back to Delhi and at 3:30 I am going to Dehradun sir in the night.
Morning?
3:30 in the morning sir.
Okay. So some other day.
Yes sir.
We'll have get together.
Sure sir, sure sir.
Okay.
Sir, I am firing it, sir.
Pardon?
Okay. I am firing the stapler.
Yeah, fire.
Yes, okay. Abhi, there are some things we are always learning. Like this thing, you have to wait and compress it. In open, we are not doing this thing, and that leads to some problem also when we closing the end.
Yes, sir.
And probably if this is the same thing we can do there also.
Sir, in one study, there was written that you should wait for 20 minutes, sir.
Yeah, so it means there is some logic in compressing.
Yes, sir. The chance of fistula formation,
yes.
Is less.
Less.
Scissor. और नहीं चाहिए क्लिप. अभी और कोई क्लिप नहीं चाहिए. Section, please.
क्या चीज़ है? ठंडी करके लाया उसका.
ठंडी है. ठंडी? चेंज कर लो, गरम है मेरे पास तो.
यार हार्मोनिक देना.
मेरे पास तो गरम है सर, तो चेंज कर लो. कुछ ठंडी होंगी, कुछ गरम होगी इसके पास. मिक्स एंड मैच. प्लेन दिखते नहीं इस तरह, कभी नहीं दिखते, रेकॉर्ड में नहीं दिखते ये प्लेन इस तरह।
30 डिग्री एक तो एंगल स्कोप है, प्लस मैग्नीफाइड विजन,
लिमिटेशन है ना, लिमिटेशन
ऐसे ऐसे पेशेंट को अब हमें डेमोस्ट्रेट करना है ये है, लेकिन अदरवाइज
Suction.
ओपन करके ये जो टिश्यू छोड़ते हैं ना, ये नहीं तो फिर बिल्कुल उसको
रेडिकल
माफ हो जाता है।
That is a splenic artery here. Bipolar. Bipolar.
तो कहाँ है अदर वहाँ से? Where are you?
मैं गुड़गांव में हूँ सर।
Pedal bipolar का?
डॉक्टर विक्रम के साथ।
अच्छा विक्रम में आया था, तो विक्रम के साथ कब से ज्वाइन किया था? नहीं ज्वाइन किया?
नहीं, मैं शुरू से उनके साथ
आदमी नहीं था।
बीच में मैं FN भी करने चला गया था, बीच में FN भी करने चला गया था।
अच्छा
हाँ, बाकी साथ में
विक्रम नहीं आया। विक्रम क्या करता है? उसकी मैनेजमेंट डाल दो।
नहीं वो
Give him a look.
करते ही हैं, OT तो करते ही हैं जरा भी, धीरे धीरे छूटे भी, ऐसे हार्डकोर सर्जन की OT ऐसे थोड़ी छूट जाती है।
Here is the
बहुत ही difficult case था। देखो ये ऑपरेशन करना है, का पेशेंस और आदमी
clip दे जल्दी.
तीनों
10,
केसेस
10,
को ऐसे
10.
मिले।
हाँ जी सर।
हैं? तीन केस
कल भी वो अबेंडन हो गया, रेडिकल हिस्टेरेक्टमी।
लेकिन ये एक वेरी वर्सटाइल सर्जन। इसके इसको वर्क होना है इसको। ये बात सही है, हमने बेटर इसने अबेंडन नहीं
हाँ.
किया था।
लिखे शो इधर.
हम लगे रहे करते रहे।
Grace पर दे.
नहीं तो ये वेन देख के कहता थोड़ा सा बस।
ला बे. हाँ. हो गया? हाँ तो जा. Going या अभी रुक रहा है? जाएगा. अंदर आ.
की आदत ऐसी हो जाती है कि
अच्छा.
लेप्रोस्कोपी
कोई बात.
में ज़्यादा इजी लगता है।
Thank you.
हैबिट्स ऐसी हो जाती है।
नहीं जैसे मेरे साथ क्या होता था, ये लेप्रोस्कोपी करने से वो आधे टाइम भी चला यहाँ, ये आज भी नहीं आज एक बार वैसे दूसरा इतना पैसा नहीं, फिर हमने बंद नहीं कर दिया, ऐसे नहीं कर सकते।
नहीं जैसे आपके
पहले हमने
साथ
शुरू की संजू हमने ये सारे काम पहले लैब से करेंगे, और इतना टाइम और इतना दिमाग खराब होता है बंद हो गया।
जैसे आपके साथ हमेशा मैंने वर्दाइम्स वो ओपन किए, आज के दिन में लेफ्ट वर्दाइम्स करता हूँ सबका, सी सर्विक्स का सेलेक्टिव केस हो या सी एंडोमेट्रियल हो तो लेफ्ट वर्दाइम्स करता हूँ, और उसमें एक अलग ही वो है, सब सामने दिख रहा होता है कि सारा ये टनल है,
एक स्ट्रक्चर दिख जाता है कि अलग अलग क्लिप हो जाता है।
आइडेंटिफाई होती है। अब तो ये लगता है कि ओपन के वजह से लेफ्ट वर्दाइम्स तो ही अच्छा है। ये बड़े सेलेक्टिव केस चाहिए होते हैं, खासकर सर्विक्स के लिए।
What is this tissue?
Sir,
Arvind, I think lymphoid.
This yes, sir.
Oh,
And
lymphoid tissue.
artery also nearby, sir. Suction, please.
This is the artery.
Yes, sir. This one is the artery. Suction.
Now last bit of patience will require.
Yes, sir. Maryland, please. Fast. Harmonic. Suction. Melent. Fast. पहले हार्मोनिक दो. Now, sir. Now I can apply clip.
Yes.
Give me
This
the
is the
clip.
artery.
Yes,
Distally
sir.
you are already clamped.
Yes, sir. Distally I have already clamped. La. La. एक और. Yeah, harmonic. ओए गिरा, ए गिर गया. सक्शन प्लीज दूसरा गिर दे दीजिए, जल्दी से लेके आइए.
यहाँ तो ये ठीक है, तुम नीचे भी ले जा. उधर दे.
बाहर दे दो, उधर ही दे दो.
कैमरा क्लीन करो, कैमरा क्लीन. हाँ डिन डाला है, मोटा मोटा मोटा. चल 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 चल. Sir, 99% of the surgery I did on from the patient left side only, sir.
99?
99% of the procedure I did from the left side of the patient, sir.
Okay. Now you were on the left side.
Yes, sir.
Sir, any particular reason?
No, I find this is more comfortable for me. Even esophagus I am doing from left side only, sir.
Okay.
Stomach mobilization. Even nowadays I started doing fundoplication also by standing on the left side of the patient only.
You are not comfortable in between legs.
Sir, I do, I am practicing ipsilateral with ipsilateral ports. So if I stand between the legs, sir, it will be a contralateral ports.
Yes.
Suction, please. Yeah.
Going very near to stomach.
Yes, sir. Of the spleen nile nahi sir humne. And I have to take these short gastrics.
This technique of hanging the stomach is really good, and it
Yes,
has
sir.
made your life very comfortable.
Yes, sir. Yes, absolutely, sir. Oh, sorry. Andhra. कोई रेजिडेंट नहीं है, वो कर देगा ना, हम चले जाएंगे ना, वो कर देगा ये। विनोद को पूछो ना, कोई आ जाएगा कि स्पेसिमेन निकालने के लिए ना, हम
The last bit.
जी सर, बस that's it.
You will
And
place
maybe-
drain?
Yes sir, maybe little attachment of the spleen is there still.
Yes.
Suction please. पूछना कोई आ जाएगा जूनियर। अरे ये क्या है इतना हार्ड सेक्शन? अरे इससे नहीं, दूसरा दे यार, यार कुछ दूसरा देना, ये नहीं ये दे यार। दे दे। ये लेना पड़ेगा हमें।
What's the plan of specimen removal?
Sir, I think this is a young girl. We can take the specimen from the fenestril, sir.
Yes. You will take in bag?
In the bag, sir. अंदर 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 पकड़ो पकड़ो।
Financial incision used for the specimen removal doesn't have so much pain.
Yes,
and
sir.
patient is very comfortable on that part.
स्ट्रेचिंग नहीं होती ना, एक बार आपने खुला स्पेसिमेन निकाला और सील दिया, बस जो खींचा काम है वो नहीं है, तो वो पेन नहीं करता। ऊपर तो रेस्पिरेशन मूव करेगा, नीचे वो भी मूव नहीं करता, इसलिए अगले दिन पेशेंट घूम रहा होता है आराम से। कॉस्मेटिकली बेटर, हाँ ऑब्वियसली बिटवीन लाइन में आता है। इसीलिए अगर हेमिकोलेक्टमी में इंट्राकॉर्पोरल एनास्टोसिस करना हो तो स्पेसिमेनेक्टमी फिनेंशियल से तो रीजन अगर पेट ऐसे कर पेट हो भी ना पता लगे कि नहीं सॉलिड भी हो रहा है ऑर्गन्स तो सब फिनेंशियल से भी होता है 99% अनलेस की स्टोमा बनाना है या इंस्यूम करना है।
क्लिप है, क्लिप क्लिप क्लिप, हाँ हाँ नहीं, इसमें चिपका हुआ था ना इसलिए करना पड़ा। हाँ 8 इकट्ठी तो कर सकते हो.
Now it's the last bit.
Yes. Finally, hard work pays.
Yes.
At one given point, I thought that we have to convert it.
No, but it was your patience.
नहीं सर, मेरा तो करवासरा सर का कॉन्फिडेंस था, सही बताऊं सर, honestly, कि somebody is there to really, I mean, in case of any adversities.
Yeah, thank you.
Once you have backup, then laparoscopy surgery becomes slightly comfortable.
Yeah, one confident, yes. I think big loud now.
Clean camera. Thank you, sir. Thank you very much.
Ultimately, you're going to succeed to do this, complete this case.
Sir, I will put a suture also with on the stump of the pancreas, sir.
Okay. Which suture?
Sir, maybe 30 vlog if it is available. Else PDS.
Okay. Non-absorbable, obviously.
vlog 30 दे दो. हाँ, 15 ही चाहिए. अब मुझे irrigation चाहिए होगा. हाँ. बाइबल चाहिए अंदर 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 bipolar. Sir, or this bipolar I find very well, sir. This is the Olympus bipolar.
Okay.
This is very good bipolar, sir. In the Maryland.
You are dissecting with it and then doing
dissection and fine bipolar when you want to do around the vessels. It find very good, sir. And it never वो कभी धोखा नहीं देता सर कि चल रहा है कि नहीं चल रहा है. It always runs.
Once you are well versed with the instrument, then you play with it.
Yes, sir. Sir, I think it's a dry, no bleeding, nothing.
Yes. Yes. There is no doubt.
Sure.
Okay, Dr. Arvind, thank you so much. It was
Give me the bag.
Dr.
Yes, sir.
Dr. Arvind, can you listen to me? Okay.
Dr. Godara here.
Yes, sir.
Am I audible?
Yes, sir. Yes, sir. Please.
Yeah, this was a beautiful demonstration of 3 cases by you. All 3 were very difficult, but the way you managed it seems that rather than you follow the tissue planes, it appears that tissue is following your order to make the plane accordingly.
Thank you very much.
In last
Funny,
2
funny.
days we have seen beautiful surgeries, and of course these 3 cases were very difficult ones.
Sir, all 3 were difficult.
But you
मेरा
managed.
एग्जाम करवासरा सर के सामने मेरा एग्जाम हो गया मेरा सर.
सर डॉक्टर कड़वासरा बैठे हैं, एग्जाम तो हो गई.
हाँ वही तो एग्जाम हो गया मेरा सर.
So this was the exam of a big and excellent teacher.
It was a master course for you.
सर करवासरा सर एक रिक्वेस्ट है सर.
हाँ.
सर पंतांबे के सर को फोन करके बता देना सर कि उनका चेले ने. हाँ.
Sure.
पानी.
Okay, Dr. Arvind, thank you so much.
Thank you very much, sir. Thank you very much.
I thanks all the moderators for sparing time and to stay with us for so long. Otherwise, at the end of conference, up to this time, nobody is going to stay. So this was a beautiful conference, well organized by a team of Dr. Vinod. And I thank all the delegates who are still there with us in the auditorium. And I thank all the persons, audiovisual persons, as well as the company persons who are with us for so long and for
From where this
nicely with us.
From where this audiovisual team is?
They are sitting
Dr. Bhatia has arranged it.
Yeah. They are sitting there. Sir.
They are sitting.
Yeah.
People are from Delhi. Okay, good job.
Yeah,
It was excellent.
Job you have done in
yes.
last 2 days.
There is no doubt.
Even not a single minute we had any type of disturbance.
Very good resolution.
It's
and
the
very
best transmission I have ever seen.
Very good coordination.
Thanks to you people, and we are very much thankful to you for sparing time and coming from a distant place, and so much thank you to you. And thanks everybody for making this show in a small city, not so big in this city, very small city, but the show was so magnanimous. We are very much happy with you.
Now it's going to be a medical hub, sir.
Yeah, with the time, I think this is one of the biggest boost to all of us in Rohtak.
Yeah.
That next time we'll be coming with something better than this.
Yes.
Obviously. Thank you so much, and thanks.
Thank you. Thank you.
This time also it was very good.
And much thanks to Dr. Dinesh, who organized everything so nicely. Thank you so much, Dr. Dinesh.
Long back, हमारे पास फोन आया था रोहतक में, conducted in 2007, right?
We are already attached with the many organizations like Netcon, LabCon, AIUS, AIUC, DOS.
Good transmission and there are so many coordination also. कितने सालों से आप इस काम में?
Company को around 20 years हो गए. फरीदाबाद का भी हुआ रिसेंटली, वो भी हमने ही कराया.
मतलब फिर एक्सेल हो जाएगा. Then you understand and then you understand what doctors are,
what exactly their requirements are.
What is their requirement. That is the important.
सर आप भी आ जाइए सर.
आ जाओ जल्दी आओ, आपका फोटो यहीं से आ जाओ
सर ये चेयर खाली है भाई.
आप आ जाओ.
सर यहाँ आ जाइए ना. यहाँ आ जाओ.
आइए.
उनमें से किसी को दे दो फोन यार.
दिनेश
सर आ जाइए आप आ जाओ.
Thank you so much.
And at the end, this is not the end, this is just a new beginning. Okay? So we are leaving with a motto of a new beginning. We will meet soon. Thank you very much.